I saw that. Good afternoon. Good afternoon, Senate Finance and guests. Today is Wednesday, February 15th, 2023. We have 9 bills for consideration today, and colleagues, as you know, we have 105 witnesses signed up, a combination of in-person and virtual witnesses. We're going to consider those 9 bills in the following order. Senate Bills 397, 410, 356, 365, 496, 307, 308, 281, and 398. We're going to begin with Senate Bill 397, Senator Gallion, health insurance, hearing aids for adults coverage. And if you have any witnesses that you want to call forward, you should feel free. Good afternoon, Senator. And let me just say while they're gathering to our guest, if you see members not present or in and out during the hearing, many of them have presentations of bills in other committees, so they'll join us when they can. And if you see people leaving, it's not a reflection of the bill that's before us. Thank you very much. Senator Gallion, you can proceed.
Thank you. Good afternoon, Chair Griffith and Vice Chair Klossmeyer and committee members. It's an honor to be here. For the record, Senator Jason Gallion here to introduce Senate Bill 397, Health Insurance, Hearing Aids for Adults Coverage. This bill simply expands the limit for adults to be in line with the benefit limit provided to minors. SB 397 will help adults with hearing loss overcome the economic obstacles that often leave individuals untreated and without hearing aids. Currently, minors in the state of Maryland are eligible for a max benefit payable limit to $1,400 per hearing aid for each hearing impaired ear every 36 months. In light of the FDA's recent approval of over-the-counter hearing aids, I've had some conversations regarding putting forward an amendment to clarify that this bill applies to over-the-counter hearing aids as well. That suggestion is also put forth by the Attorney General's Consumer Protection Division in their informational support letter that you'll find in your written testimony. I'm happy to work with the committee and other interested parties to make sure that we get this bill in the right posture. And I respectfully ask the committee for a favorable report to assist our hearing impaired adults gain greater access to hearing aids.
Good afternoon, ladies and gentlemen of the Senate Finance Committee, and thank you for the opportunity to speak in favor of Senate Bill 397. My name is Jane Bellmeyer, and I am among the more than 1.2 million Marylanders who are deaf or hearing impaired. I've been wearing hearing aids since 1979. The set I am wearing today cost me $4,000. That's just for the aids themselves. The ear molds were another $350, money I had to pay myself. Batteries to operate the aids cost $18 for a pack of 24 at Walgreens. The good news is both the Internal Revenue Service and Maryland Comptroller's Office view hearing aids and batteries as medical devices and as such are non-taxable. As you can see, I also wear glasses. My health insurance covers eyeglasses. My out-of-pocket cost there was less than $200. I fail to understand how it is that hearing aids are not included in health insurance coverage in Maryland, except for children under 19 or those on the Maryland Health Benefit Exchange. It's not just a financial issue, it's a health issue. It's a mental health issue, it's an emotional issue. It's also an issue of freedom and self-sufficiency. My hearing loss is 85%. That means without my aids, I only hear about 15% of the sound in the room. I can hear high pitches better than low pitches, and even with the amplification. Can you imagine what I would be like without my hearing aids? Conversations, phone calls, a knock at the door, a child crying, a car approaching as I cross the street. Without my hearing aids, I can't work. This means I'd be unable to support myself, pay taxes, volunteer in my community. I'd become dependent on social services, food stamps, energy assistance, and housing assistance. The American Academy of Audiologists spells out the risks of untreated hearing loss. Hearing loss can make it more difficult to interact with peers, can lead to decreased social engagement, depression, and bad moods. I'm asking you to please consider supporting Senate Bill 397. Thank you.
Thank you. Are there any questions for the sponsor? I see Senator Hershey.
Thank you very much, Madam Chair. And you saw how eloquent that testimony was that she just provided. I want to thank Jane also for her many years of being a reporter for the Cecil Whig and everything that she's done in getting the news out to residents of Cecil County. So thank you, and I'm very supportive of this piece of legislation.
Thank you, Senator. Any additional questions? Seeing none, that concludes the testimony on Senate Bill 397.
Thank you.
Thank you.
Thank you.
Colleagues will now turn to Senate Bill 410. Senator Watson, Public Health Childbirth Paternity Test. Good afternoon, Senator Watson.
Good afternoon, Madam Chair and members of the committee. For the record, Senator Ron Watson from the 23rd Legislative District, and I'm pleased to present Senate Bill 410, a very simple and common sense bill in which the goal is to simply establish paternity and strengthen families. Fatherhood is a vital component in raising our children. This bill has 3 provisions. When a child is born in a healthcare facility, the physician shall offer the presumed father a paternity test. There is no difference with this than a person being read their Miranda rights. The offer will be made orally and in writing, and the presumed father may waive the right. Now, I reached out to many folks, one women's group, and when I described the bill, her response was, I didn't know that was a thing. I contend that if we had more meaningful conversations with fathers, you would realize that this is indeed a thing. I've spoken to over 100 folks who are in full support of this bill, 1/3 of which are women. The stories vary from a gentleman who was informed via mail that his child was about to be put up for adoption. The gentleman didn't even know the woman he saw was pregnant. Ultimately, he wound up adopting the child. Several of the other respondents suggested that this be made mandatory. I did not go that route in this bill, which is why it is optional. This takes into account married couples. The role of the men has been systemically reduced in the family. And if you, like I have, spoken to those recently released from prison, the overwhelming majority will tell you there was a direct correlation with the relationship of the father and the outcomes of that individual. Now, for those who stand opposed, fathers already have that right. Well, the birth of a child can be both exciting and traumatic. For younger couples, it can also be very intimidating. Again, this is simply a notification of rights. Who will pay for it? The presumed father would be responsible for the cost if he chooses to take the test. There is no cost to the state for this bill. It can take 2 to 5 days. My answer is, so what? If this is what it takes to ensure parentage before the birth certificate is filed, then that is the responsible thing our state should do. And lastly, some misogynistic viewpoint that women regularly lie about who the father is. I found this an interesting statement in some of the opposition. And it goes on to say this is statistically untrue. So by definition, we know that this indeed does happen. Now, I did bring, and I won't read these, but I'll leave it for the committee's consideration, 2 studies. One is a national sample of U.S. paternity tests related to demographics. And I will just tell you that on an annual basis, 1.5 million paternity tests taken, 688,000 were established through voluntary in-hospital acknowledgement programs. The state of Maryland, Mid-Atlantic region, was included in this study. And the results state that it's been suggested that the legal determination of paternity may alter interactions between a father and the child, and that the impact of paternity may vary by the method by which paternity is established. For instance, children from whom paternity has been established by any means are much more likely to receive child support and to have contact with their non-residential fathers than their counterparts for whom paternity is uncertain. I will also point out in this study, 92% of the cases reviewed related to African-American families. The last one I'll leave you with is called In-Hospital Paternity Establishment and Father Involvement in Fragile Families. The results were the same. And again, I'll leave this for the committee to look at. Now, if you enjoy having our families exploited on Ricky Lake, Jerry Springer, and the Maury Povich shows, if you enjoy seeing paternity of a child established on national television, multiple fathers being introduced, or the mother not knowing who the father is, then vote against this bill. But if you really care about what's in the best interest of the child and can imagine the horrific stigma of having a child's first introduction to his father highlighted on national television in some circus-like atmosphere, then you will support this bill. I call your attention to the fact that all of the shows in which I mentioned, they prey on the least of us. And I'm talking about poor Black families. And if you remember all those shows, there are some races who you never saw them there. And finally, I'll tell you a final story. A young man in graduate school who was notified that he was a father. This young man accepted this responsibility and paid child support for 10 years. And during that course of time, he was threatened to be taken to court, told to drop out of college. Unfortunately, the child was diagnosed with lupus, which neither ran in the father nor the mother's family. The father ordered an in-home paternity test, and the results were that there was zero probability that the child was his. Upon presenting the results to the mother, her response was, "I just wanted my child raised in a good family." As you can imagine, this was a traumatic experience for everyone involved. If the father were taken to court, we know that the court would have ruled what was in the best interest of the child. This story did have a happy ending, though. The young man finished college. The young man went on, receives his doctorate degree, and that man sits before you as a Maryland State Senator. This is my story. I know what I'm talking about. And there are many, many other men who have gone through similar circumstances. Colleagues, again, I believe that many of the issues we face in our state can be mitigated by strengthening our families, and particularly our Black families. I urge your favorable support.
Thank you very much. Are there any questions for the sponsor? Okay, seeing none, thank you very much.
Thank you, Madam Chair.
We do have one witness signed up on this bill. Lori Ruth. Good afternoon.
Good afternoon. I'm signed up in opposition. I just wanted to make sure that you understood that. Good afternoon, Madam Chair, Mr. Vice Chair, members of the committee. My name is Lori Ruth. I'm the legal director at the Women's Law Center of Maryland. I'm actually here on behalf of the MSBA's Family and Juvenile Section Law Council today. They didn't have another private attorney available, so I am on the section council and I'm testifying on their behalf. The section has approximately 1,000 members. I didn't look up the exact amount, but it does represent the MSBA members who are family law practitioners. We're not often here in finance, but you'll frequently find the section council in JPR and across the street in judiciary on family law bills. We do oppose Senate Bill 410 and urge an unfavorable report. As you can see in the written testimony, this is not a simple issue, despite what the sponsor says. The bill itself reads like it's simple, but if you look at our written testimony from both organizations, there are all of these other laws that are implicated by this. And so you'd really have to take a deeper dive before you just upended all of the paternity laws that exist in Maryland. I will admit paternity is complicated. And it comes up in the Estates and Trust article, as well as the family law article. The Child Support Office has a piece of paternity in strange ways that don't make a lot of sense. But it's a little bit of a mess. And I don't think that this bill layered on top of that is going to make any sense at all. Just, one thing to raise is the presumption in Maryland law, and I suspect before the statute and common law, there's a presumption that a child born of a marriage is either conceived or born during a marriage is the child of that husband, that spouse. Now we have same-sex marriage. We have two mothers, two fathers. There's no knowing what all of this might upend. In addition, I briefly looked at how long it takes to get the results of a DNA test. I admit it was Google that told me this information, but it said in hospital facilities that have the test, it's 2 to 5 days at a minimum. But most women, unless there's a health problem, leave the hospital before that 2 to 5 days would have gone by. And so we don't know what would happen. They leave the hospital without the forms being filled out. There's a statute that tells the hospitals their timing of when to do that. So for all of these reasons, we urge an unfavorable report.
Thank you. Senator Reedy.
Thank you, Madam Chair. Just very quickly, Ms. Ruth, and good to see you. Used to see you a lot in another committee. I understand the points. I was reading your testimony on the Bar Association side about some of the complexities you mentioned with the law, and I understand this bill may not be as written, may not be the perfect vehicle to resolve this issue, but putting aside the marriage presumption, couldn't there be a way in law for us to ensure that when it's not a marriage, that at least we could get this? Because there are the sponsor spoke very clearly about a lot of controversies that happen. And he's right to point out how things get exploited in media unfairly. And there's frankly, a stereotype about some fathers in some communities. And I know it's very hurtful to people in that community. So, and a lot of people I talk to point to this as an issue of paternity. Would there be a way to make a bill much more narrowly crafted to deal with the specific issue of frankly, an unwed mother having a child and there being paternity issues?
Well, I would not feel very comfortable telling you yes or no, because I don't really know how hospitals work. I will say this bill only sells healthcare facilities. Many people give birth in birthing centers. They have home births. They have midwives, not an attending physician. So there would be no attending physician. Maybe, I don't actually know. I had a doctor help me with all of my children's, but maybe there's one down the hall when you have a midwife actually. So there are pieces of it that I couldn't tell you how to do it. I will tell you quite frankly that during the discussion at the family law section, there was a lawyer there who had practiced in another jurisdiction. And I can't remember where. I think she might have said District of Columbia, to be honest with you. I don't want to say for sure, but she said, this does happen in other states. And our response was, well, that's great, but this bill doesn't account for what Maryland's existing laws are. Okay. So there may be a way. I abhor Maury Povich and Jerry Springer. Those shows are revolting. And I actually am sympathetic to the idea that in certain circumstances, somebody wants to know for sure before they sign an affidavit of parentage. Although there are mechanisms in our law to undo that if it's done by mistake, if a father signs an affidavit of parentage. So there may be a way, but this bill is not it.
And just a final closing question, Madam Chair, if it's okay. I mean, from your Women's Law Center, Pat, with that hat on, yeah. I know this issue of fatherhood, presumption of, best interest of child versus 50-50 presumption, those are all JPR related issues. But from the Women's Law Center side of things and advocate for women and women's rights, it's not good, the setup we have right now. Isn't it generally better for women to have the paternity established and clear, even if the father is less than the ideal person to be involved in a relationship with? And I know there's certainly extenuating circumstances at times where it might be dangerous, but putting those aside, wouldn't it be better for us to find a solution for some of these unresolved questions? I mean, from your perspective, dealing and trying to support and help women.
I guess I would say that I approach things like this believing women, and I don't think that there's some epidemic of women not being truthful about who the father of their child is.
I don't think it's truthfulness, but a lot of times there's confusion, or there's they can't find. I mean, there's a lot. So there are some times where there's not truth, but a lot of times it's a confusion, or it's not certainty, or
right. But again, this bill is not going to solve a wide variety of those problems. We have clients who choose not to have the father present at the delivery because of domestic violence. And therefore, this attending physician who's supposed to offer this it says right in the bill, if they can't find the father, well, that attending physician can't go around telephoning, who they think is the father and offering it. So it's not going to answer those types of questions. There are certainly other times when the putative father is not in the delivery room. So again, it's a bill that doesn't, to me, answer the valid point that you make and that the sponsor makes, that yes, there are times when it would be better to know at the outset. But I think in, whatever percentage, high percentage of times, it's known at the outset. So we're talking about a small number, relatively speaking, of births where there's some question about who the actual father is. I also think that there's a privacy issue here, especially with married couples. You know, it's amazing to me how many people make private decisions about who is going to step up and be the father. And I don't know
Yeah.
how this would upend that type of thing within people's own private lives. So I don't think this bill solves what you're talking about.
Thank you for your answers.
Thank
Madam
you.
Chair.
Thank you. I don't see any additional questions from the committee, so thank you very much for your testimony.
Thank you.
Colleagues, that concludes the hearing on Senate Bill 410. We'll now turn to Senate Bill 356. Senator Beidle, Transportation Citizens Committee for the Enhancement of Communities Surrounding BWI Thurgood Marshall Airport Modification. Good afternoon.
Good afternoon, Madam Chair, Madam Vice Chair, members of the committee. Thank you for hearing Senate Bill 356. We already have a fund at the airport that's based on $1 per flight. It's not $1 per passenger, it's $1 per flight. And that money is used only for transportation issues, like we can get sidewalks put in or a sign that here's this neighborhood or speed humps, but it's only transportation issues. And you've heard enough recently to know that the noise from the airport, the whole second gen issue has just created a great deal of angst for the community. And so what this bill does is increases the funding from $1 a flight to $2 a flight, but expands the way the money can be used. And so, you know, we have a local development council in Baltimore City. You have Horseshoe. We have a racetrack fund where people that have an impact from the casino or the racetrack can use this money to help in their community. And so my goal with this bill is by increasing it to $2 a flight, there'll be more money available to do more than just transportation projects, particularly for our nonprofits in the area that help our communities. Could be for sound in homes or for just other things that help with the impact from the airport. And so I'm just asking that we increase this fund from $1 to $2. I did notice in the fiscal note, they think they need a whole nother person to manage this. It's already being managed without an additional person. So I'm not sure why we need a whole person, an additional person just to fund this, but I think we can work that out a different way. But I really very much like to have your favorable support for this bill so it can help our surrounding communities that are in the noise zone.
Thank you. Any questions for the sponsor? Okay, seeing none,
Thank you.
Oh, Senator Ellis has a question.
Thank you. Thank you, Madam Chair, and Senator Beidle, thank you for this bill. And I'm trying to search through the fiscal note. I didn't see a quick answer. How much additional money will this raise? And what are some of the intended uses you think that can help the constituents dealing with that issue in their community?
I think it'll raise about another $300,000 a year. There is money there now, you know, left from prior years that wasn't all used. But I think it can really help with some of our nonprofits that are really struggling to help communities. We have one nonprofit in Linthicum that helps to rehouse people with all their furniture and clothing and things they need when they have been evicted. We have the food bank, you know, distributing a lot of food to our communities. I just think there's a lot of nonprofits that could use this extra help. And we already have experience in the district with this because of those other funds. So there's a whole grant application and it has to be a true nonprofit, confirmed nonprofit that's a 501c3 and, you know, with an explanation for the grant for how the money would be used. And the committee's already there. The committee's already together making these decisions. So we don't need to appoint a new committee.
Okay, great. Thank you.
Thank you. Thank you for the question, Senator.
Thank you. Any additional questions? Okay, thank you very much. We do have one witness signed up favorable with amendments, Dan Woomer. Good afternoon.
Good afternoon, all. I'm Daniel E. Woomer, past VP of the Linthicum Shipley Improvement Association, board member and past president of the Maryland Coalition for Responsible Transit, member of the Citizens Against the SC Maglev, and a voting member of the BWI Roundtable. I encourage the committee to vote in favor with amendments to change as proposed in Senate Bill 356. With the establishment of the Citizens Committee for Enhancement of Communities and $1 takeoff and landing fee to fund its annual budget, communities neighboring BWI Marshall have received grants and aid to make transportation-related improvements. This bill would increase the fee to $2 and expand the scope of the projects eligible to receive grants. Currently, for example, only existing sidewalks can be replaced. There are many roads that lack sidewalks at all. The proposed change would allow communities to request additional quality of life, environmental impact improvement, and safety projects. Note, the proposed change would have no impact on the state budget. Grants are funded by takeoff and landing fees. On average, there are 8 to 10 grants per year pre-COVID. Even doubling the fees, the number of grants awarded would likely remain small. Existing state resources should be able to absorb these few additional simple grants. My first suggested amendment is no additional employee as proposed in the financial and policy note. The second amendment I suggest is to strike line 11 on page 3, quote, improve education, quote. The grant should be focused on community projects that improve resident safety and quality of life. For example, replacement of dilapidated decades-old sidewalks improves the safety and quality of life for all, from tots, parents with strollers, to school children, to senior citizens. In summary, I encourage the Finance Committee members to vote in favor with amendments to proposed changes in this bill. I'd be happy to accept questions.
Thank you. I don't see any questions from the committee, so thank
Okay.
you very much for your
Thank
testimony.
you all very much.
And that will conclude the hearing on Senate Bill 356. We're now going to turn to Senate Bill 365, Health Insurance Qualified Resident Enrollment Program, Access to Care Act, Senator Lamb. And as he comes forward, colleagues, let me just remind you all, we have 29 witnesses signed up, all supporting the bill or favorable with amendments. And we have a combination of virtual and in-person witnesses. Senator, if you want to bring up those witnesses on your panel that are in person, and we know that you'll have a witness early on that will be virtual as well.
Great. Thank you, Madam Chair. There are members of the sponsor panel can come up. I think that's Ms. Flores, Ms. Eberly, Ms. LaRue, Ms. Peralta, Mr. Sims, and Dr. Sharfstein. And there's one virtual as well. Apologize to the committee in advance. I think you'll be seeing a lot of me today. So appreciate everyone's patience with this. I will note that this bill doesn't look like it has any opposition. There's no unfavorable in the committee report, so that's positive. And as our, well, I guess a little full here. As our panel is coming up, why don't I go ahead and get started? Thank you, Madam Chair, members of the committee. Good afternoon. For the record, Clarence Lamb, Senator District 12, and here to introduce Senate Bill 365, the Access to Care Act. Here in the state of Maryland, it is estimated that about 275,000 residents are undocumented, and about half of them do not have health insurance. So I'm really pleased to be able to introduce Senate Bill 365 today to expand healthcare coverage and accessible healthcare to this large uninsured population. This legislation builds on legislation that we introduced last year, and I think this is in the identical form as it was left last year, to help do two things. One, it requires the Maryland Health Benefit Exchange to seek federal permission to enroll undocumented individuals here in the state. It also creates a state-based insurance subsidy to mirror the federal subsidy that currently exists on the exchange. This subsidy is essential to ensure that exchange plans are as affordable as possible for those who are signing up for this benefit as enrollees. I believe this bill will help make our state healthier and also help meet our goal of ensuring all Marylanders. I recognize that the fiscal note appears large, but I believe this bill is not actually as expensive as the fiscal note suggests, and I'll explain why as well. The fiscal note estimates that a yearly cost of $250 million will be incurred to the state for this program by 2027. Yet in 2021 alone, 2 years ago, the cost of healthcare for undocumented residents in Maryland that was covered by emergency Medicaid totaled $118 million. So $118 million, almost half of the estimated yearly cost of the program by 2027. Emergency Medicaid is a program that allows Medicaid to cover emergency hospital care for undocumented individuals. Generally speaking, undocumented individuals are receiving care much later in the course of their illness, which drives up expenses for hospitals and the healthcare system. Access to routine preventative services leads to greatly reduced healthcare utilization and costs in the long term. For example, the average cost of a hospital stay for a heart attack is $21,000. For that same cost, medications and primary care visits to prevent that heart attack could be given for over 20 years, just in comparison. We know that rates of hospital admission for preventable conditions are higher among undocumented individuals, and thus by opening the Maryland Health Benefit Exchange to undocumented residents and thus expanding access to affordable and preventable care, healthcare issues and diseases in this population should be diagnosed and treated earlier before they become more costly or before they become more serious or perhaps even worse. And so I think it's important to note that when you look at this and to bear in mind that federal law requires anyone who needs emergency care coming to our emergency departments to receive the care that they need, whether they have health insurance or not. And as a result, those who don't have health insurance are still getting the care and somebody is subsidizing it. In effect, all of us that have health insurance are subsidizing the care that those who don't have health insurance would otherwise receive at the emergency departments. And that includes folks that are undocumented. So as a whole, it benefits all of us, even those who have a health insurance and folks across the state, to be able to get as many people enrolled in health insurance as possible. So that helps reduce the costs on our own premiums as well, even for those of us who have health insurance. Separately, I believe that undocumented Marylanders, that we as a state have a moral and ethical responsibility to provide undocumented Marylanders affordable access to health care. They do pay taxes in the state just like others in our communities as well. And in fact, in 2018, undocumented residents in Maryland paid an estimated $375 million in federal taxes, almost $250 million in state taxes and local taxes. Our current healthcare policy ignores the contributions that these undocumented Marylanders have made to our economy and our society. I would like to add that the proposal for this bill was informed by some of the prior work by the Maryland Health Benefit Exchange itself. If enacted, we can expect to see an increase in the overall enrollment of individuals on the exchange, which in turn will help reduce overall individual market premiums by almost 4% by 2028, all while bringing down the state's total percentage of uninsured, per what I cited just a few seconds earlier. The lower overall premiums will lead to savings in federal subsidies for existing exchange enrollees, which the state could capture in pass-through funding through a 1332 innovation waiver. In essence, the state would apply to the Federal Center for Medicare and Medicaid Services for a waiver to help support subsidies for this population that would sign up. In the past year, in the intervening year since we first introduced this legislation last year, both Colorado and Washington State have successfully submitted waivers to the federal government to do this. And they actually did receive approval for those waivers. Colorado's actuarial analysis for their 1332 waiver suggested insurance premiums would decrease by a significant 22.3%. And this correlates to approximately $1.6 billion. So in essence, by granting this population access and by seeking the approval of a federal waiver, they are decreasing their insurance premiums by almost $2 billion. And that's over a 5-year period. Maryland also successfully previously applied for a 1332 waiver in 2018, which was used to partially finance a state reinsurance program. For many of those who were on this committee a few years ago probably recall. By opening the exchange up to this population, we would bring down both Maryland's uninsured rate and individual premium costs. Senate Bill 365 is a major step forward in creating a more just and equitable healthcare system by expanding access to care for undocumented Marylanders through the Maryland Health Benefits Exchange. And finally, I'd like to emphasize that the cost is not necessarily fixed. When you look at the fiscal note, it's just showing one scenario that is scoped out in the note itself. The bill, to be clear, allows for flexibility. It allows the Health Benefit Exchange, and I think Ms. Everly can speak to this, to scale their program and scale the subsidies to the amount of funding that we have. And so there are many possible scenarios that the exchange can study and go forward with. So the bill is intentionally written to give the exchange as much flexibility as possible to make decisions on who will actually be included in being able to receive those subsidies. And I think she can also speak to some other scenarios that would help bring down the cost. But just to be clear, the healthcare exchange program would scale their eligibility requirements to be able to work within the funds that they have to be able to provide subsidies for this. So with that, let me pause here. I know there are a lot of folks on this sponsor panel. I'll turn it over to them. Happy to answer any questions.
Thank you very much. Did you want to go first to your, let's go first to your.
Yeah, let's
first
go to Ms. Everly.
We had a
Oh,
virtual,
sorry,
we
yes,
had
to
the
the virtual.
virtual witness that we would go, and then we'll go back to the panel.
Sounds good.
Okay, good afternoon.
Hi, my name is Lina Guerrero, and I'll be translating for Briseida. Briseida, empieza. Okay.
Thank you. You can go ahead.
Buenos días. Buenos días, Presidenta Melanie Guilford y vicepresidenta y demás miembros del Comité de Finanzas. La Clínica del Pueblo se complace en apoyar el proyecto de ley SB 365 con enmienda. Good afternoon, Chair Melanie Griffin, Vice Chair Klaus Mayer, and other members of the Finance Committee. La Clínica del Pueblo is pleased to support SB 365 with amendments. Mi nombre es Briseida Flores, soy de El Salvador y tengo 19 años. He sido residente del condado de Prince George durante casi 4 años. Soy estudiante de Northwestern High School. Pertenezco al programa de salud mental Mi Refugio, la Clínica del Pueblo. My name is Briseida Flores. I am from El Salvador and I'm 19 years old. I have been a resident of Prince George's County for almost 4 years. I'm a student at Northwestern High School. I belong to Mi Refugio, a school-based mental health program of La Clínica del Pueblo. La Clínica del Pueblo es un centro de salud federal calificado. Mi Refugio es un programa de salud mental dentro de la escuela para jóvenes inmigrantes recién llegados. Tener acceso a terapia de salud mental me ha ayudado a lidiar con problemas para poder adaptarme a la escuela y aceptarme a mí misma. La Clínica del Pueblo is a federally qualified health center. Mi Refugio is a mental health program within my school for newly arrived immigrants. Having access to mental health services has helped me to deal with problems in order to adjust to school and accept myself. En el día de hoy quiero pedir que apoyen el proyecto de ley de acceso a la atención médica. Hoy hablo en representación de muchos jóvenes inmigrantes y sus familias que, como yo, hoy se encuentran excluidos de poder recibir servicio médico. Today, I would like to ask you to support the Access to Care Bill. Today, I speak on behalf of many young immigrants and their families who, like me, are currently excluded from receiving health services. En la escuela he podido darme cuenta de que muchos de mis compañeros, al no contar con un servicio médico, no pueden tener suficiente información para poder tomar decisiones. Como jóvenes nos encontramos más expuestos a riesgos como embarazos no deseados, enfermedades de transmisión sexual, diabetes, depresión, ansiedad, que nos llevan al uso de drogas y alcohol. When I go to school, I notice that many of my peers lack access to see a doctor, and they are not able to have enough information to make decisions. Being young means being more exposed to risks such as unwanted pregnancy, sexually transmitted diseases, diabetes, depression, and anxiety that can lead to the use of drugs and alcohol. Tuve que irme de mi país por los altos índices de criminalidad y la falta de oportunidades. Mi sueño es estudiar en la universidad. Para poder lograrlo, requiere poder cuidar mi salud, pero no puedo tener un seguro médico por mi estatus migratorio. I had to leave my country due to high crime rates and lack of opportunities. My dream is to study and go to the university. To achieve this goal, I need to be able to take care of my health, but I can't because I can have a health insurance because of my immigration status. La decisión sobre la salud de muchos jóvenes de Maryland está en sus manos. Espero que nos apoyen en esta decisión para el futuro de nuestra sociedad. The decision about the health of many young Marylanders is in your hands. We hope you will support us in this decisive stage of our lives for the future of our society. Muchas gracias por su atención. Thank you for your attention.
Thank you for your testimony. I don't see any questions from the committee for you, so thank you for being here and sharing your testimony. We're going to turn it back over to the in-person panel now and
Thank you so
proceed
much.
with the hearing. Thank you very much.
Gracias, Briseida. Ya te puedes conectar.
Ok,
Thanks, Ruth.
gracias.
Good afternoon, Chair Griffith, Vice Chair Klossmeyer, and committee members. For the record, I'm Michelle Eberly, Executive Director for Maryland Health Benefit Exchange, the state's designated marketplace established under the Affordable Care Act. I thank you for the opportunity to testify today on Senate Bill 365. This bill, as you know, would establish an enrollment program for populations who are currently ineligible for coverage through the exchange. Maryland's uninsured rate has fallen in half in the last 10 years, standing at around 6%. And the state has been a national leader in working to reduce the uninsured rate through efforts that this committee in part has helped put in place, such as the state reinsurance program, which has reduced individual market premiums by more than 25%. Our easy enrollment programs that allow uninsured individuals to get connected to health coverage when they file their taxes or when they file for unemployment insurance. And our young adult subsidy program that helps those younger, healthier people to afford health insurance and come into the marketplace. Even with these innovative efforts, approximately 357,000 individuals remain uninsured in Maryland, and undocumented residents make up about a third of the state's remaining uninsured. Providing access to health insurance for all Maryland residents will have benefits beyond just that individual getting health insurance. Premiums across the entire individual marketplace will be affected. As you know, the more people you get into a risk pool, the more that spreads the costs out. So we expect that would have downward pressure on the premiums. The overall improved health to our state's population due to increase of access to care, and the decreased cost to hospitals for uncompensated care. In fiscal year 21 alone, Maryland hospitals provided over $780 million in uncompensated care. As of December 2022, 8 other states in the nation have already expanded state-funded coverage for undocumented populations. And as Senator Lamb said, this included Washington and Colorado through their ACA marketplaces. Establishing a qualified resident enrollment program is not contingent entirely on state funds. It could be implemented without the use of state funds. If we don't provide the subsidy, we still could do that. The exchange is ready and prepared to do this. Thank you.
That's the most important thing we need to know. Okay. Next. You just want to run the line?
Yeah.
Madam Chair and members of the committee, good afternoon. My name is also Michelle LaRue, though. I'm the Director of Health and Human Services at CASA, Maryland's largest immigrant rights organization. CASA asked the committee for a favorable report on this common sense and life-saving legislation that will allow undocumented immigrants a chance to buy insurance on the exchange. Everyone deserves health care regardless of their immigration status. That is at the core of this bill. The majority of immigrant families who enter our doors at CASA are undocumented and uninsured. We work tirelessly to ensure the immigrant community is receiving the care they need. Sadly, our services are in high demand because our community is entirely ineligible for coverage and must rely on overwhelmed safety net providers. Despite paying approximately $350 million in state and local taxes each year, they cannot buy insurance on the exchange, even if they can afford it at full cost. Committee members, as you know, these individuals contribute so much to our community outside of their tax contributions. They are weaved into the fabric of our community. They risk their lives to keep us afloat during the pandemic, working in essential jobs. We cannot leave them behind now. Maryland has taken great strides in prioritizing health equity and being a leader in embracing reform. Yet little has been done to address the access to care for the nearly 5% of our population that remain undocumented and uninsured. This bill would help correct that injustice and allow access to the marketplace for all Marylanders, as well as to create a framework for a subsidy that would make the plan affordable. We support this bill with a small but important amendment, as critical equity language is needed for clarification purposes to ensure that when the exchange opens, newly qualified individuals have the same experience buying insurance. And we thank Senator Lamb for his leadership in prioritizing equity. Insurance providers, hospitals, community clinics, and the entire immigrant community are all in alignment. It is time to make this happen. For these reasons, so many and more, we strongly recommend a favorable report for SB 365. Thank you.
Well, then I have good afternoon to Madam Chairs and good afternoon to members of the committees. My name is Elizabeth Chang. I'm from Frederick, Maryland, though I was very active, have been active in the state for the health equities. My agency is the Asian American Center of Frederick, and I am the executive director for the center. For the past 4 years, we have been helping Kaiser Permanente to enroll, undocumented, residents to their insurance program. And for everyone that we enrolled, we have 2 in the waiting list, and we usually do about 500 or so each year. So you can imagine almost 1,000 still waiting for insurance. Despite the Kaiser's generosity, there was still an asset issue because many of our clients in the communities from Western Maryland, a lack of adequate transportation to access healthcare services in counties where Kaiser's providers are located. So this particular bill, Senate Bill 365, would remove the barriers that tens of thousands of residents would be able to access healthcare services in their own communities. I have submitted written document, and one particular case I want to share with you is that someone that we served from Bangladesh for 20 years, undocumented, have no insurance all this time, but with Kaiser Permanente, he was able to have his hernia and then able to go home to see his grandchildren. This is very important. So our services provide for all, all Marylanders, in Maryland. It's last, I know that my time's up. It's my own father. I have to send him home to die because of no insurance. So as a family who has a flying tiger to serve this country, that we deserve, health insurance for all of us. So I want to thank, thank Senator Lamb for his leadership. And again, to that, with our insurance program, we find out that many of our clients, they just cannot afford even the premium. And our income level is $12,000, $22,000 for families of 6 or 8. So how can they even afford the premium? So we ask for your favorable consideration, as well as the amendments that we propose to you. Thank you, Madam Chair, and thank you, members of the committee.
Yes, good afternoon, Madam Chair and members of the Finance Committee. I am Dr. Reed. I live in Frederick, Maryland. I'm a leader with Progressive Maryland's Healthcare Task Force and Frederick County Progressives. I am also a member of RISE Western Maryland, which is Resources for Immigrant Support and Empowerment. Thank you for this opportunity to testify in support of Senate Bill 365, the Access to Care Act. I urge your support for the Access to Care Act, which will allow Maryland Health Benefit Exchange to cover all Marylanders who meet the Affordable Care Act eligibility requirement, regardless of their immigration status. The Access to Care Act provides a way to address the racial disparities in our healthcare system, so allowing access to the exchange for Marylanders of color who cannot currently use it makes sense. I'm a retired veterinary staff scientist from the National Institutes of Health, and I have worked in the infectious diseases research for more than 30 years. I am also a member of the Frederick County Health Department's COVID-19 testing task force, charged with community engagement and ensuring our residents, especially those in vulnerable communities, have access to free COVID-19 testing. My background and my experiences during the pandemic have made me keenly aware of the insufficiencies of our healthcare system, especially when it comes to meeting the needs of our neighbors who are undocumented immigrants. I urge you to pass Senate Bill 365 and to provide full subsidies for those individuals and families who will be enrolling. These subsidies will help ensure newly eligible residents register and get the medical care and attention they need when they need it. I appreciate your consideration and thank you very much.
Good afternoon, Madam Chair and Madam Vice Chair and committee members, and thank you all for having me here today. My name is Brian Sims. I'm the Vice President of Quality and Equity at the Maryland Hospital Association. And on behalf of our 60-member hospitals and health systems, I'm proud to sit alongside all of the advocates and supporters here in support of Senate Bill 365. Maryland's hospitals are committed to the state's efforts to expand healthcare coverage. We are strong proponents of that. Yet we know that many Marylanders remain uninsured, including those that are undocumented. Now, these individuals are often forced to put off their healthcare needs and often seek care in the emergency departments when their medical conditions should have been addressed long before they experience an emergency. And we know just how overwhelmed our emergency departments are with folks seeking care. And oftentimes that care could have been and should have been addressed prior to that situation. You all are very familiar with our total cost of care model, and successful in that model, which is one of a kind in the nation, relies on folks who receive care in Maryland to have adequate access to care. We believe in broad-based, affordable, and comprehensive health insurance, which is key to hospitals' ability to deliver high-quality care and critical to ensuring success on the state's population health goals. Senate Bill 365 would close a long existing gap for individuals who, based on their immigration status, are not able to access affordable care. Additionally, the Maryland Health Benefit Exchange projects that this coverage expansion could have a positive impact on the individual market as well, reducing premiums up to about 4%. And you've heard some of that from some of my counterparts here today. This is an equity issue, this is a population health issue, and this is a public health issue. And for those reasons, we urge a favorable report on Senate Bill 365.
Now make room for Dr. Sharfstein, no stranger to this room. Good afternoon.
Good afternoon. It's great to be here. That was great testimony. I should just say, and to all of my fellow panelists, that was an honor to be here. It's an honor to be with you, Madam Chair, and Madam Vice Chair. It's an honor to be with Senator Lamb. I know that some of you may know I was the Health Secretary in Maryland. Before that, I was the Health Commissioner in Baltimore City. For that, I was a pediatrician and I worked in the pediatric Latino clinic at Boston Medical Center. Since I've come to Johns Hopkins, I've been supportive of Centro Sol, which is a group of clinicians, social workers, and others who serve primarily the Latino community in Baltimore, many of whom are undocumented. And in that work over the last 7 years, and I'm testifying today on their behalf as part of Centro Sol, they have taken care of many, many people who have suffered the consequences of not having health insurance. And that is just, it's really hard. It's really hard to see people suffering. I know this from my own experience. It's really hard to know that that suffering was preventable. And we live in a great state and the state couldn't do anything to help to prevent suffering. It's also a moral injury for the clinicians who have to see this happening and know that there's very little that they can do. There's really a policy failure that underlies the problem. And they also see the consequences. They see the consequences to families when people can't care for their children because they're injured and can't respond when for their work. People can't work and they do jobs that are necessary and there aren't other people to do them. And ultimately, they see the consequences for costs and for the whole healthcare system struggling. So it's really on their behalf that I'm here, and it's an honor to be here. This would be an incredible step forward for Maryland. Thank you very much.
Okay, I'm just gonna take a quick pause. Senator Reedy has a question, and I know we're swapping out witnesses, but before some of your initial panel leaves, Senator Lamb, I'm going to take this question and then we'll keep rolling with the witnesses if that's all right. Senator Reedy.
Thank you, Madam Chair. First of all, can I ask a question, and maybe Senator Lambert's for you, but I'm not sure. The bill, as I see, is silent on what a qualified resident. Is there any limit to the amount of time someone would have had to have been here in the state as a resident before they could take advantage of this? I didn't see it in the bill, but
I don't see it in the bill. The bill does on page 2 have a definition of a qualified resident. There are 4 conditions that are stipulated in there. And I think anyone who meets those conditions would otherwise qualify. Now, I think it's important to note that other states that have expanded health insurance, when you look at California, for example, that's expanded coverage to those who are undocumented, they had not seen an increase in migration from folks that are undocumented. I know that that can be a concern for a lot of folks, but I want to make sure that that's clear, that it's not an issue that when other states have engaged in expanding healthcare access, that they've seen a concern from.
okay. Another question would be right now, and I forgive my ignorance, but if someone is an undocumented person here, can they go buy private insurance if they had the financial means to do so? There's no limit on someone buying insurance currently. You don't have to be a citizen or legally present to buy insurance in the state. I don't know if anybody can answer that.
They could purchase directly from the individual marketplace on their own. Typically, the cost is prohibitive.
Right, I understand. And then, so if they go through the exchange, will these largely will be Medicaid funded entirely, or likely they'll be Medicaid patients, correct? This would be Medicaid, not patients, Medicaid enrollees. That's the word I'm looking. Medicaid enrollees. So that this is an expansion of Medicaid to, correct or no?
No,
Can you
because,
walk me through
right,
that?
well, right now, what this bill does is it allows people to purchase through the exchange. So right now, federal law prohibits anyone that's undocumented to purchase a health plan through the exchange. What initially it would allow it to do is anyone could purchase through the exchange, and any existing subsidy programs such as the young adult subsidy program, because it's state-only funding, they'd be eligible for that. If there was any additional state funding on top of that, they would be eligible for that. There is another bill to do a study on what the cost would be to have people enroll through Medicaid, but that's not what this bill is about.
Okay, and I saw, thank you for the answer on that. I was looking at the fiscal note a little bit, but I wasn't clear. I saw in the bill about mandating $15 million of the governor funded at 15 million. Is that language that deals with what currently is funded, or is that extra money that would have to be added to make sure we covered this, or am I misreading? I saw,
You reading that in the fiscal note?
That's existing law. So that must be the transfers $15 million to the Health Equity Resource Community Reserve Fund fiscal years 2023 through 2025. So that's currently what's been transferred.
That's out, yes, that's out of the reinsurance program funding. That's
Right.
a whole separate.
Okay, all right. Thank you very much. Thanks for your interest.
Thanks. So we'll proceed with, we'll continue with some testimony. Those of you that haven't testified can proceed.
And I'm going to be translating, if that's okay.
Hola a todos los aquí presentes. Mi nombre es María Peralta. Soy de origen República Dominicana y vivo aquí en el condado de Baltimore con mis 2 hijos de 16 y 13 años. Soy miembro de casa y soy sobreviviente de cáncer.
Good afternoon, Senators. My name is Maria Peralta. I'm a proud immigrant from the Dominican Republic. I am a resident of Baltimore County. I am a CASA member. I am a mother of 2 young teenage children, my 16-year-old and my 13-year-old. I am undocumented, and I am a cancer survivor.
Tenía cáncer triple negativo. Me lo diagnosticaron a los 32 años de edad.
I was diagnosed with triple negative breast cancer when I was only 32 years old.
Para los que no conocen, el cáncer triple negativo es una de las enfermedades más agresivas que hay para nosotros.
For those of you that don't know, it's one of the most aggressive form of cancers out there.
Es una enfermedad bastante complicada, bastante difícil, porque te destruye psicológica, mental, emocional, en todos los sentidos de la palabra, y para la familia también.
It's one of the most traumatic experiences out there. It destroys you psychologically, physically, and not just you as an individual, but it has an impact on your family as well.
Necesito un chequeo rutinario, un monitoreo de cáncer de triple negativo, porque es una enfermedad mortal. No sé cuándo pueda volver, me da miedo al despertar y no saber que si volvió o no, porque no tengo un seguro médico.
I need to do routine checkups because this is one of the most aggressive cancers. And one day I'm just afraid of maybe I won't be able to wake up. The future is uncertain for me.
Aparte también, cuando me hicieron una mastectomía radical, me sacaron 19 ganglios de mi brazo derecho, lo cual se me hincha a cada rato, y por no tener una manga para mi brazo y no tener el seguro, no puedo acceder a nada de eso.
And there's so many side effects that have impacted my life: swollen hands, no lymph nodes, which have prevented me from being able to work. And with no insurance, I haven't been able to do the routine checkups that I need.
Mis dos niños tampoco tienen una cobertura de seguro, ya que sufren de una alergia severa y asmático, y no puedo llevarlo a un médico para que lo chequeen. La última vez que lo llevé, la cobertura, el seguro me llegó, el Medicaid me llegó bastante costoso a la casa.
And my two children don't have health insurance and suffer from severe allergies. As a result, I still have medical bills from when I had to take them to the hospital that I'll never be able to pay off.
Así como yo, hay muchas familias indocumentadas que no pueden acceder a un médico porque no tienen seguro y viven con miedo a morir. Yo vivo con miedo a morir por mis hijos, y porque si yo no trabajo y no tengo un seguro, ¿cómo yo puedo sostener a mis hijos?
And just like so many families like mine, having that lack of health insurance, I'm afraid to die. I don't know what to do with the future of my kids.
Le pido por favor que tomen conciencia y nos ayuden a tener un seguro médico, ya que la salud es mundial y todos tenemos derecho a una salud. Gracias.
And that's why I'm here asking you guys all to pass the Senate Bill 365, access to healthcare, because we deserve access to healthcare, and this is a health and human right. Thank you.
Were there any questions for that witness? Okay, thank you very much for your testimony and for sharing your experience. Thanks so much. Okay, you can proceed. Please identify yourself before you start.
Okay, thanks. Good afternoon, members of the Finance Committee. My name is Shannon Riley. I'm the population health nurse at Healthcare for the Homeless in Baltimore. Thank you so much for having me to testify today. We at Healthcare for the Homeless are in support of this bill, and we believe healthcare is a human right, and that nobody should be sick or die because of their economic or immigrant status. As a nurse, I have seen unimaginable pain and human suffering occur due to the lack of access to healthcare and other health support networks. I have seen a young woman, immigrant, not yet with legal status, present to a hospital for pain during pregnancy, and in that visit, diagnosed with end-stage cancer. Her cancer resulted in the early birth of a loved child who died hours later. The young woman began inpatient treatment for cancer that was provided only by some emergency and other charity services, but otherwise discharged to home with only over-the-counter pain medications to manage intense pain. She was without proper access to outpatient cancer treatment and therapy, and her only option was to return to emergency services if her discomfort became so severe that was her only recourse. And during that time, if she were to be rehospitalized, she would be then having even less time to spend with her husband and her other child. She was a member of our community, and the only difference between the treatment she should have received and the care she did not receive is that she was born somewhere else. Last fall, I inquired about an older female client at our clinic who missed an appointment for a routine influenza vaccination. Her primary nurse said it was unlike her to miss appointments, so she called her at home to check on her. And that woman explained through tears that she was holding her dying son, who was 40 years old, dying of cancer and unable to receive any care or treatment for his pain and suffering. She was giving him sips of water and comforting words. He did not have access to world-class medical care, even though it was sitting right here in his neighborhood. It is unimaginable to me that in the state of Maryland, we would tolerate countless such stories of human suffering and do not act with haste to ease it by extending ACA coverage to all persons living here. At Healthcare for the Homeless, we urge favorable with amendment report on Senate Bill 365. Thank you.
Thank you for your testimony and for being here this afternoon. I don't see any questions, so we're going to move. I have Allison Taylor, Kenneth Phelps, Ricara Jones, Callie Schumitz, Vinnie DeMarco. And Monica Vasquez. Not seeing movement there. Okay. Michael Patty, if you're here. Stephanie Clapper. Might as well fill all my chairs. Good afternoon, everyone. You can proceed. Whoever's closest to the mic, you can get started. Thank you.
My name's Linda Boyd. I'm here today with Ken Phelps on behalf of the Maryland Episcopal Public Policy Network. I'm also here on behalf of the Maryland Lutheran Synod. Lee Hudson could not be here today, but has filed testimony on behalf of the Lutheran Synod and on behalf of the Central Maryland Ecumenical Council. Basically, we believe that all people are children of God, deserving of equal dignity and respect. We should not be monetizing healthcare. Other countries have recognized this and have provided healthcare for all of their citizens, or all of their people in their country, I should say. And that's a very important concept because it respects the dignity and it represents and it recognizes that healthcare is not just some privilege. Healthcare is a necessity. You've heard the stories today. You've heard the suffering that people have gone through because they did not have access to healthcare. We strongly urge a favorable report on this so that you can help Maryland to recognize this need. Thank you.
And good afternoon, Madam Chair, members of the committee. I'm Ken Phelps of the Diocese of Maryland. Good to be with you in person this week. And when I left off in last week's sermon, I talked about how salvation actually means healing, which means that healing is the central mission of Christianity. Well, today, I want to tell you that Christianity is not about Jesus. It is about what Jesus taught, which was a way of engaging the world, a way of engaging with each other, a new way of being human. And one of his central themes was that of hospitality. You know, the word hospital is in that, right? And it's one we share with Islam and Judaism, because how we care for the stranger in our midst is of the highest priority. It was so important that when Jesus spun a tale about the Last Judgment, and we conveniently forget this detail, it's not individuals who line up to be judged about telling this lie or cheating on one's taxes. Go and read it. It's the nations who line up, and they are judged about how they cared for the marginalized, including the stranger, the immigrant, the refugee in our midst. Here's one more secret about Christianity. We talk a lot about eternal life. Well, the best translation of that word eternal is authentic. Authentic life, being real human beings who are compassionate, empathetic, who are less fearful. Because that ultimately is how we do bring about the kingdom of heaven, the kingdom of love, the culture of love, the beloved community.
I envy you because you have a chance to help us as a state become a bit more authentic and move us a little closer to our best destiny. We hope and pray that you will do the right thing. On behalf of the Diocese of Maryland, we do request a favorable report. I thank you for your time. God bless. I'll see you next week.
I was waiting. I was like, does he like this bill? I know.
Yes.
Thank you. All right.
Thank you, Chair Griffith, Vice Chair Glassmeyer, and members of the committee. My name is Callie Schumitz. I'm with the Maryland Center on Economic Policy. We are a nonprofit, nonpartisan research organization. And we're here in support of Senate Bill 365 because we believe all Marylanders deserve access to affordable, quality health care. This is a situation where doing something that is good for people is also good for our communities and for our economy. As prior panelists have stated, affordable health coverage not only improves an individual's health, but is connected to greater financial security, both by ensuring that people are healthier and can continue working and caring for their families, and also by reducing out-of-pocket healthcare costs. Just for one example, there's research related to the Affordable Care Act expansions that shows that access to health coverage reduces evictions and reduces medical debt. And as Senator Lamb did a great job of outlining, we all pay when people delay care because of the expense and end up with a more serious health condition that is more expensive to treat, or maybe they end up in the ER for treatment. And there are really good examples of similar programs in other states. Maryland has a good models to work from. Senate Bill 365 is a great first step in ensuring that we began the process of requesting the waiver, setting up a program, and setting up the pathways to address care for Maryland's largest uninsured population and help more low and moderate income families afford health coverage. We would ask for a favorable report. Thank you.
Chair Griffith, Vice Chair Klausmeier, and members of the committee, thank you for this opportunity to testify in favor of Senate Bill 365 with amendment. I am Stephanie Clapper with the Maryland Healthcare for All Coalition. Our mission is quality, affordable healthcare for all Marylanders. And I do mean all Marylanders, regardless of immigration status. I'm representing here over 300 faith, business, labor, community, and healthcare organizations across the state that support expanding coverage regardless of immigration status. And you can see a flyer with just some of their logos in your packet. The Access to Care Act would be a big step forward, and I know this committee has already made big strides towards health equity through legislation like the Healthy Babies Equity Act and the Health Equity Resource Act. And now I'm asking that we continue to move forward. There are over 275,000 undocumented immigrants ineligible for care through Maryland Health Connection. And this has had the biggest impact on Black and Latino residents who have become sicker, hospitalized at higher rates, and die younger due to their exclusion from safety net programs such as the Affordable Care Act. This improving access would improve their access to primary care and managing chronic conditions. And in addition, like others have said, it would reduce uncompensated care in our hospitals, which would benefit all Marylanders. We are supportive of CASA's proposed amendment, which would ensure that any subsidy support would be given out at the same level as it is for other Marylanders who are already eligible for subsidies. So in conclusion, I urge a favorable report with amendment for House Senate Bill 365. Thank you.
Good afternoon, Madam Chair. My name is Michael Patty, here today on behalf of the Maryland Dental Action Coalition. I want to thank Senator Lamb for the bill. It was this committee last year that enacted Senate Bill 150, which finally integrated dental coverage into our adult Medicaid program. And thanks to that bill, as of January 1st, 800,000 adults now have dental coverage. We're proposing an amendment just to be abundantly clear that when we're talking about a qualified health plan, we're also talking about a standalone dental plan. Currently, on the exchange, there are standalone dental plans. This amendment would just add in standalone dental plan a few times throughout the bill. I do want to highlight the fiscal note on the last page and the additional comments, the waiver that Washington State turned in specifically mentioned standalone dental plans. So we just wanted to see that that's also included as this bill moves forward. And with our amendment, we'd ask for a favorable report. Thank you.
Good afternoon, Madam Chair, members of the committee. My name is Allison Taylor, and I'm here on behalf of Kaiser Permanente today. As you heard earlier, Kaiser Permanente works with CASA to enroll undocumented immigrants into our charitable care program, where we provide free healthcare and premium assistance for people who need it. So to the extent that we're in full support of this program, and to the extent we can get people in the a formal system, it does help improve the risk pool and allows people to access subsidy programs, which would help us extend our charitable care dollars even further. So I request a favorable report.
Thank you all very much. I see no questions for this panel, so thank you for your testimony. Good afternoon. We're going to turn to Anna Rubin, Antonio Brooks, Bridge Dumais, Blanca Escobar, Oguchu. Help me. You'll finish it when you, thank you. And Frank Patanella. Okay, you can proceed. Good afternoon.
Good afternoon. Thank you, Chair Griffith, Vice Chair Klausmeier, and members of the Finance Committee. My name is Anna Rubin. I live in Columbia in District 13. I'm testifying in support of Senate Bill 365 with amendments on behalf of Jews United for Justice, which organizes 6,000 Jews and allies across the state in support of social, racial, and economic justice campaigns in Maryland. The issue of ACA inclusion for people regardless of immigration status is personal for me, as I've detailed in my written testimony. In the past 6 years, among others, I've worked with a refugee family of 7 who came from Syria in 2016 after years in a Jordanian refugee camp. They were given Medicaid immediately as part of their federal benefits package. The care they received was crucial because they'd gone for several years with very little. Healthcare has been vital as their children dealt with a slate of childhood diseases. The mother went through pregnancy and childbirth, and the father dealt with chronic back injuries. The parents have found jobs and resettled successfully. They couldn't have done this without good healthcare. Including undocumented people in the ACA is not only humane, it helps prevent the spread of infectious diseases, such as COVID, maintains a healthy workforce, and saves money, as you've heard, by reducing the reliance on ERs. As Jews, we are obligated by our ethical tradition to make sure that all are treated as sacred human beings, deserving of good health. On behalf of Jews United for Justice, I respectfully urge this committee to return a favorable report on SB 365 with an amendment that ensures newly qualified individuals will receive the same subsidy rate as all other individuals covered under the Affordable Care Act.
Good afternoon, Madam Chair, members of the committee. My name is Frank Patanella. I'm a senior policy advocate with the ACLU of Maryland. Those of us who have access to care should be unsettled knowing that there are mothers and fathers out there, little children and grandparents with chronic illnesses who don't have access to care. Unfortunately, that's what we have here in Maryland, despite the work of this legislature. People with access to care like me and my wife and children can go to the doctor for an illness or medical condition for a routine checkup or the emergency room without having to worry about compiling enormous debt or paying thousands of dollars for treatment. Knowing that I have access to care for myself and for my family means security. Access to care means longevity. Access to care means financial solvency. Access to care means opportunity, and access to care means freedom. These are principles and values that we as Americans pride ourselves on. And I want to take just a quick moment to explain how access to care has impacted my own life. My parents were both immigrants, and while I was growing up, I watched my father suffer with the chronic illness of diabetes, type 1 diabetes. I've seen him have reactions to his condition. I remember him shaking, breathing rapidly, and acting confused. Him having going to the doctors frequently and a few times to the emergency room. What saved his life was access to care. And not only that, access to care was also responsible for the opportunities had and consequently that I had growing up. We were never saddled with insurmountable debt because of his medical condition. He was able to run a successful business and adequately provide for my mother, my sister, and me. I can only imagine what would have happened if he didn't have access to care. Perhaps his condition would have gotten out of control, could have slipped into a coma, or perhaps it could have been a fatal outcome. Perhaps I wouldn't have been able to go to college, or I wouldn't be standing here now, able to provide for the well-being of my own family. The access to care has ripple effects. So we want to make sure in Maryland that we can take care of our families, pursue opportunities, and contribute to the tax base and make our state economically stronger. So, vote yes for access to care. Thank you.
Good afternoon, Madam Chair, Madam Vice Chair, members of the committee. Can you hear me okay? All right. Thank you so much. My name is Bridge Dumais. I'm the co-chair of End Medical Debt Maryland. We are a statewide coalition of unions, faith leaders, patients, health justice advocates, consumers' rights proponents, lawyers, and healthcare workers. Collectively, we represent hundreds of thousands of Marylanders. I am also the political coordinator with 1199 SEIU, United Healthcare Workers East, the largest healthcare workers union in the nation. Both organizations urge a favorable report on this legislation with CASA's amendment to create a subsidy program. We very strongly support the Access to Care Act because healthcare is a human right. This bill is an important step towards ending healthcare disparities for immigrant communities. With this bill, Maryland would become a healthier place for all its residents by ensuring individuals are able to afford primary care. This will result in higher rates of early detection and better long-term management of chronic illnesses. Furthermore, it would decrease the amount of costly emergency room visits and disproportionate mortality rates. Patients who delay seeking healthcare because they fear medical debt are stuck in a vicious cycle where their health deteriorates in the long run and their condition ends up being even more expensive to treat. Choosing between receiving healthcare and being burdened with medical debt or not seeking healthcare and suffering from worsening health is an unfair choice that no one should have to make. Other states in this country have established care programs to extend coverage to immigrants regardless of immigration status, and it's time for Maryland to do the same. Thank you.
Good afternoon. My name is Antonia Brooks. Senators, I am a healthcare worker in the ICU at Hospital in Baltimore and a union delegate 1199 SEIU. Our union has over 10,000 members in Maryland, DC regional. We support the Access Care Act and urge committee to vote yes. Patients without healthcare insurance often delay seeking healthcare because they cannot afford it. The consequences of this that patients' health gets worse over time, medical bills get higher. For example, if a patient has a heart condition but puts off primary care, they end up in the hospital and have to get surgery. We have short staffing crisis in the hospitals. The current patient to work ratio is understandable. Healthcare workers are overworked and underpaid. We need safe staffing and higher wages. Expanding access to affordable health insurance for everyone will help patients get primary care so that we do not end up in the hospital. This better is for patient health, reduces the burden on healthcare workers and short staffing hospital. We always provide the best healthcare we can, but it's unfair for patients to have to go to the hospital because we cannot afford primary care. I am a healthcare worker because I care about people. And I believe access
to healthcare is human rights. It should not matter where someone was born or live. Everyone deserves affordable healthcare. Please vote yes for access at care. Thank you.
Good afternoon. My name is Ogochukwu. I live in Prince George's County in Laurel. Although I was born in Nigeria, I have made Maryland my home for the past 3 years. I want to give an example of what it's like not to have healthcare insurance. Few months ago, I fell down the stairs and injured my back, elbow, neck, and my arm very badly. For most people, after a fall like that, it will be no problem to call a doctor or to visit doctor afterwards. But for someone without insurance, the experience is extremely stressful. An ambulance was called. I was taken to the emergency room, and I was afraid because I didn't have insurance. Of course, bills have been coming in because my medical bills, my medications were not covered in that emergency room. So they've been sending me bills. That's just one example. Another one was when I had my son 2015, my blood pressure rose up to 223. And in 2 days, I was billed $23,000. Yes, I was advised to go home because I didn't have insurance. Otherwise, I'll have more bills. So, because it was so serious. I'm the sole provider for my son, and I worry about what it would be like if I was not around to take care of my son. Not having health insurance has been very difficult for me emotionally. I ask all the legislators here today to think about what it would be like if you didn't have insurance when you took a fall down the stairs or had severe health problems. Without insurance, I can't get my eyes checked. I can't get regular checkups. I can't stay healthy for my son. I work so hard as a human being. I'm a certified medical technician. It is a right in this country to have healthcare insurance. Thank you.
Thank you very much. I don't see any, Senator Ellis.
Yeah, thank you, Madam Chair, and thank you, Senator Lamb, for this bill and the witnesses. Unfortunately, I had to leave to go testify on 2 other bills, and I'm back. I had a question for the sponsor when he was giving his presentation. And you were talking about the fiscal note, and you're saying it's very high. So I was looking at the fiscal note, and it talked about, and you mentioned in the 2028, I believe, was 250 million. And so I'm looking at that. I'm just kind of like, where's that number? Because this is like in dollars, not in millions. If someone brought this up before, forgive me for bringing it again. But it's like that number they give for 2028 for the state effects is like 250, like 1,000. And so I'm just trying to figure out where you saw that other number that you mentioned is in this million range. And I don't know. Okay, yeah, thank you.
Sure. So thank you, Senator Ellis, for that question. The fiscal note can reflect a few different scenarios, right? And so part of what the bill does is ask the federal government, it requires the state health benefit exchange to apply to the federal government for a certain waiver that would provide additional funding to the state to help support subsidies for those who qualify and enroll in the exchange program. Some of the costs cited here are the additional effort that's involved to apply for the federal waiver. And the in the fiscal note itself, I think it also spells out different scenarios on looks like page 3, where it says for illustrative purposes only, it's giving some scenarios of how many people might potentially enroll, because it's uncertain how many people would enroll. And the federal pass-through funding that would be available to the state if we were approved for this additional waiver that the federal government would provide to us, that we would have funding that could be used to support people through subsidies on the exchange. And so the exchange can scale those subsidies based on how much funding we receive from the federal government. So it's not intended to be a dramatic hit to, there's a fund that supports the exchange program. They can scale it so that certain eligibility requirements can make people more eligible and also can make it less eligible depending on how much funding we receive from the federal government through that pass-through that's cited through there. So, there's flexibility to the health benefit exchange to be able to scale the eligibility based on how much funds we receive from the federal government as part of this waiver.
Yeah, but it wouldn't be a $250 million hit in 2028.
We don't believe it should be a $250 million hit. And I think the other thing to keep in mind that was cited earlier that you were probably had stepped out for was the fact that it would reduce the amount of uncompensated care that we would see in our emergency departments. Uncompensated care is still being paid for by someone. It's usually paid for and supported by those who have health insurance. Reducing the number of people uninsured, we believe will help ensure that all of our premiums don't rise unnecessarily because of the unsupported care that folks are receiving at the emergency departments.
Thank you, Senator. Thank you, Madam Chair, for your indulgence.
Thank you. All right. Are there any questions for this panel? Okay, seeing none, thank you all very much for your testimony. We do have some virtual witnesses signed up on the bill. Sorry, we're going to have to proceed with the hearing. We have some additional bills before us this afternoon. Our first virtual witness that we have in the Zoom is Ria Aurora. Good afternoon.
Hi, good afternoon, Madam Chair, Madam Vice Chair, and members of the committee. And thank you so much for giving me the opportunity to testify today. My name is Ria Aurora. Though raised in California, I lived in Maryland for 4 years while attending Johns Hopkins University. While at Hopkins, I spent 2 years as a patient advocate at a pediatric clinic, connecting uninsured Latino families to resources related to social determinants of health. Last year, I moved to Washington, D.C., and am now an AmeriCorps Fellow at La Clínica del Pueblo in the Gender and Health Program. I connect women who are survivors of gender-based violence to community-based resources, legal, and medical services. This year marks my 3rd year supporting Latino communities in Maryland. After my fellowship, I will attend medical school this fall. La Clínica del Pueblo is a federally qualified health center that has offered health and community services since 1983 in the Washington metropolitan area, with one location in Hyattsville. Our mission is to build a healthy Latino community through culturally appropriate health services, especially for those most in need. Today, I would like to speak about the lack of healthcare coverage for Latino immigrants in Maryland, as I have witnessed firsthand these adverse consequences. At Hopkins, I remember assisting a 45-year-old uninsured female immigrant when making a dental appointment, having already had several teeth fall out. At La Clínica, I continued to see these disparities with my clients in Maryland, who already deal with the effects of trauma, given that they are survivors of gender-based violence. I am currently working with a 26-year-old uninsured female immigrant experiencing a high-risk pregnancy. In a recent call with the hospital, I was told that because she has no health coverage, a surgery she might need would cost $50,000 to $60,000. Hearing these stories, especially with the potential of this bill, has mobilized me to challenge the status quo and take action by testifying before you all. Today, I respectfully urge a favorable with amendment report of the Senate Bill 365. For the purposes of equity, La Clínica del Pueblo supports an amendment that ensures newly qualified individuals will receive the same subsidy rate as all other individuals under the Affordable Care Act. As an incoming medical student and future physician, I want to practice in a world where patients do not have to sacrifice their rights to healthcare to maintain their quality of life. Thank you for your time and consideration.
Thank you very much. I don't see any questions, so thank you for your testimony.
Thank you.
We'll now go to Kate Sugarman. Good afternoon.
Hi, good afternoon. I'm Dr. Kate Sugarman, a lifelong resident of Maryland, live in Potomac, Maryland, and Montgomery County. I'm a family physician working at a federally qualified health center. And I see in real time that when an immigrant patient lives in Maryland, they're almost always denied affordable health insurance, which means that immigrant patients in Maryland who have very common illnesses like diabetes, like cancer, like hypertension, often can get sick and are at risk of death, and some do die because they can't afford their treatment. The DC government figured out decades ago how to cover immigrants without insurance. They have a plan called DC Healthcare Alliance. So my DC immigrant patients can get their insulin, they can get their chemotherapy, they can get their dialysis, they can get what they need to live. But an immigrant patient in Maryland Maryland cannot get what they need in order to live. And it's just, and that means that they end up in the emergency room and they end up with premature death. So I urge everybody in this hearing to approve SB 365, access to care. It's a matter of life and death. And thank you so much.
Thank you very much. And we will now, no questions for this witness. So thank you for your testimony. We'll hear from Matthew Lopez.
Thank you. And thank you for this opportunity to provide testimony in favor of SB 365 on behalf of the National Immigration Law Center, where I am an attorney and Deputy Director of State Advocacy. We are an organization exclusively dedicated to defending and advancing the rights and opportunities of low-income immigrants and their families, and one of the nation's leading substantive experts on immigrant eligibility and access to federal and state health programs. Consideration of this bill comes at a time of significant momentum on state expansion of health coverage, in no small part due to the pandemic. 73% of foreign-born residents now live in a state that offers or plans to offer health coverage to at least some residents, regardless of their immigration status. 40 states, including Maryland, cover lawfully present children and or pregnant people in Medicaid and the Children's Health Insurance Program without any waiting periods. Just these past 12 months have been monumental, as you've already heard. In December, the federal government granted Washington State a waiver to pursue a similar strategy to what SB 365 contemplates, and they will cover individuals up to 250% of the federal poverty level in their state's health insurance marketplace. But they are not alone. Colorado's waiver was also approved, creating a parallel marketplace that is providing 10,000 undocumented residents with health insurance coverage with subsidies up to 300% FPL. Many states now cover older adults and children, regardless of immigration status, in their Medicaid program, and Oregon voters even enshrined access to affordable care for all as a fundamental right in their state constitution this past November. California recently took the groundbreaking step of covering all low-income residents, regardless of status, in their Medicaid program. Advocates and policymakers across the country are looking eagerly at these developments, and my colleagues and I at NELC are constantly fielding questions about how their state can be the next Washington. The federal government approved that waiver because it will, quote, help Washington work towards the goals of improving health equity and reducing racial disparities, important goals that this committee can also pursue. Thank you again for this opportunity.
Thank you very much for your testimony. I don't see any questions from the committee, so that will conclude the hearing on Senate Bill 365. We'll now turn, colleagues, to Senate Bill 496, Consumer Credit, Commercial Financing Transactions. Senator Kramer, good afternoon.
Good afternoon, Madam Chair, Madam Vice Chair. Madam Chair, I have some people that I think are part of a panel. May I have them come up? Great, thank you. Madam Chair, colleagues, Ben Kramer here to introduce Senate Bill 496. I will point out that this is a bill that last year passed off the Senate floor 47-0, meaning that every one of the members of this committee, bar one, voted for it on the Senate floor. And unfortunately, it was passed late in session and ran out of time in the House. So the bill is back, and it is an extremely important bill that will provide common sense regulations for the commercial financing industry. The commercial financing industry has sprung up over the past couple of decades and has been largely unnoticed until recently, and is almost entirely unregulated and abusive in its lending practices. This industry provides financing to small businesses, our community mom and pop businesses. They have designed their business model and lending practices to skirt existing lending laws, both at the state and federal level. There are some good actors within this space, and in fact, the good actors will be here to testify in support of the bill because they are put at a disadvantage by the ones who do skirt the laws. Many in this industry make cold calls with aggressive sales tactics and offer misleading information in an effort to lure small businesses into accepting deals that are too good to be true because they are too good to be true. Many of these companies are the payday lenders of mom and pop businesses. Colleagues, our legislature banned payday lending to consumers in our state years ago. The loans these companies make typically include extremely high interest rates, 100, 200, 300% interest. It also allow the lenders to seize the assets of the small business owner with little or no warning should the borrower fall behind on their payments. The Federal Reserve several years ago conducted a study of these types of lenders and raised significant red flags about the frightening and dangerous practices of this industry. Similarly, a few years ago, Bloomberg did an extensive investigation into this industry and exposed the predatory and abusive practices of these lenders. And the fact that, unsurprisingly, our minority business owners are disproportionately adversely affected. Colleagues, this bill will replace the Wild West reckless lending practices that currently exist in the commercial lending world with a well-regulated regime that is identically modeled after the regulations that have been adopted by New York and are very similar to those that were adopted last year by California. The bill before you simply provides disclosure requirements for commercial financing to ensure that small businesses have adequate information from commercial lenders to ensure that they can make the best decision about their borrowing and not be taken advantage of. The bill defines the types of commercial financing that are covered. It clarifies which types of financing and entities are covered and specifies that it applies to lending under $2.5 million. Once again, squarely targeted at our small mom and pop businesses. It requires that the lender disclose the annual percentage rate, APR, just as California and New York are now requiring. The bill requires that all fees and extra charges that are being included, as well as the interest rate, be disclosed. The bill requires an acknowledgement that the borrower has actually been provided the disclosure information. Finally, the bill provides that the Commissioner of Financial Regulation adopt regulations that are substantially similar to those of New York. Colleagues, the evolution of the opposition to this bill has been as follows. When it was first introduced, this bill would have banned the practices that this industry does altogether, just as we did with payday loans. The industry came to the table and said to the committee, no, don't ban us, regulate us. We get it. We're Wild West. We need to be regulated. So please don't ban this type of lending. regulated. Colleagues, I listened to the industry. The next year I came back with a bill that would put in place regulations, and it would have also put a cap on the amount of the interest that the industry could collect. The industry came to the table and said, no, we don't want a cap. And by the way, if you regulate us, we're going to have a patchwork of regulations here in the states. We're going to have one state doing one thing, another state doing another thing. So now regulation became a problem. And they pointed to this patchwork being the core issue. So colleagues, the bill before you this year is modeled identically to that of the state of New York, which has in fact adopted its regulations. That's why the bill this year specifies that if there are little tweaks that have to be made, they have to be made keeping New York's regulations as the model. And by the way, just like in New York, California has almost the identical regulations that New York has because they worked hand in hand between their regulators. And New York has an annual percentage rate requirement. California has an annual percentage rate formula requirement that is exactly the same in the bill before you. So when the industry comes up now, and I have no idea what this year's woeful tale of logic for not being able to do this will be, but the fact of the matter is, if they want to compete in the marketplace in New York State and in the fourth largest economy on the planet, California, then they will be able to do exactly what we're requiring here in Maryland. So I look forward to further discussion when the opposition does come up. And but the fact of the matter is, colleagues, this is about honesty and integrity in lending to our small mom and pop businesses and giving them a chance to be treated fairly in this marketplace. So once again, I ask that the committee give it a favorable report as it did last year, and look forward to it once again passing off the Senate floor 47-0. With that, thank you, Madam Chair.
Madam Chair, honorable members of the Senate Finance Committee, for the record, Kaylee Locklear here on behalf of the Maryland Retailers Association in support of this very important piece of legislation. As you just heard over the past, I think it's 4 years now, we keep hearing from opponents that we need to mimic or we need to wait for specifically New York to act on this issue and to not ban, restrict, or cap, as you just heard from the senator, this issue. Well, guess what? That's the bill that's sitting before you today. And I think what's important to understand is the remaining lenders sitting behind us who continue to stand in opposition and intentionally keep doing anything and everything that they possibly can to stand in opposition, including offering bills in other states that do not include APR, are being disingenuous about this issue. But now that California and New York have moved their laws and their regulations that are, like the senator said, almost identical, there is no valid argument to block the basic transparency that is outlined in this bill. Businesses have been suckered in for far too long. They're completely unclear about what they're getting themselves into with what truly appears to be a quick and easy loan. I wanted to read from the New York regulator's press release because she really gets to the heart of the issue. She states, clear and easy to compare disclosures are paramount to entrepreneurs and small businesses evaluating financing. The new regulation aims to improve fairness and transparency in the financing process so businesses can effectively evaluate and choose the best offer before them. Just like payday lending, predatory commercial lending is impacting and taking down small businesses in your districts. And this bill is one small step in helping them understand what these loan products are. Thank you so much.
Hello, members of the Maryland Senate Finance Committee. I am very grateful for the opportunity to sit here in support of Senator Kramer's bill concerning commercial financing transactions. My name is Joshua Miller, and I'm the Vice President of Research and Policy at Axion Opportunity Fund, the leading nonprofit CFI lender providing access to coaching, networks, and capital to underserved entrepreneurs across the nation. To date, we have deployed nearly $1 billion to nearly 25,000 entrepreneurs across the country. And 90% of our clients are women, people of color, and people who have low to moderate income. We are currently expanding our access to capital here in Maryland, already deploying $2 million up to 100 entrepreneurs, again, majority of which are Black-owned and women-owned small businesses. As founding members of the Responsible Business Lending Coalition, we are in support of this bill because it extends truth in lending protections to the small businesses that we serve daily. All this bill does is ensure that small businesses are told the truth about how much it would cost to access financing through annual percentage rate, the APR. And we believe that Black small-owned businesses are being targeted by non-bank lenders with terms such as simple interest rate and factor rate. And what we found is a factor rate of 1.1 is really hiding a 70% APR. We conducted a research report that found that the average APR was 94%, stretching as high as 350%. We believe this is unacceptable and unjust, that these products are designed to take advantage of communities such as Black-owned small businesses and people who have already been locked out of traditional financing. Therefore, I encourage you to pass this bill by requiring the disclosure of APR as soon as possible to protect our underserved entrepreneurs in this state. Thank you.
Thank you, Madam Chairman. Robert Anton, on behalf of the Maryland Bankers Association. We've come to the table every year to support this bill. This is a totally, completely unregulated lending business. Banks are regulated by, if you're a national bank, you're regulated by the Office of the Comptroller of the Currency. You may be regulated by the Federal Reserve. You're regulated by the FDIC. If you're a state charter bank, you're regulated by the Commissioner of Financial Regulation in the state of Maryland or their counterparts in another state. This is totally unregulated. You've heard when you try to back out, and it's not easy to do, to figure out what the APR is on this type of loan, you see what the problem is. For small businesses, what's wrong with telling them what the interest rate is? If you look at one of these documents, you will have no idea whatsoever what the interest rate is that you're paying. And how do you compare it to any other loan if you don't know what the rate of interest is? By shuffling the deck and coming up with a different system to advance money to small businesses, and at the same time hide what the cost is going to be for the small business, we just can't possibly think that that's the right way to go. This industry needs to be regulated. We'd urge you to pass the bill as you have done in the past. Thank you very much. And thank you for letting me come to the table. I apologize for being late.
Thank you. I don't see any questions for the sponsor of this panel. Thank you very much for your testimony.
Madam Chair, if I may quickly, there is an amendment coming. Mr. DiPietro will be coming to the table, I think, to discuss it. I forgot to mention that in my comments, so thank you.
Thank you. And Mr. DiPietro, I have you on the list next, so you might as well come on up. Thank you all very much.
Good job.
Good afternoon.
Good afternoon, Madam Chair, members of the committee. My name is Chris DePietro. I'm here on behalf of Fiserv. Fiserv may not be a name that you know, but I can guarantee you that you've interacted with our merchants. We are the ones who have the Clover Merchant Terminal. You've probably seen it in a lot of small businesses in your district as well as large businesses. That we are a merchant processor, which means we accept electronic payments, both debit and credit card payments on behalf of the merchants that we serve. So we are here in support of this legislation, and as Senator Kramer indicated, there is a small amendment that actually further conforms the bill to make sure it is like the New York legislation. So I had offered this amendment to the senator and to committee staff. So it should be, I didn't put it into the written testimony, but I know committee staff does have it. I sent it by email yesterday, and both to the senator. I think one of the differences I want to get across to the members, we only provide this Clover Capital product, which is this merchant cash advance, to our customers. So we just don't, you have to be a Clover or a Fiserv customer merchant to actually avail yourself of this product. So we are a closed system. So we know our customers, we know what their cash flows are, we know what their daily merchant, we have a lot of insight on their businesses. So it's unlike some of the other business models that you might hear about from some of the folks that will follow me. So we are, in short, here in support of the legislation with the amendment. I'm happy to answer any questions.
Thank you very much. I don't see any questions, so thank you for your testimony.
Thank you, Madam Chair.
We're going to call forward Frank Boston, Caitlin McDonough, Catherine Fisher, and Patrick Siegfried.
I think Frank is across the hall.
He's right behind you.
Oh, sorry. Oh,
Just ran
amazing.
in.
Hope the rest of us goes out well.
All right. You can go ahead and proceed. Thank you.
I'm gonna go first. Let me go first. Sure. Madam Chair, can Kate Fisher go first? Okay, good.
Thank you, Madam Chair. My name is Kate Fisher. I'm a partner with the Maryland-based law firm Hudson Cook, and I represent the Revenue-Based Finance Coalition. We are a nonprofit group of responsible finance companies that provide financing to small and medium-sized businesses. The Revenue-Based Finance Coalition opposes this legislation because it will mislead our customers. We support disclosures that tell our customers the cost of capital, including the total dollar cost of capital, instead of APR. And I submitted as written testimony a recent report from the Florida State Hispanic Chamber of Commerce explaining that APR is misleading when applied to revenue-based financing because revenue-based financing transactions do not have a fixed payment term. An APR calculation considers the interest charged, the required payment schedule, and the term of the loan. In a revenue-based financing transaction, there is no interest charge and there's no required payment schedule and no term. As a result, the APR calculation will be made up of guesses and estimates. And in fact, it's termed estimated APR is applied to revenue-based financing transactions. This will not result in a helpful disclosure to our small business owner customers. And requiring financing providers to give a disclosure that they know will be wrong creates significant litigation risk. There's ongoing litigation in California right now regarding this very issue. Finally, the Uniform Law Commission, which is the body that drafted the Uniform Commercial Code, has recently formed a study committee on commercial financing disclosures to determine whether a national uniform law on commercial financing disclosures is needed. The Uniform Law Commission is made up of lawyers from across the country, including a 3-member delegation from the state of Maryland. We respectfully ask the committee to allow the Uniform Law Commission to complete its study before passing legislation that may harm Maryland small businesses. Thank you.
Madam Chair, members of the committee, I'm Frank Boston III. I'm here today on behalf of the Small Business Finance Association and the Revenue Based Finance Association, and we respectfully oppose the bill as drafted. We support disclosure, we support licensing, but we can't support disclosure of the APR in this instance. It will be misleading and somewhat unworkable. I want to talk about an example. You have a merchant who's doing well, a deli, okay? And they're doing so well, they want to add another meat slicer. But they need the cash flow immediately to get it, to buy the machine. So let's say they borrow $5,000 from one of my clients, bless you. They agree to pay back an extra $500. I'm just using round numbers for the interest. Keep in mind, this is a fixed amount. It's important to know that that $500 interest is not going to change. My clients get paid from the receivables of the deli. We get a percentage. If the deli decides to pay this off right away within a month, let's say, then the APR is going to be crazy high. But if they pay it off in 6 months to a year, the APR is a lot lower. Therefore, it's not a good measure to disclose APR because it's actually misleading. And remember, the amount is $500. It's fixed, whether you pay it off sooner, whether you pay it off later. It's the same amount. You know what it's going to be. And our clients like knowing what it's going to be. One last important point is this bill allows quick access to capital. Traditional loans for bank sometimes take longer. Our clients need money right away sometimes.
Good afternoon, Madam Chair and members of the committee. Caitlin McDonough here in respectful opposition to Senate Bill 496 on behalf of Rapid Finance. They are a Maryland-based finance institution that provides both traditional commercial lending and more innovative products like the sales-based financing at issue in this bill. I'm skipping most of my testimony because the previous two witnesses went over a lot of it. But again, we're not opposed to disclosure. We're not opposed to regulation, and we haven't been in that position in other states. What we've said I couldn't believe it was 4 years that this bill has been before the legislature, is that APR is a troubling metric for us because of the nature of the product. It doesn't have the fixed term. If we were to follow the formula outlined in the bill to provide the APR disclosure, one, we can't really be absolutely sure of its accuracy. So it puts us in a difficult position where we're telling our customers, our clients, something that may or may not be accurate or true. And it just doesn't accurately reflect what the product is. And that's what we found in this, I think at least 3 to 4 other states that have passed legislation that does not have APR as the metric. So, that's one thing. And then the only other thing I'll kind of talk about our client base, the customers that we do provide these products for, is I do feel like there is a narrative that they're failing businesses or that they're in trouble for some reason. As Mr. Boston, reflected on, often they are businesses who are growing, who are seeking capital so that they can invest back into their businesses and increase their revenues so that they're in a position to pay back this type of financing quickly, under a year, short-term financing. So, it really is not accurately reflected by that annual percentage rating. Patrick's here in-house from Rapid and can speak to, our business model and I know we're going to get into it. So thank you.
Thank you. Good afternoon, Madam Chair and members of this committee. My name is Patrick Siegfried. I'm in-house counsel for a Maryland-based small business finance provider called Rapid Finance. Founded in 2006, we've been headquartered in Bethesda the entire time. Again, all of my colleagues have already kind of covered the issue and the details in relation to the difficulties of APR and some of the issues that the industry has encountered trying to implement some of these regulatory regimes. What I wanted to actually highlight was how critical of a time this is for small businesses in the country to have access to working capital. The EIDL loan program, the PPP loan program were incredibly beneficial to small businesses across the country. And it's thankful that we had that program to save some of these small businesses. Those programs are no longer existing. And a lot of these businesses are trying to get back on their feet and start up again. And we've seen an incredible amount of demand from the market for our products. And if there's a complaint that our industry gets,
And the major one is that we are unfortunately not able to serve everyone, not able to serve every small business that comes to us for financing. But as a result of the California regulations and what we'll see in New York is that there's commercial finance providers are starting to exit the market. I've spoken with a number of colleagues at other companies that do this type of financing. And because of the complexity and the issues that were just highlighted, they've decided that they can no longer do business in California and maybe ever again. So they'll pause and see what happens, likely to occur in New York. Lastly, I'd like to highlight that Rapid Finance is supportive of disclosure laws and licensing. We have supported disclosure laws and licensing bills in other states. Our concern now actually is just uniformity across the states. We are a national lending business, and to the extent that there's inconsistencies across the state, and increase our compliance costs and increase our costs to our customers. And at the end of the day, we're just trying to serve small businesses. Thank you.
Thank you very much. We'll go to Senator Guile, followed by Senator Kramer.
Thank you, Madam Chair. I think this question is for Ms. Fisher. You had mentioned that the Uniform Law Commission has created a study committee to conduct a review, I guess, of the UCC and whether or not something needs to be addressed on this issue. Has there been any indication from the commission as to how long that study committee was going to take, when we may hear back from them on any recommendations?
That's a good question. I've not heard on this specific committee, study committee, but my understanding is that it takes about a year because they need to make sure that stakeholders have a chance to come and testify. And they will do a pretty exhaustive survey of businesses and the different state laws. So I anticipate it will take a year until we know the recommendations.
And thank you. And then I see you said it was recently created. How recently was it created?
It was created, the study committee was created just in the past couple of months. So they're just getting rolling. Okay. That's part of why I built in the year timeline.
Okay, thank you.
Thank you. Senator Kramer.
Madam Chair, and I guess we'll come back to it. We'll come back to our video Zoom people, right? I think they're okay. Perfect. Thank you. So Ms. Fisher, once again, we now are aware of what the latest stall and delay tactic is, that somehow there will be federal action perhaps taken because there's a new study group that'll look at this. And I mean, we might be back here a year from now and you'll be there saying, oh, but the study group still hasn't come to a conclusion. So maybe we need to wait another year. And during that time, the small vulnerable business will continue to be victimized by an unregulated industry. So you indicated that passage of this law would be misleading our small mom and pop businesses. That was your quote, misleading customers. In California and New York, are the customers there being misled, ma'am?
Thank you for that question, Senator Kramer. So the New York law has not yet been implemented. It's effective August 1st. So I can't speak to what customers see in New York. I can speak to California. And to the extent applied to revenue-based financing and factoring products, which do not have a payment term, the estimated APR disclosure is misleading. It is based on a series of guesses and projections about what might happen with the business's revenue. So my answer is yes. Now, one more thing.
The fourth largest economy in the nation, on the planet, fourth largest economy on the planet, has taken a position where they're going to allow their small mom and pop businesses to be misled. That's your assertion? If I
may,
correct.
APR is a very controversial disclosure. 2 states have adopted it. You're right. California,
which 2 states?
California and New York, and the California law sunsets the APR disclosure January 1, 2024, because the state was not sure if annualized rate disclosure was a good idea. So that APR disclosure in California on the books sunsets in a year.
May sunset, and New York, in fact, has no sunset. Is that correct?
That's correct.
Thank
But New
you.
York has not yet implemented the law.
And they will be August 1st.
That's right. There's an August 1st implementation date.
Thank you. And they'll be misleading, I guess, New York's government officials decided that it's appropriate to mislead their small mom and pop businesses because they have APR. In fact, they've got the identical APR that's in this bill here before us. Is that correct?
As applied to transactions without a payment term, correct?
Perfect. Thank you, ma'am. Mr. Siegfried, good to see you again this year. Question for you. What is the Owen Piano Company?
I'm not familiar with that company.
You're not. Are you familiar with Pendleton Rodeo Lanes?
Doesn't sound familiar.
Doesn't sound familiar. How about El Pueblito Meat Market?
Do not recall that.
Woodland Vintage Lumber?
Nope.
I've got pages after pages after pages with names, sir, that show up right next to yours on the Maryland Judiciary case search. You have filed suit against every one of these businesses that you contracted with, that you said you're providing this important business that provides access to products that are important to small business owners. Sir, you have sued so many people to collect on those loans, you don't even remember any longer the names of the companies that you have filed suit against. I will share with you that on the judiciary case search, there's 20+ pages of lawsuits that you have filed. It says displaying 500 items. And so when you come before this committee and you're just telling us about this important product and this great service that you're providing to these small businesses, do you think perhaps they might have a different perspective after they get trapped into loans that they realize later on they can't afford? And evidently, you don't hesitate to go in and file suit to seize their assets. Do you think maybe the small business owners you claim to be benefiting might have a different perspective on that? Looking at over 500 lawsuits, so many you don't even remember the names of these small business, these small entrepreneurs, these mom and pop businesses that you have gone and filed suit against. You think maybe they have a different perspective on the value of your product?
I completely understand your point, Senator Kramer. Any lending business is going to have collection actions to mitigate the losses and in order to control prices to their new customers. To the extent that we weren't filing collection lawsuits and allowing losses to rise up, we wouldn't be able to provide any financing to any businesses. And I don't think that's a good outcome.
And if I may, Madam Chair, just to note, as we said in our initial testimony, Rapid Finance is based here in Maryland. So any suit we file in Maryland. Oh, excuse me, any suit we file in Maryland. And Patrick, as our chief legal officer, is on all of those suits. So this would be, I don't know the exact percentage in front of me, but it would be a small percentage of our overall national business base.
And
So-
I've worked for the company for
Yeah.
12 years. So we have filed lawsuits in the past. As any
Pages
other-
and pages and pages
Every
of-
other financing
of
company. would have
small
the same
mom and pop businesses shut down and put out of business because they were lured in to financing that they couldn't understand, and then they couldn't pay. And then you slammed down the hammer to take their assets from them. Thank you, Madam Chair.
Thank you, Senator. All right, I see no further questions from the committee for this panel. Thank you very much for your testimony.
Thank you.
We have one additional in-person witness, Amy Hennon. You can come forward and then we'll move to our virtual witnesses. Good afternoon.
Good afternoon, Madam Chair, members of the committee. I am Amy Hennon. I'm with the Commissioner's Office of Financial Regulation. I signed up to testify today because the Commissioner himself needed to be in another committee. Fortunately, the Commissioner is now here, and I would request that the Commissioner be able to substitute for myself.
All right, the committee says yes.
Thank you.
That was a quick vote.
Thank you, Madam Chair, Madam Vice Chair, members of the committee. We signed up to provide information because this is a complicated bill. You've heard, pros and cons on the bill, and if there's any questions from the committee that we might help you with regarding our office's implementation of the bill, happy to provide that information.
Hey, Senator Beidle.
Thank you for being here. So I understand this difficulty in calculating the interest rate. And I happened to be on a bank board that was doing construction loans. And so the draws come at different times. And we were using software to calculate the interest rate, the APR. And the OCC came in and smacked us and said we didn't have the right calculation, even using software. So my question is, not that I don't like the bill, but my question is, how difficult will it be for them to really calculate a true APR?
Well, they'll have to follow what's required in the statute and the regulations that our office will issue. So in theory, they can operationalize that.
Okay. So there might be software to do that, or?
I would think. I'm not sure how the industry would do it. It's a new program for our office because we regulate consumers. So if the legislature passes it like it did last year and it goes through the final hurdle, then this would be a new program for our office. So there is, as you point out, software, APR software on the consumer side. I'm not sure on the commercial side. So that may need to be developed but typically you follow the calculations that are set out in the law for the regulation.
Which are tricky, but thank you.
They are, but
And Senator, if I may, the bill does.
I'm finished. Thank you, Madam Chair.
Senator Kramer.
No, I was just going to point out to the senator that the bill does have, with specificity, the two formulas that the lenders can adopt for doing the calculation, and they are the identical formulas to those that New York adopted as well. So I just want to point out it's in the bill, how it'll be done.
Thank you. Senator Mounts.
Thank you for being here. Just a quick question. How does this bill differ from other regulations that are in place for this industry in other states? It was mentioned that other states have some sort of rules or regulations for these transactions. Could you explain how this bill is either similar or how it's distinctive from other regulations currently in place in other states for these business transactions?
sure. So I guess at the highest level, you heard the testimony before where some states, New York and California, have adopted bills regulating lending to small businesses requiring disclosures of APRs. And then there's bills in Utah and Virginia which have passed but do not contain that requirement. So I haven't looked in depth at the Utah and the Virginia bills. I believe they contain some of the similar provisions here other than the APR provision. As the senator mentioned, this is modeled on the New York bill, which they just passed their regulations now. So, that's that. And I think it's a little different from California's, which has just been operationalized as well.
Yeah, so New York has put a law in place, but it does not mandate an APR?
No, New York is one of the two states. New York and California do mandate APR.
They do.
And as the law says, they're required to issue regulations. New York worked for a while to draft the regulations. Then they issued them on, I believe it was February 1st. And the regulations are going to go into effect in August.
Which states have regulations? New York and where?
California.
New York, California. Thanks.
Okay, thank you very much. I don't see any additional questions, so thank you for getting in and participating
Thank you,
in the
Madam Chair.
hearing.
Appreciate it.
Very good. We're going to turn to Awesta Sarkash. Good afternoon.
Good afternoon. Thank you so much, and perfect pronunciation of my name. So thank you, Chairwoman, members of the committee. My name is Awesta, and I'm the Public Policy Director for Small Business Majority, a national small business organization, and I also serve on the executive committee of the Responsible Business Lending Coalition. Thank you for the opportunity to discuss this bill. Let me first say, we have seen no evidence that lenders have actually exited the market in California. Let me also say that other states that the opposition mentioned that passed bills that they supported, guess what? They don't include APR disclosure because the opposition lobbied to remove it. There are states across the board, thankfully, that are aiming to pass true transparency for small businesses, and Maryland should be one of them. While California and New York are the only two states that have mandated APR, plenty of other states are attempting to do the same, because in reality, you cannot support small businesses without appropriate disclosure, and appropriate disclosure must include APR. I highly doubt the opposition searches for credit cards and doesn't look at the APR. So why are they expecting small businesses to do the same? The legislation provides transparency about the lending product, tells the online lender how to calculate APR. There's literally two formulas, Senator Kramer mentioned this, and what to disclose to the borrower. Small businesses are not financing experts, so shouldn't we support them? APR is the only metric that enables an individual to make an apples to apples comparison among financing products with different fees, interest, and term lengths. For the typical small business owner, it's really difficult to analyze and compare the relative costs. We talk to small businesses every day and they tell us this, so we really need this bill to pass, and it must include APR disclosure. Small businesses today are often overpaying for financing, sometimes with devastating results for the small business. You're going to hear, and you have heard from the MCAs that they can't disclose APR and they can't calculate it. That's incorrect. MCAs provide plenty of MCAs already disclose APR, and so I urge you to pass this bill. Thank you.
Thank you very much. I don't see any questions from the committee, so thank you for your testimony. And that will conclude the hearing on Senate Bill 496. Colleagues will now turn to Senate Bill 307, Financial Institutions, Mortgage Loan Originators, Independent Contractors. Vice Chair Klaus Meyer. And you can feel free to bring up your panel.
Good afternoon, Madam Chair, and the rest of our wonderful committee. Senate Bill 307, Financial Institutions, Mortgage Loan Originators, Independent Contractors. Senate Bill 307 would simply codify that an independent contractor can be licensed in Maryland as a mortgage loan originator, an MLO. This will bring clarity to MLOs and mortgage companies and provide much needed flexibility to both. Some companies employ their MLOs as W-2 employees. It is important to note that this bill will not impact these employees, nor does it impact existing labor law. This bill only aims to clarify the law as it applies to mortgage companies that contract to an MLO as an independent contractor. We often think of as 1099s. Current law and guidance provide for taxes to be withheld on behalf of these contractors, despite them largely being independent. This creates an undue burden on both mortgage companies and MLOs. It leaves a mortgage company having to guess the likely tax burden of their 1099 MLOs, while leaving the MLO with a determined withholding that may be widely different than what they need. A 1099 MLO may have other income sources or expenses that may not be known to the mortgage company, leaving the mortgage company in a poor position to predict tax burdens. This is not a radical change. 39 states either have similar statutes or do not explicitly prevent independent contractors from being licensed as MLOs, including our neighbors in Pennsylvania, Delaware, Virginia, and West Virginia. As I said earlier, this bill does not make a substantive change to labor law, nor is it directly impact customers. The legislation also leaves strong consumer protections in place, as all MLOs can only perform origination services for one license. Overall, Senate Bill 307 will add clarity to the statute without harming consumer protections or regulatory oversight. So with that, I would just like to say I would appreciate the bill. So.
Madam Chair, members of the committee, my name is Chris DePietro. I'm here today on behalf of Rocket Mortgage. I just want to set up the issue. I think the senator did a fine job in explaining what the bill's purpose is, but I want to set up why we are where we are. Back after the 2008 mortgage crisis, this General Assembly acted appropriately and strengthened the mortgage lending and mortgage origination statutes. In doing so, they created this an MLO, a mortgage loan originator. MLO is an individual. So if I were doing this, the license would be in my name, Chris DePietro. So it doesn't go to a business, it goes to the individual. That individual can act as a W-2 employee, or it could act as a 1099. So, but what happened in the law when it was passed, they created this proxy that said that you must withhold taxes from the MLO's pay. So that proxy was to ensure that there was a one-on-one relationship between the mortgage lender sponsor and that MLO. And that's for oversight purposes. You want to make sure that the MLO is acting in unison with that lender, complying with all the regulations of the state, as well as the policies of the mortgage lender. So what happened in 2021, we had this situation. We have a relationship with State Farm Insurance where those the insurance agents that are associated with that institution could also act as an MLO. So, but in that scenario where they're acting as an independent contractor, because they have their primary businesses to sell insurance, but they do offer this product through to their own customers. So this creates a problem for us where we had to start withholding taxes out of the pay that we were paying these individuals. So what this bill does, in short, takes away the need for the guidance that the Commissioner of Financial Regulation put out in August of 2021, and just codifies it and allows MLOs to be licensed as independent contractors. So with me today is Michael Stedham, who is the Director of Regulatory Affairs for Rocket Mortgage. He'll talk a little bit more detail about the bill. Thank you.
Good afternoon, Madam Chair and members of the committee. Rocket Mortgage appreciates the opportunity to offer testimony in support of the proposed amendments to the Maryland Code, which will provide clarity and the conditions that an independent contractor may be licensed and sponsored as a mortgage loan originator, otherwise an MLO. Under Maryland's current code, mortgage licensees are only able to sponsor MLOs who have taxes withheld by the sponsoring licensee. Typically, this type of tax withholding would indicate a traditional W-2 employment tax status. However, based on the code's current vague language, companies looking to sponsor independent contractor MLOs must again withhold the taxes on these independent contractors' earnings. And this goes against the spirit of an independent contractor arrangement, which generally provides flexibility on those tax earnings and filings, including allowing independent contractors to anticipate their tax burden and withhold how they see fit. For small business owners, taking the taxes off the top of the earnings doesn't allow them to reinvest these funds into the business throughout the year. This common sense change will help keep these tax dollars local and accessible to these small business owners. As noted earlier, currently there are 39 states that allow sponsoring of independent contractor MLOs, and only Maryland requires tax withholding for those independent contractor MLOs. In addition, HUD previously did require MLOs to be W-2 employed, but revised their stance back in 2019 to the mortgagee must report all employee compensation in accordance with IRS requirements, thus including the 1099 in that. So in sum, we appreciate the committee's leadership on this matter, and I urge a favorable report on Senate Bill 307. Thank you.
Thank you. Senator Ellis.
Thank you, Madam Chair, and thank you, Senator, for this bill. And I have just a question as far as with independent contractors versus employees. I know there've been a lot of lawsuits across the country with so many people who work as independent contractors, including rideshare folks. And it's hard to really approve independent contractor status because you have, of course, supervision. You provide them with direction, with rules about, you know, your products that they are moving and their work hours. And there's just a tremendous amount of rules that you have to kind of meet in order to really verify that someone really is an independent contractor. So, I mean, do you experience that in your industry as far as those lawsuits tapping on your door saying these folks are not necessarily independent contractors, or a lot of them that want to be employees?
Well, Senator, that's an excellent question because we contemplated that very scenario that you laid out as we were drafting this bill. We want to make sure that it was very surgical in its approach, that it only dealt with this tax issue. And if I refer you to the section 2 of the bill, which has uncodified language that says that this bill does not impact any existing labor law as it relates to independent contractors. So our goal here is not to affect existing law and some of the sensitive nature of the relationship between certain employers and certain independent contractors. We're not trying to wade into that at all. So we were very clear that we steered clear of that by putting that section 2 in there. So hopefully that answers your question.
Yeah, it does.
Thank you.
Thank you.
Thank you. I don't see any additional questions for the sponsor of this panel, so thank you very much.
Thank you.
Thank you.
We
Thank you.
have Richard Green signed up in opposition to the bill. Come on up. Good afternoon. And after Mr. Green, we'll hear back, I believe, from the commissioner or Amy. Okay. All right.
Good afternoon. Thank you to the committee, Madam Chair and Madam Co-Chair, for allowing us to share our testimony today, both written and oral. I want to introduce myself. My name is Richard Green. I am a past president of the Maryland Mortgage Bankers Association and current co-chair of the Legislative Committee. I've been in this industry for 46 years. I've seen the good, the bad, and the ugly. We don't ever want to go back to the ugly. We want to maintain the integrity of this business, and we feel that we can do that under the current situation that we live with. We want to thank the state of Maryland for imposing the consumer ability to repay requirements ahead of the federal government back in 2008. This created, amongst other things, the need for constant training within the industry. When a borrower obtains a mortgage loan, it is the biggest financial transaction likely that they'll ever incur in their life. They need guidance, they need professionalism, and we respectfully request that it continues the way it is. If we fast forward to 2023, training remains our #1 priority for licensed lenders. It will protect the consumer and it will protect the lender from maintaining their license. If you have an employee, the status of that is that there is a bond there, and that bond can't be replaced as an independent contractor. An independent contractor is not a fully dedicated professional mortgage banker. It is a side hustle. And this is too big a transaction to not be a full-time dedicated professional in the industry. We see it differently. We see that HUD FHA does require that you be a full-time employee and therefore get compensated by W-2. There's no benefit to anybody as a Maryland consumer in changing this, and that is because the only one that wins is Rocket Mortgage in this case. who doesn't have to pay Social Security on behalf of their clients. It does not benefit the Maryland consumer. It's too complex, process. And so we unanimously at the Maryland Mortgage Bankers Association oppose Senate Bill 307 for those reasons.
Thank you. Senator Ellis has a question.
Yes.
Yeah, thank you, Madam Chair. So, sir, listen to your testimony. Your perspective is very interesting. So if you have someone who worked in the mortgage business at your bank, Prudential Bank, for many years, 30 years, decided to go out on their own, be an independent contractor, are you saying they can never do a good job?
No, but I'm saying they could comply with Maryland licensing regulations and get a broker's license, which is a different set of rules than just saying you can be a independent contractor.
Okay, well, that's another, you took it to another level.
Well,
Which I won't go there with you, but
I
thank you for the
understand.
answer, Madam Chair.
I understand.
Thank you. Are there any additional questions for this witness? Okay, thank you very much for your testimony. We had Amy, are you coming or the commissioner or?
Madam Chair, I would request that the commissioner be substituted.
Fair enough, we'll accept that. Good afternoon again.
Good afternoon, Madam Chair, members of the committee. Again, thank you very much for that courtesy. Appreciate that. We're here to answer questions on the bill. Just a brief comment to Senator Ellis's point. We understand that concern, take it very seriously about the misclassification of employees. And our office issued some guidance, as was mentioned before, back in August of 2021, admonishing institutions that they had to make sure they followed all appropriate labor laws. We view this as a licensing bill so that folks can get licensed as an MLO who, whether they be a 1099 or they be an independent contractor. So that's kind of the perspective there. It frees them up to do that either way.
Thank you. Vice Chair has a question.
Yes, to get licensed, everybody gets the same license. Is that correct? Whether you're independent contractor or if you're working for someone else?
Well, it depends. So you need a mortgage loan originator license right now, but if you're an independent contractor, you need a mortgage lender. You need 2 licenses because you're the independent contractor. So this would eliminate that.
Okay. All right. Thank you.
Yep.
Thank you. Senator Ellis.
Yeah, thank you, Madam Chair. The Vice Chair asked my question. It was answered. Thank you.
All right. I don't see an additional questions. So thank you very much again for your testimony.
Thank you so
And
much.
that will conclude the hearing on Senate Bill 307. We'll now turn to Senate Bill 308, Health Insurance Utilization Review Revisions. Vice Chair Klausmeier, and we have 28 witnesses on this bill, in person and virtual. So just be mindful. You can feel free to bring your panel up.
All right. Maybe I'll stand and we can get more of them up here and then. Okay. Thank you for the opportunity to present Senate Bill 308, Health Insurance Utilization Review Revisions. Over the past few weeks, I've had lots of different doctors come in, pharmacists come in, just to tell me the plight that they have. So I will just reiterate some of them. Last week, I had a physician in my office who told me a story of a patient who had been successfully managed on her medication for manic depression. On reauthorization, the insurer denied the medication. Without the medication, the patient spiraled and the consequences were tragic. She ended up back in the hospital. Unfortunately, this is not an isolated incident, but we are continuing to hear from constituents, friends, and family. According to the MIA and self-reported by the health insurance carriers rendered 81,143 denials in 2021. This is an increase from 78,314 in 2018. The most common denials are in the areas of pharmacy, dental, labs, and radiology services. What is also troubling to me is the fact that when a patient manages to file a complaint with the MIA, 7 out of 10 times the appeal is decided in favor of the patient during the course of the investigation. I understand that health insurance is expensive. We all know that, but we have got to take steps to ensure that the story I heard last week does not happen again. It's a whole lot more expensive to put someone in the hospital than to give them the right medication. Over 50 organizations, including provider organizations and patient advocacy groups, support this legislation. And I read that 42 states are considering legislation this year. To me, this is indicative of a problem that needs to be addressed. I think we can all agree with that. Senate Bill 308 contains what I think are common sense approaches to better manage the healthcare needs of our constituents. And on that note, while it is common to hear about the health insurance cost, we need to also consider the cost to the healthcare systems or social cost when treatments are denied or delayed and patients suffer bad outcomes. Therefore, Senate Bill 308 looks to lessen the burden both on patients and providers by reducing the volume of medications subject to prior authorization. As an example I first gave, the bill will allow a patient to stay on a prescription drug without another prior authorization if the insurer previously approved the drug and the patient continues to be successfully treated by the drug. Senate Bill 308 will also exempt prescription drugs from requiring a prior authorization for dosage changes, provided that the change is consistent with the federal FDA labeled dosage. And it will eliminate prior authorizations for generic drugs or the need for multiple prescriptions due to formulation differences. Senate Bill 308 will also reduce delays that occur when the patient appeals a denial or when the medical necessity is being questioned by the insurer. Number one, Senate Bill 308 will require that the physician making or involved in making the denial is knowledgeable of and experienced in the diagnosis and the treatment under review. I know all physicians respect their colleagues, but it wastes time when a physician conducting the review has never seen or diagnosed a similar case that is subject of the prior authorization. Senate Bill 308 will also require the criteria used by an insurance company is based on known and accepted standards of care. Senate Bill 308 will also require the carriers to reach out to treating provider prior to issuing a denial and not just available for a discussion on the medical necessity of the requested treatment after the fact. Again, we need to minimize delays that can negatively impact treatment plans and schedules. The bill also looks at ways to improve the system through 2 studies. The first study is the feasibility of implementing a gold card standard in Maryland, which would exempt healthcare practitioners who meet certain criteria from prior authorization standards. Other states have begun to do it, and we can learn from their experiences. The second study is how to create better standardization and uniformity across the electric prior authorization systems to make them more user-friendly. This study authorizes CRISP to conduct a pilot program to create a single entry portal rather than each carrier having its own portal or system, which will hopefully simplify the process. In conclusion, I urge everyone to roll up their sleeves and come up with meaningful solutions to the problems that we have all either heard or have experienced. The issues are real, patients are suffering, and we need to address these issues this session. And I would like to add that I have talked to the carriers and I have talked to the folks that are sitting here at the table, and we are all willing to work. We're going to roll our sleeves up and we're going to make beneficial and meaningful changes to prior authorization and utilization. And I hope that we can do that without a problem. Well, there'll be problems, a couple. But I think everyone at the table and every carrier just wants to work to make this whole process work, because no one wants to see someone suffer or end up in the hospital because they didn't have their medication. So with that, I'm gonna let the. Okay.
Thank you very much. For the record, my name is Dana Kaufman, here today on behalf of MedChi and several other healthcare clients. The sponsor, Vice Chair Klossmeyer, did an excellent job of explaining the bill, so I'm not going to reiterate. I just want to make a few points that this General Assembly has made extraordinary efforts to increase access to coverage. And because of that, Maryland's uninsured rate is only at 6%, but coverage does not equate to healthcare services. And having coverage doesn't mean you get healthcare services. And that is really what we're trying to do in this bill, is to ensure that individuals who are paying premiums, very high premiums, have access to that coverage. This is not the first time we've been before this committee trying to relieve the burden caused by prior authorization. For example, in 2019, there was a bill on prior authorization, and in that bill that passed, it required an insurer to honor a prior authorization when the dosage for the approved prescription drug changed, and that change is consistent with FDA labeling. Unfortunately, though, we're still being required to submit it. So what this bill does now is to very clearly say to exempt, if you have to honor it, why are we submitting it? The other issue that we addressed in 2019 really was that reauthorization, and we compromised to say that it was to be for 1 year, but a couple years now has passed, and what we're finding out is that patients are getting denials on the reauthorization. So again, this bill is going back to what we were hoped was the solution, and not requiring a reauthorization when the medication has not changed. We did not take drafting this bill lightly. We did it judiciously. We looked at the issues at hand and we crafted solutions. We didn't try to eliminate prior authorization, which I think would have been the preferred method. But we really did try to figure out how to impact the majority of patients in the best way. I'm going to turn it over now to Dr. Jeffrey Bernstein, who can share his experiences on this issue. Thank you very much.
Good afternoon. I'm Dr. Jeff Bernstein. I practiced pediatric medicine in Silver Spring for 35 years. On behalf of myself and the Maryland chapter of the American Academy of Pediatrics, I'm in strong support of Senate Bill 308. While in some instances, the currently available electronic prior authorization format is functional, it too often is non-productive and results in patient care delays. Being rigidly formatted, it is difficult to determine the triggers or criteria needed for approval of a prior authorization, thus often requiring multiple submissions. These systems don't integrate well with electronic medical records, so any additional documentation must inefficiently be uploaded to these systems. Criteria for prior authorizations often don't correlate to the needs of patients, especially pediatric patients. For example, a commonly mandated inhaled asthma controller medicine is incompatible with the administration devices required for effective use in young children. The prior authorization systems will repeatedly deny the appropriate medication, requiring additional documentation or scheduling a peer-to-peer meeting. Difficult to efficiently arrange, these peer-to-peer meetings are sometimes not even with a pediatrician. More generally, fluidity to reflect real-time changes in diseases, treatments, and recommendations is missing from the prior authorization system. For example, in a recent year, there was an unexpected shift in the season of RSV, respiratory syncytial virus. A sharp rise in cases occurred in May and June before the usual fall-winter season. The American Academy of Pediatrics promptly issued recommendations that at-risk pediatric patients be prescribed Synagis, a preventive treatment against this potentially life-threatening disease. The treatment was indicated for a very young patient of mine with complex congenital heart disease. Despite documented recommendations, there was an approximately 6-week gap of exposed vulnerability between the time of initial request for the medication and actual administration due to denials and requirements for additional documentation. Finally, pediatricians are aligned with the goals of to efficiently utilize healthcare services and resources. And by nature, we're protective of our patients and families, not subjecting them to unwarranted discomfort, risks, and expense. Our practice data are closely monitored by payers for propriety and cost of care. A physician with a documented record of appropriate and cost-efficient care should have their initially prescribed treatments promptly available by a gold card or similar. We believe that the changes in this bill will bring relief to physicians and their patients while Maryland studies how to better improve these systems. Thank you very much.
Good afternoon. I'm Dr. James Chesley. Thank you, Madam Chair, Madam Vice Chair, and committee members. I'm a gastroenterologist practicing in Prince George's County since 1984. I want to give you a vignette of a case that's representative of what I see in my practice and how this bill affects them and why I speak in favor of it. 24-year-old lady was referred to me after being treated by her primary care physician for abdominal pain, weight loss, diarrhea, alternating with constipation. They tried treating, thinking it was probably due to the stress of her getting ready to graduate from college, that she was getting ready to take exams, and she was going to be going out on her own, looking for a job, leaving the family. After those treatments failed, they referred her to me. After going through an authorization to do a colonoscopy that was performed, it disclosed that she had a stricture in her small bowel, which was consistent with Crohn's disease on biopsy. I started her immediately with a prescription for treatment of this, and it was denied. It took us 13 weeks to get her the care that she needed. Once the medicine was finally approved, which I originally asked for, she was better in 10 days. Her diarrhea, alternating with constipation, stopped. Her abdominal pain stopped. She started gaining weight. She went out for job interviews and was hired. Did great. Now, as some of you know, it takes usually about every 3 months that you can give a prescription for before you have to renew it. So we got up on the 10th month time to renew. Well, what do you think happened? Yeah, they denied it. So we go through this foolishness again. She runs out of the medication. Her symptoms recur. She gets abdominal pain. She loses weight. She gets diarrhea, alternating with constipation again. And she's feeling awful. And the way a young lady is feeling with this and her new job and the pressure and missing work, she unfortunately lost that job. After, make this is right, after 13 weeks of arguing with them, but getting the medicine at 5 weeks because her father bought the medicine for her, it was re-implemented. Took a little longer for her to get it back in. And this time she got better in about 2 weeks. It took a little longer. We were very fortunate in her case. She didn't develop antibodies to the medication, which will happen when you break stopping a medication treatment. She also was able to get another job and get gainfully employed because now she felt well and was doing very well. And I didn't even talk about the time and the cost that the practice incurred to get her this medication renewed. So I urge you to pass this bill. Thank you.
Good afternoon. I'm Dr. Erin Morey. I'm a rheumatologist in Anne Arundel County, and I'm here in support of Senate Bill 308. Imagine that your asthma is acting up and you have to wait for a prior authorization for a generic drug such as prednisone. If you don't get it in time, you could end up in the emergency room or worse. I've had prior auth requests for prednisone because it has been labeled a transplant drug by the insurer. This is true, but it's standard practice to use prednisone for acutely for asthma and also for serious flare-ups of rheumatoid arthritis and lupus and other diseases I treat. Delay of prednisone for lupus flare-ups like asthma can result in ER visits costing the system substantially more money, more than $5, which is what prednisone costs. Senate Bill 308 would exempt generic drugs from prior authorization. Likewise, dose changes within the FDA guidelines should be exempt from prior auth. Humira, a drug that requires prior auth, is given every 2 weeks for rheumatoid arthritis.
Some patients need once weekly dosing, which is an FDA approved dose. Even though the drug is already authorized, we must spend time requesting authorization to increase to this FDA approved dose. The staff time could be better spent on chronic care management to reduce ER visits and hospitalizations in my severely ill patients. If the carriers say that utilization review protects patients, then why are 70% of the prior auths overturned when a complaint is filed with the MIA? During the thick of the pandemic, I had a psoriatic arthritis patient with commercial insurance who was obese, older, diabetic with heart disease, whom I prescribed Otezla, which is a drug that does not suppress the immune system. Her carrier denied this drug on appeal in favor of putting her on an immune suppressive drug with serious or more serious side effects, which would put her at an increased risk for serious disease or death associated with COVID. This decision by the carrier did not protect the patient. Instead, this went against common sense and our psoriatic arthritis treatment guidelines. SB 308 will require utilization review to be guided by specialists in the field. It will improve appropriate, timely, evidence-based care and free my staff to provide more chronic care management for my severely ill, immune-compromised patients to keep them out of the hospital. Thank you.
Hello, my name is Benjamin Stallings. I am a radiologist practicing in Prince George's County. I'm in favor of Bill 308. This bill is about ensuring that treatment can be received without delay and jeopardizing care. Please understand that I have trained for 9 years and I've practiced over 30 years in my specialty. My colleagues and I are all well-trained and practice state-of-the-art medicine. We see our patients regularly and understand their needs. Insurance companies try to justify their actions based on algorithms. Algorithms make assumptions which are frequently not applicable. These algorithms spit out suggestions based on a model. Patients are individuals and should not be treated as such. They are individuals and should be treated as such. We can't have a pediatrician denying cancer patient meds. This is unacceptable, wrong, and unethical. I want to give you some quick examples. I do a certain number of procedures that only a few physicians in the state of Maryland perform. A mother of a high executive in an insurance company needed to get one of these procedures done. It was denied by the insurance company. He looked at me angrily and said, "Give me 5 minutes." True enough, 10 minutes later, it was approved. Most patients don't have that access. 50-year-old man with recurrent prostate cancer needed to receive a PET scan for recurrent prostate cancer. This patient appropriately ordered Plarify, which is a isotope specifically for recurrent cancer. This was denied. They wanted a general PET scan. This is not the standard of care, and the insurance employee did not know anything about Plarify and its use for recurrent prostate cancer. Another 42-year-old patient came in with a request for an MRI of the right knee and ankle. The knee was authorized, the ankle was not. The ankle was denied. After receiving a normal MRI report, the insurance company recommended physical therapy. Weeks later, after no improvement, the patient was still in pain. They authorized the ankle. Patient subsequently had an ankle, an Achilles tear. And which required surgical repair. If an ankle of Achilles tear shows up early enough, it can be non-surgically repaired. Just as with any business, there are wrongdoers, and the insurance companies will always trot out these examples and hang them out as a common physician. As you all know, physicians work diligently for the care of our patients. That's our primary concern.
Let's see. Good afternoon, Madam Chair and members of the committee. For the record, my name is David Sharp. I'm the Director for the Center of Health Information Technology and Innovative Care Delivery at the Maryland Healthcare Commission. It is my pleasure to present our testimony on behalf of our Executive Director, Mr. Ben Steffen, who could not be here today and sends his regards. The Commission supports SB 308 with amendments to extend the time to complete the various areas of study in sections 2 and 3, and to delay implementation of section 1 until the studies have been completed to allow for the findings to be considered by the General Assembly. The bill requires the Commission, in consultation with providers and payers and the state designated health information exchange, to develop recommendations to achieve greater standardization and uniformity to ease the burden of prior authorization and other utilization management techniques for patients, providers, and payers. The bill also requires the Commission, in consultation with the MIA, to study the development of standards for the implementation of prior authorization requirements for prescription drugs, medical care, and other service based on provider-specific criteria. The additional time is needed to complete the work adequately and to assess the potential impact on pending federal legislation related to prior authorization. On December 13th, 2022, the Centers for Medicare and Medicaid Services released a proposed rule that aims to streamline the process related to prior authorization, among other things. The proposed rule would require implementation by 2026 and includes requirements intended to reduce the overall provider and payer hardship and improve patient access to health information. The Commission supports the aims of SB 308 in reshaping medical oversight and review by payers, and notes that more time is needed by payers to consider the impact of the bill on existing prior authorization processes and technology systems. The Commission recommends the committee require the Commission, in collaboration with payers, to identify barriers to implementing the legislation and propose solutions as part of the study requirements for the bill. We hope you find this information helpful and encourage a favorable report on SB 308 with the proposed amendments. Thank you, Chair Griffith and members of the committee, for the opportunity to testify.
Thank you. Senator Reedy.
Thank you, Madam Chair. I was listening to this, kind of trying to look through all the testimony, and I think it was Dan, I think it was you talking about this issue that I thought electronic, like doing it through electronic means was going to streamline a lot of this. Some of this happened before I joined the committee, but I've been reading up on this because I'm getting lots of correspondence from all over the place. I mean, why is this not, why isn't it? Because I think the opponents of the bill will talk about doing it all electronic should be streamlined, right? So what's the problem? Why is that not working as well as it should be?
Thank you for that. So I do want to say that Maryland was a leader in the area when we passed the electronic prior authorization bill and its requirements. But one of the things that we didn't do back then was make that system consistent and uniform across all payers. So basically, and I think there is some testimony in your file from an Angela Campbell that will shed additional light on this, but each carrier can have its own system and each carrier can designate its own vendor. So some may use the same vendor. You do have different portals by different carriers. Within some of those portals, you have sub-portals for radiology, cardiology. There's a portal for prescriptions, a portal for healthcare services. So it makes it very difficult to even figure out. I think one of the biggest shortfalls, and I think where we can benefit, is that the current portals don't have interoperability with electronic health records. So when a medical record is requested, which is often is, that cannot be pulled directly from the physician's electronic health record. It has to be printed, scanned, and uploaded into that electronic health portal. So that's why we did the study, because part of that study actually resulted from the language that we used was from a 2011 report that the Maryland Health Care Commission did, where it recommended using a single point of entry like CRIT.
Well, I remember it was a long time ago. I was on the health committee. I remember I thought there was going to be a lot more interoperability. Probably just didn't happen. That's surprising to me that there's not a way to get. I would have assumed that if everything's electronic, then there's a way to just send them the electronic health record, but there's not.
No, it has to be uploaded to those systems, which takes an enormous amount of time.
I'm sorry to interrupt you. Is that because the insurance company can't, is it a security issue, or is it just their systems don't connect?
Their systems don't connect, is my understanding.
Okay. Thank you. Thank you, Madam Chair.
Thank you. We'll go Senator Hershey.
Thank you, Madam Chair. Dana, just to follow up, a number of times the word criteria was used. Can you just explain what that is and what that means?
Sure. So what we have in the bill is criteria. So basically the standards that are in the utilization review law right now basically says that the standards have to be objective, clinically valid, but it doesn't say what those standards have to be. And we have heard, and you heard Dr. Morey And Dr. Bernstein referenced the fact that the recommended standards were not being followed. So for true transparency, we should know what the standards are. So the bill is basically saying that those standards have to be evidence-based, peer-reviewed, and they have to be developed by a professional medical specialty society or an organization under the same specialty. That's not a new concept for Maryland's law. We have 2 instances already where that for hospital services related to maternal and newborn care, when you're deciding medical necessity, Maryland law requires that the criteria be based on the guidelines of perinatal care developed by the American Academy of Pediatrics and the American College of OBGYN. Same is true for substance use disorders. Standards must be based on the American Society for Addiction Medication or Medicine. So we just think that those standards should be built in for every specialty. And then there is a better understanding also of what will be needed to make sure that approvals can be met.
So are the payers opposed to that? I can ask them, but.
Why don't you ask them?
I will. All right.
One has indicated their willingness to work on it.
Okay, good. Good to hear. All right. Thank you.
Thank you. Senator Lamb.
Thank you, Madam Chair. I just wanted to focus on generic drugs because this has come up before with the payers and in the bill, there's an exemption for prior authorization for generic drugs. And what the payers and the insurers will say is that the prior authorization, even on generic drugs, is really important to control costs, while generic drug costs are just a very small portion of overall healthcare costs here in the state. And so I'm wondering if you can further articulate the need for this exemption for prior authorization for generics, recognizing that it does contribute very little to the overall healthcare costs, but it's a huge burden on providers.
Thank you. And you're right. I actually was listening to the Prescription Drug Advisory Board, and they made a reference to a report. So I read the report, and I was surprised about what it said. It basically said that generic drugs represent only 4% of the overall healthcare spending. And as a result, the changes in generic costs are not likely to significantly impact insurance premiums. Maryland, and this was specifically for Maryland's fully insured market, the report said generics represent 84.8% of all prescriptions filled in Maryland, accounting for 18.5%. So we are encouraged to use generic drugs, but we're still being required to submit authorization. So if the issue for why prior authorizations are needed is to control costs, generics are controlling the costs, but we're still having to go through additional steps like Dr. Morey had indicated for generic drugs. And again, I want to emphasize that, care cannot be based on a simple algorithm. You can't put something in and expect a result to come back out. That's why we need the acceptable standards. That's why we're looking at these issues. But again, generics aren't a cost driver. So why are we going through the process? And I will say, if there's a better way to do it, if there's certain generic drugs that for whatever reason, the carriers feel that they still need to be prior auth, then let us know. But if it is a drug that is part of the standard of care for that specialty and it is generic, then why are we requiring a prior authorization and the costs that are incurred by the practices to do it if it's not a leading cost driver?
All right. One last question, Madam Chair, and I've heard this as well, kind of from many of the payers and insurers about the fact that they serve an important role in being a check on providers, making sure that they're following the standard of care and that they're using best practices. And I want to thank the providers for being here, because I know you took time out of your busy day to be here and take yourself away from the clinic or the hospital in order to provide this testimony. Can you respond to that contention? Because I hear that from a lot from the payers who will be coming up subsequently, that they serve that important role of being a check on what providers do. What's your sense of how that affects your practice?
And I'm gonna let the physicians take that one. I think that's more appropriate.
Yeah, I have the American College of Rheumatology guidelines easily accessible as one of the links on my computer while I'm sitting there, just to make sure that there's not been any updates or changes, especially with regards to like COVID vaccination. I was always looking at that because that was always being updated. So I follow the guidelines, and the prior authorization denials that we get don't always follow the guidelines. And when you look at the psoriatic arthritis guidelines, the new GRAPPA guidelines that came out in 2021, the carriers are not following them. And it's very frustrating to try to provide appropriate care for unique patients with serious autoimmune diseases that have all kinds of varying different little quirks to them, and will require different medications based on those quirks and also based on their comorbid conditions, of which they have a lot. So it's a big frustration. The other thing, there's another example. I put in for a prior authorization for a patient, and 2 months later, we're still waiting for the prior authorization to come through. I get a call from a physician in California for a peer-to-peer saying, "Where's that TB test for that drug?" I'm like, that's the standard of care for that drug. If you look on page 6 of our initial prior authorization that we sent in 2 months ago, you will see that TB test that we did and that it's negative. And I don't understand why nobody even read that, because that was a very straightforward prior authorization. I think there were like 7 or 8 pages total that we sent them. And for them to not have even read that very clearly, not even handwritten, that information, and to delay a prior authorization by 2 months is ludicrous to me.
Okay, all right. Thank you, Dr. Murray. Thank you, Madam Chair.
Thank you. Senator Beidle.
Thank you, Madam Chair. I guess I'm going to start and ask this question of Ms. Kaufman, but someone else might need to weigh in. So the prior authorization is required even for generic drugs, right?
Yes.
And so what's the patient doing for their illness or their pain while they're waiting for the prior authorization?
Frankly, they're waiting. And I think that's one of the biggest issues. And that was one of the issues that Dr. Chesley had touched on, that there are times while they're waiting, especially for those chronic conditions, for the prior authorization to be approved, especially on a reauthorization, there was always those concerns that the patient is going to run out of that medication. And some of these medications are of the type that the patients can develop antibodies, and then they can't get back on that medication and they have to start. Or we've heard cases where the patients have had to stretch their doses out so that they don't run out. That is not good for patient care, and that can put them into a situation where it's actually costing the healthcare system more money if they end up with a bad outcome or they end up in the ER. So I don't know if I've answered it completely. I welcome the physicians. Again, I'm only an attorney. I'm not a physician.
But you really know healthcare, so we appreciate it. But the other question, I guess, is, we hear electronic authorization and we think that that's going to be pretty quick, but apparently it's taking a long time to get authorizations. Average time, what do you think? Weeks, days, weeks?
It varies on the drug, but typically the prior authorization done electronically does not work, because you have to end up doing things either by phone or responding back, because you get an automatic rejection because they want to use a different drug. That's not the state of the art. What Dr. Maury was talking about with that patient with Crohn's disease, they wanted to use a medicine used in 2010. We're in 2020. There's top-down and step-up therapy, we call it, for treating inflammatory bowel disease in a stricturing process. I wouldn't expect them to know that because they're not a gastroenterologist, but I would expect them to respect what I'm telling them. But we submitted it all electronically. They had all the data. They rejected the drug, come back and said, "Oh, we'll use that." Well, that drug isn't used for this. Well, that's what it says on my paper here. Well, yeah, I understand it says on your paper. Well, you have to talk with someone. So in this meantime, we're going back and forth. So you talk to someone who first is the person looks at it first, then you get to another reviewer, and then eventually you get to a quote unquote peer-to-peer. Unfortunately, it was like Dr. Moore, the peer-to-peer didn't know anything about this, and I don't fault them for that. They wouldn't expect them to know that. But then finally they realized, oh, okay, and we got it. But the patient suffers
How long
away.
did that take, doctor?
13 weeks.
13 weeks.
13 weeks. The second time it took 5 weeks. It didn't take as long.
I just concerned for the patients who are waiting and in pain. So
We bought medicine don't want to give too much information out about the patient, but the father found out about it and actually paid the money while we waited to get the medicine after the second week because she started deteriorating and we thought she was going to lose her job again and even maybe get depressed behind things. And I worry about the antibody response. That's really something. Once you find a drug that works and then you stop it, sometimes you go back to reinitiate it, you get a flare, you get reaction, and you've got to now find another drug and you're going through that again. So, but in the patient's case, we try to get samples, we try to find something else, and we do a lot of prayer.
Thank you.
I just want to highlight two important points concerning your question. One is that there is no standard portal. So for one insurance company, you'll have to use a certain electronic method of delivering information. For a different insurance company, you have a different portal. For another insurance company, so there are various portals based on the insurance companies that you have to utilize in order to get the authorization. Separately on that, although it says electronic authorization, it's not electronic. We have to print, copy, fax, scan. So there's all of this work in the background that we have to do. So if you combine those two things together, so you have various insurance portals for authorization, and then for each one, you have to copy, fax, print. All of that time and all those resources should be utilized to give and deliver good care to the patient. But unfortunately, we're spending a lot of time doing other things rather than taking care of our patients.
Thank you. We'll go to Senator Mounts, then Guile.
Yeah, and my question is not very complicated. I think it's, my question isn't very complicated. I think I already know the answer, but this bill deals only with pre-authorization for prescription drugs.
So the bill has 4 exemptions for prior authorization, and that's pretty much what I would call reducing the volume. But I also want to be clear that what this bill is also doing is looking at the process as a whole, which is known as utilization review, and making changes to that, which would affect not only prescriptions, but healthcare services. And that is really what we've been talking about when we say acceptable standards of care. But the actual prior authorization exemptions only go to prescriptions.
Yeah, so this bill focuses on prescription drugs,
Yes.
but it could have a.
But it will have hopefully a positive effect on healthcare and the delivery of healthcare services like labs and radiology, because the decisions will be required to be based on acceptable standards of care.
Yeah, thank you.
Thank you. Senator Guile.
Thank you, Madam Chair. I think I'm going to ask what's is probably an obvious question for the providers, but all this work that you're doing in getting the prior authorization request submitted and the back and forth, I'm going to assume that you're not able to bill the health insurer for all that time. Is that correct?
You are correct.
Okay. And so how do you ultimately, I mean, we're talking a lot about costs right now, and I know that the payers are going to get up here and say that this is in the interest of costs, specifically regarding the prescription drugs. Like, so how do you ultimately get compensated for all that time that you're doing, going back and forth and complying with what the insurer requests are?
Mine came in the form of seeing that young lady get gainfully employed and the smile on her face. I mean, it was an amazing feeling. It made me know that, yeah, 40 years of doing this, and it's still a blast to see someone get better because you fought for them. Because I stayed on the phone from 4 p.m. to 7 p.m., 3 hours, because you're going to hold back and forth, this one, you get disconnected, you go back and you get into a queue. I mean, and you can't have your staff. I mean, they got to go home. They got things, they got families too. So you do this and you do it after hours, you do things. I mean, you just have to do what you have to do, because you got to get the care for them, because people will get sick and they'll get in the hospital and they will have bad outcomes.
Mm-hmm.
I mean, I didn't say anything about that, but if physicians were to do this, what they're doing, it'd be malpractice suits.
Mm-hmm.
But that's another issue.
Well, I appreciate what you're doing for your patients. Thank you. Thank you, Madam Chair.
No.
Thank you. I do not see any additional questions from the committee for this panel. So thank you very much for your testimony.
I just want to say, I hope we can get up in electronically to 2023. I think that's part of the problem, that we have fallen behind that. And I do want to thank the doctors and the panel for taking off today. And this Do you get paid for this?
Thank you, Madam Vice Chair. We have 22 additional witnesses on this bill, so we thank you all very much for your testimony. Have a safe afternoon. We're going to now turn to Charles Doring, Louis Tharp, Daniel Dougherty, Josh Howe, Michael Patty, Felicia Brannon. I don't know if I filled up all my chairs. Good afternoon. You can get started as soon as you're ready.
Thank you, Madam Chair, members of the committee. My name is Dan Doherty. I'm here on behalf of the, Maryland State Dental Association and the Maryland Society of Oral and Maxillofacial Surgeons. I think the bill and what it is trying to do has been explained very well. So I'm going to raise a couple of issues only, and they're applicable to dentistry. First of all, our prior approval is for services. Rarely is it for medications. So prescriptions play a much lesser role. And often the prior authorization are for services where the patient needs services now, not 3 weeks from now. And people may ask, well, why is this of a concern to dentistry? Well, in 2018, according to the Maryland Insurance Administration's report on the appeal and grievance law, out of 78,314 of denials, 24,677 were dental, 31.5%, second only to pharmacies. In 2021, that number dropped dramatically in terms of numbers. And the reason is we had COVID. Dental offices were closed mandatorily for a period of time. Then once they reopened, patients that weren't in dire need were afraid to come in. That being said, we still were number 2 in the number of denials. This is obviously a very serious problem to dentistry. We are willing to work with the sponsors, the committee, to get things taken care of. But to this point, we've not been included in those discussions and would ask that dentistry be included. Thank you very much.
Madam Chair, members of the committee, my name is Charles Doring. I'm a general dentist in Rockville, Maryland. I'm the Legislative Affairs Committee Chair for the Maryland State Dental Association, and glad to be here in support of Senate Bill 308. I do a weekly advocacy email to all our members, and we list the bills that are coming up. And this past week, I did Senate Bill 308 and asked for feedback from our members. Boy, did I get swamped. Issues with insurance is our number 1 complaint from our members. I'll be brief and just read one of the many emails I got from our members. The amount of denials are increasing and the rationale for the denials is getting weaker. I have staff members who spend significant time every day responding to insurance denials instead of performing the functions which they are trained. Recently, we've noticed that insurance companies are changing codes different from what was originally submitted and then denying their own edits. When we bring the error to the insurance company's attention, then they deny their own edits. We will bring the error to their attention. Ultimately, they pay, but not after hours on the phone, gathering, submitting information. This year, I had to add a new phone line because we're always on hold with the insurance companies, which was tying up the lines. Any help would be appreciated. So I ask for your support in Senate Bill 308. Thank you.
Madam Chairman, committee members, thank you for the invitation to be here today. My name is Louis Tharp, and I'm commenting on behalf of about 1 million chronically ill patients in Maryland who suffer from a variety of diseases. I'm with the Global Healthy Living Foundation. I currently live in New York. I was born in Baltimore, raised in Towson, and still have family ties here, so it's good to be back. thank you for allowing me to comment today to support Senate Bill 308. This bill puts the patient first by regulating the damaging practices by pharmacy benefit managers and health insurers, which increases their profit at the expense of prompt and appropriate patient care. It took 3 months, 12 weeks for prior approval of a biologic that I take. Yes, I have a chronic illness. My physician staff and I made many calls, completed complicated forms. We're on the phone for hours to CVS Caremark to appeal all of their rejections. We finally prevailed, but my condition remained untreated. And when it comes time to renew that prescription, I could go through the same thing again. Besides difficulty in obtaining initial prescriptions, as we've talked about today, patients can't get timely refills. SB 308 will fix this, and we appreciate it. And importantly, nothing in this bill prohibits insurers from using prior authorization. They can still use it. It does not require insurers to cover any specific medication. It simply seeks to reduce these unnecessary delays. A vote in favor of 308 protects patients and curbs PBM profits. Thank you.
Good afternoon, Madam Chair, members of the committee. My name is Felicia Brannon, and I'm a patient advocate for persons living with rare diseases. I appreciate the opportunity to testify in favor of SB 308. In 2015, I was diagnosed with the incurable rare disease, pulmonary arterial hypertension, and I was told I had a short time to live. However, during this time, basically my lung capacity, I should say, was so low, I had trouble speaking during this time. Treatment for the disease included an oral medicine called tadalafil, which is commonly known as Cialis. However, I had to wait 3 months for my insurance company to improve the drug. So when you ask, what does the patient do while they're waiting for approval? I basically sat at home being tormented while I waited for my insurance company to approve the treatment after I'd been told that I basically had a short time to live. And so every time I got the notice from my insurance provider that my treatment had been denied, of course, my heart sank. It was an emotional burden that I had to carry at the time, which haunts me to this day. SB 308 also touches on allowing a patient to stay on a successful course of treatment without reauthorization. I was also diagnosed in 2015 with myositis and interstitial lung disease. And each year, my IG infusions have to be reauthorized. And so as I was walking into the chambers for this hearing today, I was called by the pharmaceutical company to let me know that my reauthorization was again approved. So it's been 8 years now that I've been treated with the same medicine successfully. So the approval of SB 308 can help with the time lapse that I just shared with you, and also with the reauthorization process annually. So I speak in favor of SB 308. Thank you for your time.
Good afternoon, Madam Chair, Madam Vice Chair, members of the committee. My name is Josh Howe with Compass Advocacy, here on behalf of the National Alliance on Mental Illness Maryland, or NAMI. For all the reasons that you've already heard from this panel and the panel before us, NAMI believes that SB 308 will bring Maryland closer to getting patients the most appropriate treatment at a quicker time interval. And with that, I'll cede the rest of my time back to the committee.
Great. Good afternoon. Michael Patty again in support of Senate Bill 308. We've already heard a lot about what this bill does, and we've heard personal stories. I'm really just here to direct the committee's attention to all the written testimony that we submitted on behalf of a number of clients. And I just want to recognize those clients as the Maryland affiliate of American College of Nurse Midwives, the Licensed Clinical Professional Counselors of Maryland, the Maryland Community Health System, the Maryland Nurses Association, the Maryland Occupational Therapy Association, the National Council on Alcoholism and Drug Dependence, the Maryland chapter, and the Maryland DC Society of Addiction Medicine all support this bill, and we encourage you to review their written testimony. And with that, we ask for a favorable report. Thank you.
Thank you. Any questions for this panel? Thank you very much for your
Thank you, Madam
testimony.
Chair.
All right, we'll bring forward Daniel Shattuck, Thomas Tomset, Krista Frederick, Ellen Weber. Good afternoon. And proceed.
Good afternoon, Madam Chair and Madam Vice Chair. Thank you so much for bringing this important bill forward. My name is Dan Shattuck. I'm here today on on behalf of a number of our healthcare clients, including the Maryland Dermatologic Society, the Maryland chapter of the American Physical Therapy Association, and the Maryland Psychological Association. And I want to keep the support train going. I know you've heard a lot already from the first two panels. This is an important bill. It's an important patient choice bill. I think this bill will cover a lot of the obstacles that are talked about with prior authorization, including prescription drugs, but going beyond that. And you'll hear examples from my colleague on the right about what some of those other obstacles are. It's very timely that this bill is being discussed. As Dana so carefully laid out, this has been a topic before the General Assembly a number of times over the years. And as we move into the future and technological advances, we want to make sure that we keep pace and that anything that is brought forward as a tool to help patients, as a tool to help the providers, reflects ease of transparency, ease of use, and also accountability on the insurers who are making the decisions ultimately. So with that, I will yield time back to the committee, but again, urge your strong support on favorable vote on this bill.
Thank you, Senators. My name is Krista Frederick. I'm a physical therapist and a Montgomery County resident. I am also a private practice owner with 8 locations serving Montgomery, Prince George's, and Columbia, Maryland. And we serve 5,000 Maryland residents every year. I echo my support for this bill. In my 12 years in private practice, I've seen our prior authorizations increase from 7% in 2010 to 75% in 2022 in the physical therapy world. Almost every patient requires prior authorization, and not just for a utilization beyond a reasonable amount of 10 visits that it used to be, but at this point, it can be every 2 to 4 visits that a patient's required to be seen. Almost none of the portals are actually online for physical therapy prior authorization. They're on paper. We must hand copy everything that we write into our medical records onto a piece of paper into 25 different fields, sign them with copies of the electronic medical record, and then fax everything back to the insurance company. More concerning is actually the access to when a denial occurs, it's almost not ever by a physical therapist. It's usually by a nurse, a physician, or another healthcare provider that is not a physical therapist. And we get 48 hours to appeal the decision if the patient, by the time it gets off the fax machine, gets to a provider who may or may not be in the office that day. If we miss that 48-hour window, the patient is no longer allowed to access physical therapy cases or services, and their case is closed. We had a patient this year, a 40-year-old woman who had to have go through a painful procedure of a hysterectomy at 40 years old, which is painful enough in its own, had serious complications, resulting in over 20 plus hours of multiple surgeries to correct the complications from the surgery, intense pelvic pain and incontinence on top of that at 40 years old. After 6 visits from a less specialized, less qualified PT, she transferred to our specialized PT, and she was given 3 visits and then denied further care because the provider was out of the office for 2 days and she missed the appeal window.
And good afternoon, Madam Chair, Madam Vice Chair, and members of the committee. Thomas Tomset on behalf of the Maryland Psychiatric Society and the Washington Psychiatric Society. That represents about 1,500 psychiatrists throughout the state of Maryland. They are in strong support of this bill. They believe it's actually the most important patient access bill before this committee and the General Assembly this year. And I'll tell you why. We finally have made headway into getting access to mental health treatment in this state. You've done a lot of work as a legislative body. The advocates have done a tremendous job. Practitioners have come to the table, as well as patients. And what's going on now is you had the foresight to knock down the barriers to meaningful mental health care in the state over the last few years and through the pandemic. And now we're seeing this artificial barrier of prior authorization really impact mental health treatment. You must understand that in the mental health space, these doctors are solo practitioners for the most part. They don't have the staff resources that other doctors and physicians talked about while sitting at this table. They have to do it all on their own. And when they do it on their own, that's at the disadvantage of their other patients who they should be seeing. And it's at the disadvantage of the doctors themselves and their work-life balance. It's just out of sorts right now. Madam Vice Chair did a great job of telling you what the adverse decisions look like. Over 70% of the adverse decisions are either overturned or modified by the Maryland Insurance Administration. If any other regulated body of this legislature, or if the criminal justice system operated in the same way where 30% were actually right, you would have brought those folks in here and to ask many questions demanding why that system is as flawed as it is. And that's what this bill does. It brings this discussion to the forefront. It allows us to get in line with other states who are taking a serious look at this. And it allows us to tell you the patient's issues. And I have 3 doctors. They're all in virtual. Unfortunately, they couldn't be here today, but please listen to their stories as to how prior authorization impacts their practice and their patients. And I thank you.
Thank you, Madam Chair and Madam Vice Chair, members of the committee. I'm Ellen Weber. I'm the Senior Vice President for Health Initiatives at the Legal Action Center. We convene the Maryland Parity Coalition, whose mission is to expand access to mental health and substance use disorder care and to help enforce the Mental Health Parity and Addiction Equity Act and state parity laws. You've already heard today that a plan's UR criteria make the difference between an individual getting timely access to care or not. And that is very clear and very true for individuals with mental health and substance use disorders. In fact, the Parity Act was enacted to stop health plans from adopting UR criteria that discriminate against these individuals, and SB 308 will advance that effort. So we very much support this bill with some amendments. And we're offering these amendments, which have been attached to the testimony, in order to enforce consumer protections and to reduce the barrier and burden on providers. The First Amendment would reinforce a state standard already. As Dana Kaufman indicated, Maryland already requires the state to adopt and apply the American Society of Addiction Medicine criteria for all substance use disorder services. We want to ensure that the law does not in any way supplant that. Secondly, what we think is very important is there are standardized criteria for mental health conditions, but the state doesn't mandate that. The state SB 308 would help improve that, but we would like to see that there be some amendments to improve both the source and the content of the UR criteria. First, to ensure uniform criteria across all health plans, we propose that the bill should require the carrier to use the criteria that are generally accepted standards of care, and we provide a definition of that. Other states have done the same thing. Secondly, we think that the carriers should be required to use the criteria that have been developed by the nonprofit society for clinical practice in that area. These are the individuals who are the experts on the care, and they have absolutely no financial stake in the application of the criteria to any particular patient. And then finally, we think there should be some guardrails to ensure that the carriers are actually implementing the standards that they say that they are implementing. We think they need to report to the MIA to demonstrate that they do that. And on a patient level, whenever a carrier is going to issue a denial, they would be under this bill required to have a conversation with the practitioner. We think in that conversation, they should be required to demonstrate that the denial actually conforms to the criteria. That's the heart of the decision, that they're going to deny care, but they should support that it is really justified within the criteria. So we thank you for your consideration. We urge a favorable report with these amendments. Thank you very much.
Thank you for your testimony. I don't see any questions for this panel, so thank you very much. Have a good afternoon. We are now going to call forward Deborah Rivkin, Matthew Celentano, Heather Cascone, Marta Harding. They've signed up in opposition to the bill. Good afternoon. Thanks for your patience. It's been a long afternoon. You can proceed when you're ready.
I'll go first. Thank you, Madam Chair, members of the Senate Finance Committee. Today, I am here on Matt Celentano here today on behalf of the League of Life and Health Insurers, the Alliance of Maryland Dental Plans, and AHIP, America's Health Insurance Plans, in respectful opposition to Senate Bill 308 as introduced. First and foremost, we are very much willing to engage in discussions on this bill, which we've actually already started on. And we'll be at the table to work on this through session into the interim if this body desires. There are parts of the prior authorization statute that have not been updated in a significant amount of time. But what in front of you is a extreme jump and a huge change to the operations of healthcare in Maryland. We know that many of you have heard from physicians about this legislation, about how prior auth limits their ability to serve their patients. But from our end, we think it's important for you to hear that prior authorization is fundamentally care coordination. It's a layer of consumer protection that keeps them safe, but also helps control skyrocketing costs. There's an NIH study from a few years ago that surveyed over 2,100 physicians from the American Medical Association master file. And this survey inquired about the extent of overutilization. The survey of physicians by physicians found that the median was 20.1% of overall medical care was unnecessary, including 22% of prescription medications, 25% of tests, and 11% of procedures. That's a significant waste in the system that we need to address. And it's one of the ways that prior authorization helps in the process. Another thing that we heard before is that doctors know the most about some of these procedures and their patients. We don't disagree, but there's not a way for them to keep up with the research that's coming down the pike every day. In 1950, it took 50 years to double medical knowledge. In 2010, it took 3.5 years. In 2020, estimates decreased to just 73 days. That's 627 hours of reading a month to keep up with medical standards. So there's absolutely no way that a physician can keep up with it and see patients. We think this is a bigger discussion. We're going to be at the table and we promise to work on it. But as the bill is introduced, we urge an unfavorable report. Thank you.
Hi, Madam Chair, members of the committee, if you don't mind, I'll go next. Usually everybody can hear me. My name is Debbie Rivkin. For the record, I'm Vice President, Government Affairs for Care First Blue Cross Blue Shield. We are here today, or I am here today in opposition to the bill as drafted, but I'm not opposed to trying to really improve the process. What we heard today happens to patients, and the process needs to change, but it doesn't necessarily need the provisions in the bill. I don't think really creates the right solution. We need to have a less burdensome and difficult process for providers, but we also have to make sure it's balanced. And I see two ways that we can have meaningful reform. I've spoken to the sponsor. I've also spoken on the House side as well, and I've spoken to the proponents about this, and I'm hoping we can move forward. The first is, way I look at this bill, there's two pieces. You've got the appeals and grievance process, which is once a private pre-auth is denied, and it goes through the process at the carrier level, and we have to look at the timeframes in the bill. That's one piece. The other piece is the actual pre-auth itself, and how can we make that more streamlined and appropriate? And I think there's a solution for both. If I can quickly tell you, and I'll be happy to do this more, for the timeframes, I really do believe if we could get the providers who are actually putting in the time for the grievances and the appeals, the medical directors and the staff at the companies that are actually doing the appeals and the grievances, I think we will come up with appropriate times that make sense, because we can go through a claim and figure out what makes sense, as opposed to just saying, let's change it from 30 days down to 15. Second, so that's the first thing I would really suggest. The second thing, as to the pre-auth process, I really would ask that we look at what Virginia just did. Virginia took a year, and I know this is going to take time, so please bear with me about it's not going to be done today. But what Virginia, Madam Chair, do you mind if I continue? Thank you. What they did is they took all the stakeholders, 21 different stakeholders from all different elements of the process. They brought them together and they talked about it in the interim, and they came out with a consensus report. And then they put a bill in this year that it's passing both the House and the Senate. It's just about ready to go to the governor. And what it does is it creates a better electronic process for pre-authorizations. So you take electronic health records and you have an electronic pre-auth system, and you have something called real-time benefit check. What that does is it puts everything together. So at the point when the patient is sitting with the doc, they sit down, they have the medical records right in front of them. What comes onto their screen is what are the patient's benefits based on co-pays, deductibles, and what drugs are being pre-authed, and a list of drugs that are not pre-authed. It also gives you the prices of the drugs. So we really think this will make a big difference. It'll become much more streamlined. It's going to help patients and the providers. Thank you.
Thank you, Madam Chair. Members of the committee, my name is Heather Cascone, and I represent the Pharmaceutical Care Management Association, which represents the nation's pharmacy benefits managers who manage outpatient drugs. We must respectfully oppose Senate Bill 308, which prohibits the use of prior auth when generics are prescribed. And while we have heard a number of concerns from witnesses before me, I'm here to tell a slightly different story, and that's the why prior authorization is used in the first place. We recognize that these concerns that were raised by the sponsor and the witnesses are valid, but they create a carte blanche bypass of the meaningful type of review of medical necessity that's required. And by allowing unrestricted dispensing of generic drugs or an override based on subjective opinion of prescribers. Prior auth can actually protect patients from drugs with a safety risk. They can catch drug disease contraindications. They can catch things like drug dosing errors or contraindications for pregnancy when your endocrinologist may not be aware of the guidelines of your obstetrics specialist. They can catch things like drug age precautions and a variety of other cost-saving precautions that protect patients and plans. For example, in the antidepressant category alone, there are 5 or 6 different types of drugs that are available, all as generics. They range mostly between $5 and $10, except for one. A generic Effexor costs about $135 for a 30-day supply. It's for these types of reasons that we must pay attention to both the clinical safety risks and the costs associated with these types of medications. These are big decisions with big implications, and we really do need to take the time to fully understand and address all of the specific problems that have been raised, but not give a carte blanche okay to prescribers in a time where healthcare costs are steadily on the rise. It's for these reasons we must respectfully oppose and ask to continue to work on the parts of this bill. Thank you.
Thank you, Madam Chair. Good afternoon. Marta Harding. I'm here today on behalf of Cigna and its pharmacy management program, which is a PBM in Maryland. We likewise oppose the bill. We would welcome the opportunity to continue to work on some of the issues that you've heard. But as you've heard from Ms. Cascone and others, prior authorization is a very important tool to make healthcare both safer and more affordable. When it is required for prescription drugs, it is used to protect against adverse drug-on-drug interactions, quantity limitations for patient safety, addiction risk mitigation, and to reduce the cost of expensive medications when an equally lower cost alternative is available. I think it's easy to lose perspective when all we're talking about is where prior auth is required for prescription drugs, which is of course what you've heard today. But for context, it's important to understand that really prior auth is and the exception, not the rule. In pharmacy benefits, close to 85% of commercial insurance enrollees are in plans that limit prior auth to 10% or less. So it is a small percentage of drugs that are subject to prior auth, but it's an important percentage. It's the drugs that really need the additional level of review for the safety and other considerations that you've heard. We oppose the blanket exceptions that the bill would create for prior auth for drugs. One of the exceptions, as Ms. Cascone mentioned, was for dosage changes, and that's one of the areas where prior auth has really made some inroads and helped to get a handle, although we still have an issue in the opioid crisis, because that's one of the things that is being looked at in terms of prior auth. So there are a lot of things we support here in terms of looking at issues for streamlining the process through electronic and other means. While we oppose the blanket exemptions in the bill, we agree that there's a need to take a closer look at our PA law. It's been a while, and we should be better leveraging technology in this space to reduce burdens, but maintain these important purposes that prior auth serves. Thank you.
Thank you. Senator Reedy.
Thank you, Madam Chair. Number one, I may not necessarily agree with everything you're saying, but I respect when you have to come up and after we're all saying, you know, hiss boo, because we're all been upset with some of what's happened with this prior authorization. And I respect you're trying to make the points that where you stand. I'm curious with some of what we're hearing anecdotally is, and we're hearing it a lot from our constituents, is emergency stuff's not moving like it's supposed to. My understanding is aren't emergency medications supposed to be approved within 24 hours?
Mhm.
Is it your testimony that that's, I know you're not under oath, but is it your testimony that that is happening by and large? Or is there something, and if it's not happening, why wouldn't it be happening? I'm just throwing that out there.
Yeah,
Sorry.
and I can only speak to the prescription drug side of this, as
Right.
we only represent on the outpatient drug side, but we find that in many instances, prior authorizations are often denied because they are lacking adequate information requested on the form, even in the electronic form. There are many times where prior authorizations process and stall because we are waiting on more information to be provided by the doctor. And
Okay.
so that creates an unnecessary delay.
Is that true of emergency and others? It's all in it, because even obviously, even for emergency, you need certain pieces of information. Why is it so hard? Are we asking for too much information? Are we?
Yeah, I'll say that in the drug space, every prior authorization is completely different from every other prior authorization, which I acknowledge may be frustrating for prescribers, but it is specifically designed that way. So they are not filling out a form, completely universal, that asks questions that aren't relevant to the patient in front of them. And so when a doctor opens up prior auth software, presumably in their doctor's office with the patient in front of them, the way the system should work is if they're using that system, they can enter in the patient's information, the drug in question, the reason for the prescribing decision, and answer any question in real time at the point of prescribing and get an immediate decision.
But they're not doing, your contention is that they're not doing that, or at least not
Unfortunately,
enough.
some of the previous witnesses, and I think the committee is aware, that the legislature enacted laws years ago that required carriers and PBMs to develop an electronic system
Right.
specific to that carrier's criteria for the drugs that they cover. Unfortunately, there was mandate put on the carrier community. There was no mandate put on prescribers to use it. Unfortunately, we've seen that it's been very underutilized.
So they're using, how are they getting off? They're going with paper, I guess.
Faxes,
or-
paper, yeah, back and forth, which, can cause all kinds of administrative problems on both sides of the equation.
One last question, and I'll conclude, Madam Chair. Doctors are, I'll just conclude that. Maybe I'll talk with you offline. It's fine. Thank you, Madam. Thank you.
Thank you. Senator Hershey.
Thank you, Madam Chair. Matt, I'll just go to you since you spoke first. One of the comments that were made on the physicians panel were that patients are being treated like algorithms. What are your thoughts on that?
I wouldn't agree that patients are treated like algorithms. I would say that doctors want to take care of their patients, and I would say the carriers want to take care of their beneficiaries as well. We have vested interest in making sure that our beneficiaries are taken care of with the best standards. And I think that one of the things that gets lost in this discussion is that prior auth, although one of the tool is used as a tool to control costs, is also to make sure that bad things don't happen to patients. And there are a lot of doctors that we have seen, and we have endless examples of this, that are working on a medical record or not using an electronic system that might not see a drug that has been prescribed by another doctor. And that prescribed medication might be in direct conflict with the other doctor, and prior auth catches it. And you can find out that if you had taken this combination of drugs, it could have been very bad for the health of that beneficiary. So I think it is a little generalized to say we look at them as algorithms. I would disagree with that statement.
Okay, so then let's go back to the process to determine then how these patients are treated. So prior auth does have a personal element to it. If a request is made for a specific drug, there is, again, is it an algorithm? Is it a report? There is something that is linking that patient to
There's always an exceptions policy for every prior authorization. We also have teams of medical experts that are working on this. I would say you can't generalize it, and every patient is different and each process is different. There are different processes for drugs and for medical authorizations. There's also an appeals and grievance process. It's not as simple as just prior auth denied, that's it. It doesn't work like that.
Mhm. But there is an element of the individual patient. When an authorization is requested, something is responding back that had looked at that individual specifically.
Correct. It is not just Chat GP. No.
Yeah, I don't know what that is. It's the second time it's been mentioned today. So Madam Chair, I'm going to figure that one out for you. Oh, you're okay. I'm missing that one, but okay. I mean, I think that's obviously the big concern is that something just isn't working yet.
So Senator Hershey, I think we agree with you. And I think that's why we said we're opposed to the bill as introduced, but we are trying to come out with a product throughout the remaining bit of this session and through the interim to try to address how we move forward to make it better for everyone involved in the chain, that and most importantly, the patient.
What is the opportunity for you to just say throughout the session and not use the word in the interim?
Well, so I would say in states that have had, no, I have not seen something this comprehensive. This is a really large blanket approach. States have taken multiple years to come up with their solution to sort of this problem. I also say, for the benefit of this committee, a lot of you worked on the value-based care bill last year, which is a tiny little blip of how we approach healthcare in Maryland. And that bill was developed with Deb on many calls at 7:30 a.m. every single Friday through the interim to get that little bill. We saw this bill. It wasn't so little. I mean, it's an incredibly important bill that's going to change the way we deliver healthcare, and that's a different discussion. But those kind of conversations happened for 9 or 10 months to get us to the place where we passed a bill. The first time we saw this comprehensive proposal was when Delegate Kerr gave me the LR the day it dropped into the system. That's like less than 2 weeks ago. So it's a little hard for us to react to this monumental shift in how we do healthcare operations in this little amount of time. So I think there are parts that we can get to this year for sure, but fixing the quote unquote problem is probably going to take us more than 55 days. Anybody got the tear off thing in front of them?
Right. Okay. Well, I appreciate your willingness to work with this. And I think, again, as you've seen from the number of questions that were asked on the previous panel, it's important to all of us.
For sure.
To try to.
It's important to us too.
And I realize with you guys as well too. Thank you very much. Thank you all.
Thank you, Senator. We'll go to Senator Ellis.
Yeah, thank you, Madam Chair. And so we're not picking on the guy, but Matthew, you said something earlier when you were talking about the advanced development of knowledge from 1950 to now. And I think you alluded to the fact, correct me if I'm wrong, that insurance companies can handle the change, but doctors out there can't. So as a professional, I mean, they have to go through continuing education. As CP, I go through continuing professional education, and you have your specialty, and you think you do the continuing education, you keep up with the changes. So why do you believe that, you know, the staff people say in insurance companies or whoever can keep up with the changes, but the practitioners out there can't? And so we shouldn't trust them to really know what they're doing. And
Sure.
so the insurance companies or the payers are more well suited to make these decisions. Correct if I'm wrong from that.
So Senator Ellis, thank you for the question and for the ability to clarify. Nobody is saying that we know better than the doctors, but the carriers also have teams of doctors that are constantly reviewing the newest medical evidence. And if you are a small owner operator of a medical practice and you're seeing a lot of patients that need to be seen, that's taking up the majority of your day. We heard from the providers behind us that they have limited time to even do the red tape or bureaucracy that goes along with treating those patients. On top of that, we just don't understand how they're going to find the time to be on top of the latest medical evidence. And the same fashion, if you are a solo practitioner or like that, teams of large health insurance companies with teams of medical directors have the ability to review. That are not seeing patients every day, that are just reviewing the latest medical literature. So I think it's a combination of both.
Yeah, so your point of view is the literature, but I didn't hear the point of view from the patient, which the doctor sees, interviews, and do all the tests on. So,
Well, I would think
it's
that we
like
look at it as a team approach, Senator Ellis, is that the doctor obviously knows the patient best, but there is care coordination at the carrier level. Like I said before, that we care about the beneficiary too, and we want to make sure that the best and the most effective uses are going to be given to that patient.
yeah, okay, thank you. Thank you.
Thank you, Senator, and thank you to this panel. I don't see any additional questions, so have a good afternoon. We have 5 virtual witnesses that we're going to hear from, Madam Vice Chair.
Okay, no, but I just want to say we will continue working on the bill.
Okay.
100%.
Fine, okay. All right, so we're going to hear from Jennifer Palmer. Good afternoon.
Good afternoon. Thank you so much. So my name is Dr. Jennifer Palmer. I'm a private practitioner and I am speaking on behalf of the Maryland Psychiatric Society in favor of Senate Bill 308. So one thing I'd like to talk about is generics. I just got a letter from Express Scripts that after years and years of my patient taking generic fluoxetine, or better known as Prozac, all of a sudden they want a prior authorization, calling it a step 2 or 3 medication. Now, this makes absolutely no sense. Prozac is a household name. It was approved in 1987 by the FDA. It was made a household name in 1993 by listening to Prozac, 1994 by Prozac Nation. It was made generic in 2001. Now in the 2020s, all of a sudden it's not covered. And I've had insurers ask me to substitute a far newer medication, for instance, brand name Trintellix, for generic fluoxetine. No explanation why. So that's just one of the examples of how ridiculous the situation is that needs to be corrected with this bill, specifically about generics. And the idea that insurers and PBMs are checks on providers in a collaborative effort is ridiculous. You are practicing medicine without a license. And then the newest thing that I heard about pregnancy contraindications is another canard that I've started getting those questions in this post-Roe era. And so that's really more of a political thing. Leave the doctoring to the doctors. We get patients' med lists. The pharmacies check medication prescriptions against each other. Stop practicing medicine without a license.
I see no other questions. Thank you very much, Ms. Palmer, for your testimony. And next we'll have Michelle Jamin. Did I say that right?
Yes, that was perfect. Good afternoon. My name is Michelle Jamin. I am a doctor of physical therapy, amputee specialist, and the owner of Align Rehabilitation. I'm here today on behalf of APTA Maryland and the entire limb loss community. Having a limb amputated is just the start to a long journey of learning how to walk again. First, a prosthetist will evaluate the patient to identify the most appropriate prosthetic components based on the patient's function. The patient then has to go to their primary care doctor to obtain a script with those specific recommendations. These documents are then sent to the insurance company for authorization. The whole process can take months. Getting fit early with a prosthetic device is associated with about $25,000 in reduced spending in the first year when compared to those not receiving a prosthesis. Delays in prosthetic delivery can be deadly. There's a high mortality rate associated with those who are not fit with a prosthesis within the first 6 to 12 months post-surgery. While a patient waits for authorization, they are restricted to their wheelchair, and this is a major health concern. Earlier interventions with physical therapy have been shown to improve patient mobility, therefore reduce healthcare utilization due to adverse events. I, for instance, will request a certain number of pre-prosthetic physical therapy visits based on the expected timeline of when a prosthesis will be delivered. When there's a delay in this prosthetic delivery, my patients and I have to make a decision to continue pre-prosthetic PT, hoping visits will be covered for prosthetic gait training, or put the patient on hold and hope there's no decline in function. Healthcare is a complicated system to navigate for any person, but for people living with limb loss, additional barriers to access can make it seem impossible to get the care needed to survive. I ask that you please support Senate Bill 308 to reduce administrative burden and allow patients timely access to care. Thank you.
Thank you. Are there any questions for Ms. Jammon? Seeing none, thank you very much. And have a good afternoon.
Thank you.
And next we have Ryan Lynch.
Yes, hi. My name is Ryan Lynch. I am a physical therapist. I'm testifying in favor of the bill. I have been a physical therapist for 21 years in the state of Maryland. I own a practice in Severna Park and one in Towson. I can undoubtedly say the biggest obstacle to the success of my clinic and my patients is dealing with the insurance companies. Insurance for outpatient physical therapy, the reimbursement is abominably low, and that's not what we're going to talk about today, but it's the hoops that we jump through for things such as pre-authorization to obtain these minimal payments. Maryland is a direct access state for physical therapy, so patients do not need a physician referral. However, most patients do. So ultimately, they come into our clinic with a physician saying, you need physical therapy. I provide a comprehensive evaluation of their systems in an hour, and oftentimes I will say, yes, this patient does need physical therapy. I then have to, in some cases, have to submit to the insurance company to then get these visits approved so that we can conduct physical therapy. The standard of care is typically about 2 months. Most often I am awarded 2 weeks. So ultimately the patient will start physical therapy, get a couple of treatment sessions under their belt and start to make progress. And then at that time we'll have to stop, submit more documentation to the insurance company and hope that they are authorized. To speak to some of my colleagues previously, this process takes about 25 minutes of paperwork. It is daunting, and to speak to Senator Giles' point earlier, this is done, that's something on my time, and that is a sacrifice that I make for my patients. However, the biggest sacrifice is the actual patients themselves, who during this time are not able to receive care. So they get a couple of weeks of therapy, we stop, we wait for the authorization, and this time they're typically regressing a little bit. So then when they resume therapy, we're trying to start and we're trying to make up for this regression and new progress. So it's a 2 steps forward, 1 step back. Thank you for your time.
Thank you very much, Mr. Lynch. And now we have Jennifer Dorr.
Good afternoon, and thank you, Chairperson Griffith and honorable members of the committee. My name is Dr. Jennifer Dorr, and I'm a child and adolescent psychiatrist. I'm here representing the Maryland Psychiatric Society and the Washington Psychiatric Society. I'm asking that you support SB 308, as this is a priority bill to help eliminate barriers currently in place that do not allow patients to receive timely mental health care. As a child and adolescent psychiatrist, I am on the front lines helping youth to battle the current mental health crisis affecting our nation. I am able to make treatment recommendations based on my knowledge of my patients and the expertise and training I have obtained, which is 17 years post-high school studies. As an example, I had a 17-year-old patient who had an inpatient psychiatric hospitalization for suicidal ideation. The patient was started on an additional medication for mood stabilization while inpatient, though there was a prior authorization requirement for outpatient medication. And this patient then went several days without being on this medication due to this, which is incredibly dangerous and unfortunately not an isolated incident. Further, studies have shown that patients are at an almost 12 times increased risk of suicide within the first 3 months following hospitalization. So delaying medication is also life-threatening. It is my professional duty to know contraindications to medications I prescribe and to stay up to date on the literature in my field. Also, I can see other meds my patient is prescribed electronically. I don't need a PBM to tell me that. Further, none have actually ever told me that. I'm sorry, but I don't think it's good enough to say we'll continue to work on this. because the youth mental health crisis is emergent and happening now. There simply is no more time. SB 308 works to help move prior authorization requirements to only those that are necessary. An argument for the PBMs is that requiring prior auths ensures patient safety. Though my question is, wouldn't I, as a child and adolescent psychiatric physician, be the most concerned and diligent about my own patient safety, particularly more so than a physician either approving or denying my requests that may not be in my specialty and has never met my patient? Thank you so much for the opportunity to speak with you, and I ask this committee for a favorable report on SB 308 to eliminate a barrier to timely mental health care treatment.
Okay, thank you very much. Have a nice afternoon.
You too.
Any questions? Okay, thank you very much. Okay, and now we have Larry Green.
Thank you, Chairperson Griffith. My name is Larry Green. I'm a board certified dermatologist in Rockville. I'm here representing the Maryland Dermatology Society and the American Academy of Dermatology Association. I'm here in support of Senate Bill 308. Every day I see how existing utilization law negatively impacts my patients, and I'm sorry if I'm being repetitive. I wasn't privy to hear earlier testimony, but I'm going to respond to what I did hear first real quick. The prior auth, the PBMs mentioned that they help with drug interaction checks, but that takes 2 seconds. Every doctor has apps to do that, and a pharmacist can do that. You don't need prior authorization to check for medication interactions. This is not 1950. And of course, it's a doctor's job to read up on the medical literature. That's our job. In fact, I would estimate we would have an hour and a half a day, and if we didn't have prior auths to do like this that I do every day to read the medical literature. And this form is a typical prior auth. We get three to five of these a day, and we have to scan in the patient's notes. We have to scan them and then fax because our EMR does not integrate with the PBM. So it's a lot of extra work every day. About half of my patients, not 15%, half of my patients have to go through prior auths. And this includes patients who have been stable on a medicine for years. In other words, my patients are using this medicine for years, and every year we have to fill out this form I just showed you and fax all this to the prior PBMs and insurance companies. So that's a lot of extra work, and it's actually medically negligent to do what they're asking us to do, is switch a patient who's stable. They're asking me to switch a patient who's been stable on therapy for years, every single year, to a different therapy. They like us to play Russian roulette with therapies. And this really harms our patients. They go on and off therapy, they cycle on and off, they suffer. Imagine how much healthcare savings we would have without the trees we have to kill, and also with patients who wouldn't have to cycle in and out of our office because they're flaring because they can't get their medications. And then in summary, we would have so much time to see our patients, keep up with the medical literature, so we didn't have the prior auth burden. Thank you very much.
Thank you very much. Does anyone have any questions? Seeing none, thank you very much for your time, and have a nice afternoon or evening at this point.
All right, that concludes the hearing on Senate Bill 308. We'll now turn to Senate Bill 281, Commission on Public Health Establishment. Senator Lamb.
All right. Well, good evening, good afternoon, sorry, members of the committee. Happy to be here as a sponsor of Senate Bill 281. For the record, Clarence Lamb, Senator in District 12. So as the state begins to move out of the COVID emergency, I think it's important to think about what we have learned over the last 3 years when it comes to public health. Our state did many things right, but I'm sure it's also something that we can all agree upon, that our public health system was severely overburdened. I would bet that throughout the last few years, we have all heard from either our local health officers, hospitals, healthcare providers, and constituents about issues faced by our public health system. And although I believe it isn't necessarily valuable to relitigate the decisions that were made during the pandemic, I think it is essential to think through what we can learn from our state's experience to ensure that we are best prepared for future public health challenges, and there will be future instances. Additionally, there are several long-standing public health issues that our state has been struggling to fully address. For example, the U.S. Centers for Disease Control has ranked Maryland 25th in life expectancy, 29th in infant mortality, and 45th in drug overdose deaths. Although each of these issues have complex causes, addressing them are all important core public health goals. And whether it's responding to a pandemic or the ongoing struggle to address longstanding public health issues, there are many challenges that our state's public health system faces and will continue to face. These challenges are related to a variety of issues, including lack of staffing, underfunding, outdated IT systems, inefficiencies in our state and local health departments, and many other issues that this committee has probably heard and is familiar with firsthand as well. This bill seeks to bring together several stakeholders to assess and make recommendations regarding our public health system. The commission will first complete and report on an assessment on the challenges faced by our public health system. Following that assessment, the commission will provide the governor and the General Assembly with recommendations on how to continuously improve our system. I have received feedback from many stakeholders who would like to be included as part of this commission, and I greatly appreciate their interest in this bill. I do think it's important to think through how we set up a commission so that it is not too large that it becomes difficult to complete its work. However, regardless of the final commission membership, I believe it is important that the commission's work include a robust public input process for Marylanders across the state, and I believe the bill does that. The House's Health and Government Operations Committee passed this bill last week with several amendments. Those are in the system. I am still reviewing those House amendments, but intend to provide the committee with similar amendments in coming days. I think they did a lot of work through their subcommittee process to really try to address some of the membership and also timelines when it comes to the bill, and I think that's really important as well. And it also serves as a good starting place for our committee to take a look at this too. Although the emergency posed by COVID is now mostly over, it is important that we take the time to think through what we can learn from the pandemic and how we can use that to build a better public health system. This bill was modeled after similar commissions that have been set up in other states as well, to not only address the post-COVID effects, but also to recognize and acknowledge the need that we have in our public health infrastructure to continue to refine, elevate, and support it. And these other states include Indiana, Ohio, Michigan, Washington, and Oklahoma. And so appreciate the consideration of this bill from the committee and hope to have a favorable report. Happy to answer any questions and then turn it over to folks that are also testifying as well.
Thank you very much. I don't see any questions for the sponsor, so thank you. We'll move forward to some witnesses. Oluwatosin. Okay. Shruti Police. And Joshua Sharfstein. Allison Taylor, Pam Casemeyer, Larry Polsky, Sarah Sample. Good afternoon, everyone. Thank you for your patience. You can get started as soon as you're ready.
Good afternoon, Chair Griffith and members of the Senate Finance Committee. My name is Oluwatosin Olateju. I'm an assistant professor of nursing and a doctor of public health with an extensive background of working in Maryland local health departments. I'm here on behalf of the Maryland Public Health Association, where I serve as the co-chair for the Advocacy Committee. I would like to thank you for this opportunity to testify in support of Senate Bill 281. This bill would establish a commission to make recommendations that would strengthen the delivery of foundational public health services in the state. The state's public health facilities continue to operate in post-COVID-19 pandemic period, while grappling with existing realities in the workforce, such as low salaries, recruitment and hiring challenges, and limited funding for public health programs, which can impact the ability for programs to achieve equitable outcomes. Consequently, it is essential to prioritize having a public health commission in place. Furthermore, it is important to note that the concept of foundational public health capabilities on cross-cutting skills and capacities needed to support essential public health protections have gained new salience. Hence, the need for this commission to provide a comprehensive assessment of the capability of the Maryland Department of Health and local departments in providing core public health services while considering factors such as the state's response to COVID-19 and overdose death, and to racial and ethnic disparities in maternal mortality and birth outcomes in the states. The recommendations that are preferred upon completing this assessment could raise the benchmark of efficient and effective public health program delivery and ultimately improve the quality of residents' health in the state. Therefore, we urge a favorable report for Senate Bill 281. Thank you for your time.
Chair Griffith, Vice Chair Klausmeier, and members of the Senate Finance Committee. Thank you for this opportunity to testify in support of Senate Bill 281. And a special thank you to Senators Lamb and Rosapep for being the lead sponsors of this bill. My name is Shruti Police, and I'm currently a graduate student at the Johns Hopkins Bloomberg School of Public Health, and I'm an intern for Maryland Citizens Health Initiative. I'm presenting this testimony today on behalf of our individual organization, as we have not reviewed this legislation with the entire Maryland Healthcare for All Coalition. Our mission is to ensure that all Marylanders have access to quality and affordable healthcare coverage, and one of our top priorities is health equity. As a student in health policy, I've had the privilege of both learning in the classroom and seeing firsthand how policy can be leveraged to close the critical gaps in health disparities among our vulnerable populations. The creation of this commission would be a significant step towards increasing the scope of care for the people that need it most, as well as calling attention to existing disparities in our communities. It's also critical for consumer voices to be raised up during the commission's process as it works to make recommendations to improve the delivery of foundational public health services. We thank the committee for all of its leadership, which has resulted in over 400,000 Marylanders getting healthcare coverage since the passage of the Affordable Care Act, and in the creation of programs to improve health equity, such as those enabled by the Health Equity Resource Act. Senate Bill 281 will continue Maryland's progress, and as such, we urge the committee to give a favorable report for Senate Bill 281. Thank you.
I think I might have been next on your list, so I will jump in. Thank you so much, Madam Chair, Madam Vice Chair, and Patrick. I didn't say thank you before. Patrick, it's great to see you again. I'm glad to be here. Thanks to Senator Lamb for introducing this legislation. I'm Josh Sharfstein from the Johns Hopkins Bloomberg School of Public Health, testifying not only on my own behalf, it's great to have a student here, fantastic, as well as actually Johns Hopkins University has taken a position in favor of this legislation. You know, one of the things I do at the School of Public Health is teach a class on public health crises. And so I have students write papers about public health crises and what happened after public health crises. And over the course of teaching this 6 times, I probably read 300 papers on this. And one of the questions is, well, do good things come out of crises? Can you learn the lessons of a crisis or not? And the answer to that really depends. There's a huge tendency for people to be disgruntled, unhappy, and blaming people after a crisis. There's a huge tendency to want to just move past a crisis without, you know, and just be happy it's over. That happens a lot. But occasionally you get a situation that makes people realize the importance of getting things right, and you can get people to come together to do a better job. And not all states, but some states, red and blue, Indiana, Ohio, Massachusetts, Washington, Kentucky, have said, you know, this is a moment, having seen how our public health system performed, that we can take a look and see whether it does the core things the public health system needs to do and whether it's designed well. And so this would, you know, pull the best from some of those initiatives and say, let's have an approach in Maryland to learn lessons that can then be applied to keep people healthier and help avoid catastrophe for families here in Maryland. Thanks so much for considering this bill.
Good evening, everyone. Thank you so much for having me. Thank you to the chair and members of the committee. My name is Sarah Sample, and I'm here on behalf of Maryland Association of Counties, and we are here in support of this bill with amendments. And so just to give you a little bit of background, one of my roles at AMACO is to liaise with the health officers. I get to work with Dr. Polsky regularly. And so one thing I am very aware of is that they have an incredibly just acute awareness of what the unique issues are in their communities. Just looking at the variances, there's differences in how they distribute the budget, the number and types of specialists that they have on staff, the scope and the accessibility of certain programs. So they really understand what their communities need in a unique way. And so our recommendations would be consistent with what we believe they'll be recommending today as well, is that instead of having maybe 2 health officers on the commission, we could add a 3rd, and that way we would cover urban jurisdictions, suburban jurisdictions, and also rural ones as well. And that would hopefully assess or give a good look into what some of that variety looks like across the different jurisdictions. Another thing would be to eliminate a few positions so that they're anywhere where there's repetitive interests that are represented. We could eliminate those so that we can streamline the process and hopefully not divert too much focus away from the mission. And then the other thing I think was a really poignant one, which was having someone from the Department of Budget and Management on the commission. And I think that serves 2 purposes, which is to give the commission insight into what is fiscally possible, but then also giving the Department of Budget and Management the ability to expedite the process once the recommendations come out. And I think talking about this from the standpoint of urgency is important because, like you've heard already, the landscape for public health has just rapidly changed. And it's not just COVID, it's things like opioids, it's the mental health issues. There's a lot of different layers of things. And so making these amendments so that we can move this process forward quickly, I think would certainly be prudent. And so we support with amendments this bill. Thank you.
Madam Chair, Madam Vice Chair, members of the committee, my name is Larry Polsky. I'm here on behalf of the Maryland Association of County Health Officers in support of SB 281 as amended by the House of Delegates. These amendments were developed over the course of several HGO subcommittee meetings that involve key public and private organization stakeholders. The amended bill will allow members of the commission to focus on the most critical needs of Maryland's public health infrastructure, best match relevant experts and community members to specific work groups, ensure diversity of input from historically underrepresented demographics across the state, including racial and ethnic minorities and rural regions that struggle with access to care, and create a streamlined work process for the commission that will allow for a more focused and timely report to the legislature. There is a cost in health and lives with each year that we postpone public health improvements. SB 281, with the incorporation of the amendments developed during the House subcommittee meetings, will move us closer to more effective services at both the local and state levels. The state's health officers respectfully request that the Finance Committee adopt the House amendments and vote favorably on this bill. Thank you very much.
Thank you very much. Senator Reedy.
Thank you, Madam Chair. I think looking back and really trying to study everything that happened and our reaction to it is good. And I agree, public health, the need for investment and figuring out where we need to go next in public health is important. Can I ask, and maybe it's Dr. Sharpstein, it's good to see you again, or maybe Dr. Polsky, I believe it would be important for you to have somebody on this commission who is I don't know who it would be because they need to be qualified to comment on these issues, but a critic of, I think you need 1 or 2 critics because I know, I could talk to the sponsor offline. That we absolutely should look at everything that happened. And I was glad to see, I looked to see that communications in here because in the early part of the pandemic, communications was all over the place, which is understandable, but communication was rough. A lot of people there was a lot of bad information out there. And then there was a lot of unwillingness on the part of the health establishment, I'll just call it that, to ever go back and say, you know what, we know we told you this, but we were wrong. This is why we think we should do this now. This is why we believe we should do this now. And I'm not talking about getting into all the ins and outs of every conspiracy theory you've heard. I'm just saying, I think there has to be ownership of hey, these are the mistakes that were made. This is how we could have done better. And this is what we should do to try to, in the future for a similar crisis, this is how we could try to not have those mistakes made. And at the same time, look at the things we did well. I mean, there's a lot of things Maryland did well from a health standpoint. So that's not really a question. Don't you think we should have a 1 or 2 fierce critics of what was happening on the commission and not Senator Reedy?
If I could just respond briefly and say that what you just described is actually the textbook approach to public health communication. What you should do is to acknowledge where things have changed where things have been done wrong, be honest with people. It's really important to do that. In fact, in the book that I put together, there's a chapter even on apologizing, because that's important when necessary. Okay. So I think that the way this is designed is going to bring up a lot of challenges that public health had. It's going to bring up criticism from citizens. It's going to bring up frustration from inside public health about what happened. I think a lot of these things are going to surface, and it's hard for any one person to be, representative of an entire spectrum of criticisms, but I don't think this is going to be successful if all the public meetings are people saying attaboy, to public health. I think there's going to be a lot of that. And I think it's going to be important for the commission to grapple with that. I don't necessarily think it requires a change. I mean, there's flexibility in who can be put on this, but I do think it won't be successful without really grappling with the reasons that we had such challenges during the pandemic.
Say, and obviously this is not just looking at what happened, but how we want to move forward is when we put if we have to make drastic decisions in an emergency, how do we scale down from that? And how do we avoid being captured by fear and scale down from it? And hopefully we won't have anything like this again, or in 100 years, but you never know. So I think that's important, but thank you for your answers, and yeah, thanks.
Thank you. We'll go to Senator Ellis and then Senator Mounts.
Yeah, thank you, Madam Chair, and thank you for your testimony. Ms. Sample, I think you talked about the need to have geographic diversity on this commission, rural, suburban, city. I'm going through the testimony and I can't pinpoint where how we would do that as far as amendment to the bill. Could you did you develop a
Yeah, I think the actual language is already in the amended version. And
Sarah,
it,
do you want me to
You
take
go.
that? Yeah, for the House version, for local health departments, it's designated there will be an urban, a suburban, and a rural district. It will be up to I presume it will be up to the health officers internally to select our representatives to fill each of those divisions.
okay, so well, thank you. Appreciate it. And you said that's in the
In the House amended,
amendment
correct.
version, so that's there. Okay, we'll watch for that. Thank you.
Thank you. Senator Mounts.
And reading this, would you envision this is a new permanent commission, correct? Am I missing something?
No, it's just 2 years.
A 2-year
Yeah.
commission?
Basically till 2 more legislative sessions, next one and the one after that. That would be it.
Do you have any concern about, I mean, I see there's specific areas, but each one of those areas is pretty tremendous, for one body to focus on. I mean, is there any concern about the array? I mean, each one of those topics
Yeah.
seem to be, I mean, you could go down the rabbit hole on any one of them.
Yeah,
know?
if I could just say that this concern came up in the House too. And one of the amendments focuses the bill very clearly on the foundational capabilities in public health, with the various topic areas being examples, not so much. This isn't like chapter 1, everything that happened during COVID, chapter 2, everything that happens on overdose. It's more like the core things that public health has to do with examples from these different challenges that the state has faced. I don't know if that answers your question, but that is following the model of what the other states have done to focus commissions like this.
What other states have done this?
Indiana is probably the one that's done something the closest.
Okay.
And Indiana had a group that generally looks like this group come together, focus on the foundational capabilities, and put together a report to the legislature saying, here's how things could be reorganized to be more effective for the state.
And that's Indiana specific. So this would be Maryland.
This would be
specific.
Maryland specific.
I guess one of my reluctance in that, it's really not a question. You may have a response to it, but is, that public health world is still overwhelmed with information, and how do they participate? And are you creating another mixed message from what they're trying to execute in their current roles. And I don't know if you want to respond to that or not, but it's, there's the government help, there's a government coming to help us again kind of scenario.
Your concern is that it may overburden them even further in part?
Yeah, or put in, or miss something, in a specific area. I know I saw the rural health was supporting this and thinking, and I can understand why, but I just, for some reason, I have a reluctance and.
Yeah, well, Dr. Polsky may want to address that. I mean, and just to say that I think there's a lot of interest in public health because of the potential, but.
Well, part of the work that would happen if this commission does come into being is to look at how we can more efficiently move information and move data across public health and then bridge into the private sector. I know that one of the things that we struggled with was information that was bottled up in our local hospitals, and how do we, as public health, access that efficiently? And so probably a work group that would develop out of this would be specifically looking at information and data and how do we more effectively manage? Do we create systems where you have more intercommunication internally, that where local health departments are on the same system or the same feed as our local hospitals, and to cut out a lot of redundancy that happens at state level as well?
I was trying to avoid this, but I feel like I'm taking everybody down a rabbit hole right now, and I don't want to do that, but thank you very much.
Thank you. And Senator Lamb has a question for the panel.
I just wanted to, I meant to say this during my testimony. Ms. Camp-Pacemeyer intended to be here. She was hoping to be here. She had another professional engagement that took her way, but that MedChi, Maryland Academy of Pediatrics, and also the Maryland Academy of OBGYN do support this bill. She intended to provide oral testimony, but unfortunately couldn't be here. So thank you, Madam Chair.
Thank you for that comment. All righty. I see no further questions for this panel. So thank you very much for your testimony. That will conclude the hearing on Senate Bill. Oh, we do have one virtual witness signed up, but you guys are good to go. Thank you very much. We have Vince McAvoy who signed up to testify in opposition to the bill.
Thank you so much, Chair and Committee. I hope that you can hear me all right. I do see that the state sponsors of SB 281. Can you hear me okay?
We can hear you fine.
So grateful. Thank you. Currently include Senators Rosa Pepose, Augustine, Benson, and Salling. I strongly urge Senators Benson and Salling to remove their sponsorship of this bill. It can easily be understood that they didn't know the breadth of this bill and the awful long-term problems such a bill could have in Maryland. For instance, I appreciate Senator Motz's concern about the proclivity of commission bills to be extended additional years. I point you to House Judiciary's 2013 HB 687, which got an extended a year. This is a huge bill. And all through COVID, there was a movement to use health to usurp constitutional rights, other branches of government, and other, as Senator Reedy brought up this term, I'll borrow it, critics. Very good. Senator Lamb just a week ago expressed his support of child sexuality enforcement, you all call CSE by another acronym, on Senate Bill SB 199. The discussion during the Finance Committee was an ideological affront to parental rights, common decency, including discussion of pedophilia, promotion of average sexual practices, exposing children to concepts and practices they can't purge from memory. Allow me to move on to Chaudhry. Superintendent was pushing these abnormal practices as well as a means of public health. He ignored increases in suicide during COVID because he didn't, even though the children weren't dying from COVID, but they are dying from suicide and depression. So public health was the one destroying Maryland through its increase in child suicide rate, increase in business closures, decrease in working hours, and decrease in support systems. I'm concerned that this bill mentions equity. Healthcare that is anti-white or that continually focuses on one race or the other is not lawful, it's not acceptable. And I've seen endless businesses in Baltimore go under since this. I just want to say this is the wrong approach. And in closing, there are three branches of government. Government's be run by the people, not by woke businesses or their proxies. Further, this bill makes the assumption that Maryland state employees and their officials aren't looking for their agency's efficiency. Committee, many of the issues brought up in this bill fall under the executive committee. This bill, lacking humility, aims to create a mini Department of Health. I am available for questions. Thank you.
Thank you very much. I don't see any questions from the committee, so thank you very much for your testimony. And that now concludes the hearing on Senate Bill 281. Colleagues will turn to our final bill of the day, Senate Bill 398, Health Insurance Reimbursement and Use of Specific Pharmacies and Dispensaries Prohibitions. Senator Lamb.
Thank you, Madam Chair. I'd like to ask members of the sponsor panel to come to Alison Rollins, Dan Shattuck, Dr. Worthing, and Ms. McDonough. Oh, I'm sorry. Yeah. Great. So good afternoon or evening, Chair Griffith, other members of the committee. For the record, Senator Clarence Lamb in District 12. Here to introduce Senate Bill 398, which will allow Marylanders the ability to receive their medications from where we believe their needs are best met. First, as you're skimming through the bill, you'll see the term dispensary in there. And I want to be absolutely clear, we are not talking about cannabis dispensaries. When the term dispensary is used in the bill, it's actually referring to providers or physicians that are able to dispense medications, that have a permit to be able to dispense medications within their clinic. That's what dispensaries mean, not cannabis dispensaries. The majority of health insurances in Maryland contract with pharmacy benefits managers, or PBMs. You may have heard from them. There were some folks in a prior panel that were here representing them as well. These PBMs in turn contract with pharmaceutical manufacturers, distributors, and pharmacies to coordinate which medications are covered or preferred by that specific health insurer. This was a pivotal service starting in the 1950s when most employers established their own health insurance and did not have the knowledge or structure to contract with the thousands of pharmaceutical manufacturers and pharmacies out there. Currently, just 3 large national PBMs arrange for over 80% of medication coverage nationwide. So there are 3 large PBMs that handle coverage for most insurers. Previously, PBMs and insurance carriers limited which pharmacies they could contract with, which in turn limited where Marylanders could obtain their medications. This term was called steering, so to speak, as they would steer the consumer towards a particular pharmacy and restrict that patient from going to their preferred pharmacy. Additionally, pharmacy benefit managers, or PBMs, and carriers rules often limit the ability of providers or other physicians to dispense medications in their offices, which can be important to patient care in certain circumstances. Furthermore, there were concerns that these PBMs had financial interest in specific pharmacies that they chose to contract with, such as mail order pharmacies, and would require patients to obtain medications at those specific pharmacies. In 2019, the General Assembly recognized this inherent conflict of interest and passed HB 759, which prohibited pharmacy benefits managers from requiring that their patients utilize specific pharmacies. And although the bill made significant strides towards improving access to medications, a major gap continues to exist. The language of the bill explicitly excluded specialty pharmaceuticals and mail order pharmacies. Specialty pharmaceuticals are generally defined as drugs that are either greater than $600 a month in cost, are not specifically stocked at retail pharmacies, so you can't just walk into a retail pharmacy and be able to access that medication, or require an unusual process of delivery, such as an infusion, which would have to be done in a clinic or hospital type environment. This carve out has become a barrier to patients with complex or chronic conditions like cancer, rheumatoid arthritis, and multiple sclerosis that require regular infusions. Currently, the pharmacy benefits managers and carriers may choose not to contract with certain specialty pharmacies or infusion centers, thus delaying care and leading to poorer medical outcomes. In addition, the previous bill that was passed 4 years ago also excluded mail order pharmacies. For those that are not familiar, mail order pharmacies are entities that will mail medications to patients rather than having them directly pick them up at a physical brick and mortar store. As one could imagine, not having a physical store to pick up medications could become a barrier to receiving medications if they have a problem with consistent housing, or the ability to be able to be present for package delivery or receipt. Additionally, mail order pharmacies can often not properly manage medications when dosing needs to be frequently changed. If there's something that needs to be titrated, that can be difficult, obviously, for a mail order pharmacy to do. One example, an oncology medication dosing often titrates up and down based on lab results or patient tolerance. Therefore, it's important that patients are able to access medication directly from their provider's offices or through a pharmacy that has significant familiarity with the patient's case. This bill will address the gaps in our current anti-steering law by prohibiting steering related to specialty pharmacies and mail order pharmacies. The majority of other states already regulate steering for specialty medications and mail order pharmacies. Last year, when this legislation was introduced on this topic by Senator Feldman, the PBMs and carriers expressed concern about increased prescription drug costs. That is why this year we have added language allowing carriers to require pharmacies or dispensing providers to accept the terms of a carrier's prescription drug contract. This will allow a carrier to require a pharmacy or provider to accept the carrier negotiated rate as a condition of reimbursement. We believe this is a very reasonable provision. This bill is not about requiring carriers to reimburse any willing provider, but is about ensuring that a patient can receive care from the provider of their choice as long as that provider is willing to follow the rules of the patient's insurance company. There's also an amendment to clarify the definition of dispensary in the bill. Again, I'm not talking about cannabis dispensaries, but there's a clarifying amendment in that bill. I want to thank you for your time. I would ask the committee for a favorable report and happy to turn over to other members of the panel and then take questions afterwards. Thank you.
Good evening, Madam Chair and members of the committee. Kaylee and I are on the same team now. I'm Caitlin McDonough on behalf of here in support of Senate Bill 398, representing the Maryland Oncology and Hematology and the U.S. Oncology Network and 19 other members of the Anti-Steering Coalition here in Maryland. And just to name a few very quickly, the Alliance for Patient Access, the Chronic Disease Coalition, the Allergy and Asthma Network, the Cystic Fibrosis Research Institute. You're seeing a pattern, chronic patient advocacy groups. As Senator Lamb has stated, and thanked him for championing this bill, Senate Bill 398 is about closing gaps in Maryland's current anti-steering statute. While Maryland does align with 17 other states in codifying patient protections from steering practices, it is the only state that has these broad exemptions for specialty and mail order drugs, which, again, as we've seen, is impacting over about approximately 80% of medications which go through these PBMs. I did want to, Senator Lamb kind of stole my thunder here, but I did just want to go over some of the changes from last year. So as the bill came in last year, it really just addressed that PBM piece, pulling these exemptions out of the current anti-steering law. The amendment or the changes from last year do two things. One, make both the PBM and the carrier side more consistent so that, we don't have steering policies on either side, but it does clarify the parameters that a carrier will be able to put in place to control costs, to ensure that providers are up to the task of dispensing specialty drugs, and to be able to implement their care coordination efforts, which I know you heard a lot about on some of the previous bills. The fiscal note summarizes the bill really well. It says exactly what a carrier or PBM would be able and what they would not be able to do under the bill. And I think the rest of the panel is going to give some more real life examples of how our patients are impacted and providers are impacted by the current gaps in the law. With that, I'd urge a favorable report and pass it down to the rest of the panel.
Thank you, Caitlin. Good afternoon, Madam Chair and members of the committee. My name is Allison Rollins, and I'm Senior Manager for Government Relations at the U.S. Oncology Network. I'm here in support of Maryland Oncology Hematology, but I'm speaking on behalf of the Maryland Anti-Steering Coalition. I should probably also disclose that I'm a patient with Crohn's disease who is receiving active treatment in the physician office setting from Dr. Worthing's practice. But today I'm here to discuss with you how Maryland's current law stands up to independent research and other state standard practice. So at the end of last year, there were 18 states that had passed targeted laws and codified protections for patients from these mandatory pharmacy steering policies. Of the current laws, there are only 4 states, though, that put forward any form of exemption for anti-steering statutes with specialty medications. That's Colorado, Georgia, Maryland, and Oregon. Now, Georgia will only allow specialty steering if the medication cannot safely be administered in a physician office setting, and they have very special particular rules around oncology. Colorado will only allow steering for hazardous drugs if the patient needs access to inpatient care because of potential adverse reaction. And Oregon similarly lists types of facilities where specialty drug steering is not allowed. The commonalities in these three permissive states is that the focus remains on the welfare of the patient and is not tied to the health insurer or PBM business practices. But that is not the case here in Maryland. Our current law exempts mail order and specialty medications from patient steering protections without any form of nuance. As written, it incentivizes a business practice that dozens of other states are banning by law and by regulation for being anti-competitive, overly restrictive, and wasteful. As cited in our written testimony, research shows that as many as 84% of patients oppose pharmacy steering practices. A 2022 study in the Journal of Oncology Practice has revealed that mandatory mail order practices for specifically anti-cancer drugs have accounted for roughly 4 times the waste associated costs that a medically integrated dispensary has experienced. And if the patient is allowed to receive their medications in the office setting, the overall waste associated cost goes down by $1.7 million per site of service that is in this practice. Evidence is abundantly clear that patient frustration and potential harm in mandatory steering policies can be mitigated through a form of care coordination that would preserve the physician-patient relationship and would allow for patient choice. And that's why we support SB 398. Its language would remove barriers to patient protections while at the same time allowing for more collaborative approaches to care coordination with the welfare and autonomy of a patient at its center.
Madam Chair and members of the committee, thanks for saving the best for last, and thanks for your attention tonight. My name's Angus Worthing. I'm a doctor and a rheumatologist at Arthritis and Rheumatism Associates. My 28 colleagues and I take care of about 30,000 people, mostly in Maryland, every year. And we're here to strongly support this bill, mainly because it helps prevent some of the worst experiences that my patients tell me about, the barriers to getting their medications. Patients have told me numerous times about deleterious ways that they're kept from getting their medications through mail order and specialty pharmacies, extensive time talking on the phone and playing phone tag with the pharmacy, and concerns about mail order packages of expensive cold chain syringes being left on insecure doorsteps at inappropriate temperatures during the day. One patient recently told me that the only way that she could avoid the mail order was to go to a specific chain store that had very long, inappropriate lines at the end of her workday. That caused a delay in her getting her medication, which caused painful disease flares. Patients with rheumatoid arthritis and other autoimmune diseases pay for these delays with unnecessary pain and disability. They take stopgap and potentially threatening steroid medications as anti-inflammatories, which can cause broken bones, serious infections, and diabetes, which can put them in the hospital. So after finally receiving their mail order medications, there's an additional delay in for syringes, somebody's first dose, they need to receive an injection teaching, usually in person. So this bill will help us help our patients by streamlining their care so we can provide medication and the injection teaching education and handling of the medication at a convenient place from a trusted source, i.e. the doctor's office or their independent local pharmacy. And we can authorize and dispense new change doses when we identify disease flares at the point of care. It's only in Maryland that these life-changing specialty medications, the only kinds of drugs that Marylanders are steered to mail order pharmacies is these life-changing specialty medications. And I would ask you to please close this loophole so that Marylanders can get their medications at the pharmacy of their choice. Thanks.
Good evening, Madam Chair, members of the committee. My name is Dan Shattuck. I'm here today on behalf of Dr. Worthing and his practice. I just want to reiterate, I think the important takeaway for this bill is patient choice. I think what we've heard and what Dr. Worthing's experienced with his patients is that there is a comfort level with patients having that relationship with their physician or their trusted local pharmacy to get the medications that they need the way that they need them without burden or hassle. In this changing healthcare world. We've seen a lot of consolidation in the health insurance market. We've seen a lot of consolidation in the healthcare provider market. But with that consolidation comes a lot of change, and patients might be bounced around, for lack of a better term, between different pharmacies, depending on the arrangement that might exist between their carrier, the PBM, and the various pharmacies at that time. And if it's a decision of having to get your medication because you need it without delay, then let's close the loophole and make sure that the patient can go to their physician or go to their local pharmacy and get the medication that they need, when they need it, how they need it. So I think that's what we're trying to do with this bill. I think, as Caitlin laid out, there's some changes from the bill that you saw last year, and we're trying to open the door to allow the physicians, the prescribers, and the pharmacies to come into the networks. We want there to be an ability, if they want to play by the rules, if they agree to the rates, if they agree to the rules that the carriers and PBMs offer to be a network, then that should happen. So I think that's what we're trying to achieve. I greatly appreciate your time and attention at this late hour. I think we're happy to answer questions, and thank you very much.
Good evening, honorable members of the Senate Finance Committee. For the record, Kaylee Locklear here on behalf of the Maryland Association of Chain Drug Stores. Nearly 90% of Americans live within 5 miles of a pharmacy that they often visit regularly and rely on for dispensing needed medications such as specialty drugs. They also provide essential healthcare services like health screenings, disease state management, vaccinations, testing, and treatment services. However, a patient's access to care is undermined when a pharmacy benefit manager requires patients to use specific or affiliate pharmacy or an affiliated pharmacy of another PBM. For example, in the current environment, some PBM plans impose penalties like higher copays or other financial disincentives if a patient chooses to have their medication dispensed at their local retail pharmacy instead of a PBM affiliated pharmacy or a mail order pharmacy, which is conveniently often owned by the PBM. These imposed restrictions often disrupt patient care, decrease patient adherence to life-saving medications, and limit patient ability to connect with their pharmacist in person for questions and concerns. Healthcare should be patient-driven and allow for pharmacy choice. We sincerely appreciate the sponsor, the committee's time, and we urge a favorable report. Thank you.
Thank you very much. I do not see any questions for this panel. So thank you to the sponsor and the panel. Enjoy the rest of your day. We're going to turn to our next panel with Deb Rifkin, Allison Taylor, Matthew Celentano, Heather Cascone, Marta Harding. They have signed up in opposition to the bill. Thank you all for your patience, and you can begin whenever you're ready.
Guess I got the short straw again. Madam Chair, members of the Senate Finance Committee, once again, I'm Matt Celentano here today on behalf of the League of Life and Health Insurers and AHIP in opposition to Senate Bill 398. We're actually having a hard time figuring out why we need this bill in the first place. It seems to create more problems and certainly would result in higher drug costs for consumers. The bill contains any willing pharmacy language. Maryland has rejected any willing provider language repeatedly over the last 20 years for pretty clear policy reasons. It's well documented to be anti-competitive and it drives up healthcare costs. Having no real clear benefit for consumers when adequacy rules are in place to ensure access to pharmacy services. The bill also dismantles specialty pharmacy as we know it, which the General Assembly struggled with for a while and made a decision to try to have care coordination services. One of the proponents actually has a specialty pharmacy on their site, and it would be a matter of walking down the hall to get the drugs. We're unclear why this new designation is needed, and by removing specialty designation, we're opening up a new can of worms. It's unclear if the physician would be able to have all the specialty drugs in stock. They require special handling, training, et cetera. And would they only prescribe the drugs they have at that time? Would they have the full formulary for their patient for each different insurance carrier? These are questions we don't have answers to that are certainly important. Specialty pharmacies improve healthcare affordability while protecting patient safety. Those specialty pharmacies prevent hospitals and physicians from charging exorbitant fees to buy and store specialty medications themselves. Secure direct delivery that the vast majority of patients got used to during the pandemic, especially, is way more efficient and effective. It reduces costs. Based on CMS data on payments in Medicare and Medicaid, the average physician office markup where we've allowed dispensing across the country has allowed a dispensing markup of over $1,000 on each cancer drug and over $4,000 on MS drugs. In hospital setting, it's even more, it's exponentially more. These are just a few examples. Carriers work every day and are struggling to manage skyrocketing prescription drug costs, and this bill just makes that challenge more pressing. We urge an unfavorable report.
Madam Chair, I'll go next. Madam Chair, members of the committee, Debbie Rivkin, Vice President Government Affairs for Care First Blue Cross Blue Shield, opposing this bill, Senate Bill 398. And the reason is that this bill removes the ability of a carrier to use exclusive specialty networks, which have been specifically allowed in the law. You actually enacted a statute a number of years ago to allow that to happen, and I'll try to explain why. I want to try to put specialty drugs and specialty pharmacy into perspective from the carrier's point of view. You'll hear from the PBMs later. The total drug spend for Care First is 34% of our healthcare dollar. That's the largest part of our spend. It's more than what we pay for specialty care, hospital care, and outpatient facility care, and it's increasing year over year. In 2021, we spent over $2.8 billion on drugs. And the interesting thing is 3.8% of all of our members are on a specialty drug. That's a really small amount of members, but that small percentage accounts for 54% of the total drug spend. So what do? We want to focus on that population and get their care under control and get them managed. So what has happened is we have exclusive specialty pharmacies, which go beyond just dispensing. What they do is they focus on wraparound supports for the patient. And what we're seeing, because of our exclusive specialty pharmacies, which have additional credentialing requirements, they have on-site medical physicians, nurse practitioners that will do 24/7 conversations with our members, is that we're seeing increased adherence to their drugs. And when you have increased adherence, you've got better outcomes overall. This bill blows that up, and we would ask that it receive an unfavorable report. Done.
Thank you. On the money.
I went over last time, I cried.
Good evening, everyone. Heather Cascone again on behalf of the nation's pharmacy benefit managers, or PBMs. Senate Bill 398 would mandate that specialty drugs be obtained by patients at any pharmacy or dispensary, such as a doctor's office. Specialty drugs were recognized by the Maryland legislature years ago as being medications that are complex, or they treat complex conditions, or at an extremely high cost. Deb mentioned it a moment ago, but nationally, specialty drugs represent just 2% of prescriptions, but account for 51% of total planned drug spending. This is an exponentially growing number every year. Given these significant and growing cost pressures, plans must use every tool available to them to build affordable products for enrollees. When an employer or plan decides to contract with a PBM, they still retain authority over the plan's design, which includes who they include in their network of pharmacies. And they often choose specialty pharmacies exclusively to assure high quality services. Specialty pharmacies acquire specialty pharmacy accreditation, just as a hospital provider would, to guarantee improved patient care. But they use this as a baseline requirement for inclusion in the PBM preferred specialty network. They all have additional requirements to ensure even higher levels of clinical care and logistical support for patients. Specialty pharmacies were established essentially in direct response to a need for a better way to procure, store, and dispense specialty drugs. We specialize in the unique storage and shipping requirements, everything from oral to injectable to infusible products. But because these drugs are sometimes the only treatment of an illness that historically had few treatment options, they are not stocked at the majority of retail stores. And while doctors have dispensed these products in the past, industry has evolved away from a much more costly physician buy and bill system where there were no cost control mechanisms. This bill would revert the evolution of this system backward, all at the cost of patients and payers to the benefit of profits. We appreciate the time and consideration of our concerns, and I'm happy to take any questions after.
Thank you, Madam Chair. Marta Harding. Again, on behalf of Cigna Pharmacy Management Program, which is a PBM. Specialty pharmacy supports patients that have chronic, rare, or complex diseases. Specialty pharmacy is an integral part of coordinated disease management programs that are administered through these networks. These programs are well documented to improve patient health outcomes year after year, and they outperform outcomes for patients with the same disease who are not in these programs. These programs lower medical costs, they lower inpatient costs specifically, they result in higher adherence and higher patient management. Cigna's specialty pharmacy program has well documented better outcomes for a variety of conditions, rare conditions, high cholesterol, diabetes, migraine, asthma, COPD, multiple sclerosis, and inflammatory conditions. Senate Bill 398 would really pull the rug out from under these programs and the benefits that they have achieved for Maryland. You've heard about the history. Any willing pharmacy laws have been consistently rejected in their various forms by Maryland over the last 20 years. There are adequacy rules in place in Maryland that the Insurance Administration enforces to make sure that everybody has adequate access to pharmacy services. So that is an important component as well. Lastly, I'll just say that I think it's important to distinguish PBMs, and I think Ms. Cascone touched on this a little, are not the ones that are making the decision whether to have a restricted network or a specialty network versus open access. It's the plans, it's the carriers that are making that decision as they try to manage the benefit that they're providing to their enrollees in a way to ensure affordability and quality to those members. And this bill would take away their choice to make those decisions. So for those reasons, we would also, and the ones you've already heard, we would ask for an unfavorable report. Thank you.
Thank you, Senator Lamb.
Thank you, Madam Chair, and thank you to the panel. I'm hearing from multiple members of the panel this whole concept of any willing pharmacy, but I want to be clear in the legislation that the carrier can still require the pharmacy to play by the carrier's rules. That's what the bill states, right? And so it's not any willing carrier, it's not any willing pharmacy, rather. The pharmacy still has to abide by the rules that were set up, that the carrier had set up for other folks that were willing to.
So
Ms.
with all
Rifkin,
due
can you comment?
respect, I would tell you that I think it's already in the bill and that therefore this bill isn't necessary. If you go, and if you don't mind, I will tell you that this was put into the bill when we originally passed the original law that allowed for exclusive specialty pharmacies in the state of Maryland. And that is if you look at lines 8 through 12 on page 2, you'll see right now, or actually, I guess it really starts up at line 5. It says designated pharmacy. I'm sorry, 8. A pharmacy participating in the entity's provider network. If the entity determines that the pharmacy meets the entity's performance standards and reimbursement rates. Today, we have 5 pharmacies that have asked to be in our network that are in our exclusive specialty pharmacy. So exclusive doesn't mean one. Exclusive means that they have met the standards that we have put into place that are, like I told you, of higher accreditation standards than a traditional pharmacy, and also have to meet those wraparound services that we are asking for our members to make sure there's 24-hour hotlines. There are nurse practitioners that will check on people that are really making sure that they understand what's happening with their meds. And we have been able to accept them because of the law as it is drafted today. So we believe that there is that opportunity for them to apply and get into our network.
You cite this care coordination and all these wraparound services, and I'm trying to understand and see a gap here as to why the pharmacies can't provide you're saying that they provide a 24-hour line, they provide advice. Isn't that what the pharmacist would do anyway if a pharmacy was willing to adhere to your rates and could participate in this program?
You can imagine, and you may have a better answer, but it completely bifurcates, it blows up the system. When you have a small group that you can coordinate and they know what information you need, you get your systems put together. We know immediately when a drug is going to them, as opposed to out into the pharmacy, somebody just shows up, they get their prescription. It creates barriers for us being able to coordinate better because we don't have everybody on the same system, because you can go to anybody that supposedly meets the standards. I mean, that's the way this bill's drafted. If it meets the standards, you're in. And I don't know how we're supposed to really manage that type of network. By keeping it coordinated, we really have the ability to have all the systems in place that we do today, as opposed to any pharmacy or any provider, which aren't pharmacists, by the way. I mean, it's kind of odd. I think under today's law, providers, and you can, hope I'm saying this right, Senator Lamb, can dispense, but they can't do refills, correct? And so if you want to do that, you're supposed to be a pharmacy and have a pharmacy license. And therefore, if you do that, you could become part of our specialty pharmacy.
May I add just a little bit of color to your question, to Deb's response? I will note that many drug manufacturers, in fact, choose PBM owned and operated specialty pharmacies as the exclusive provider of their drug product. And that is because of the specialized training that is available for the specialist pharmacists that work in those pharmacies. So much like the practice of medicine has evolved over time from a generalist basis to a specialist basis, many specialty pharmacies have now evolved to specialize in oncology treatments. So those pharmacists are dealing solely with oncology patients on a daily basis and fully understand all of the risks that come along with the medications that are prescribed. Likewise, there is a level of accreditation that is required by specialty pharmacies to participate in a plan's network. There are 64,000 pharmacies nationally. 378 of them have achieved accreditation. This level of accreditation ensures that patients are being counseled appropriately, that adherence and persistent checks are being made, that nursing care is available to patients on site in their home when it is needed, that all of the quote wraparound services that could include for an infusible drug, not just the drug medication, but also the delivery pump and also the tubing and the alcohol wipes and the batteries and extra batteries for should that infusion pump fail. So all of that care coordination is a service that's provided as part of accreditation standard and also happens automatically at the PBM owned specialty pharmacy. So I hope that helps answer your question as to sort of some of the additional services that are being offered to patients.
I think you touch on some of the concerns that many of the other stakeholders have, which is that you're talking about PBM owned pharmacies, which is really kind of self-referral and steering it back to these folks. And so I'm happy to continue the conversation offline. I know it's late, but I do have concerns when PBMs can steer folks to a pharmacy that they themselves own, and still fail to see that gap if there are pharmacies that want to adhere to the rules that the payers have stipulated for this and PBMs have stipulated, why they can't simply participate in this program, including with care coordination that's required. So
Sure.
Thank you, Madam Chair.
May I respond just briefly to that?
Okay,
I'll
the
be brief.
senator wants a response, but please.
Thank you, Senator. I'll just note that Marta said earlier, PBM owned pharmacies are just that, but plan sponsors are designing which pharmacies should exist in their specialty networks. And it's often the case that beyond the PBM owned specialty pharmacy, other pharmacies participate. I know this to be true here in Maryland, in Baltimore. This is very well documented that many retail settings participate in the networks of the plan's design. And it is to the patient's benefit that they've reached that level of care and clinical standard to be able to open up the services. And the health plans recognize that and include them as a result.
Thank you. Vice Chair has a question.
Yes. How many specialty pharmacies are in Maryland? Do you know?
Physically located in Maryland? I don't know the answer to that question, Senator. I'll have to get back to you. I'm not aware that there is one. But specialty pharmacies are not like your average brick and mortar store. You wouldn't walk up to it with a paper prescription. You would have your doctor coordinate with the specialty pharmacy directly and issue the prescription either electronically or over the phone. And at that time, the customer care team at the specialty pharmacy, wherever it may be located, would coordinate both with the physician for dosing and administration requirements and the patient for delivery and scheduling and making sure that they have all of the counseling and supplies needed for that
So
prescription.
it is more of a mail order.
Correct.
And someone said
Correct.
something about the prescription was thrown out in the heat or something like that. Do they take care of that so that doesn't spoil?
Yes, so prescription drugs that are dispensed through specialty pharmacies are always coordinated with the patient so that communication is made to arrange for delivery, particularly since many of the medications have special handling requirements. They have temperature, they have to maintain a certain temperature to be effective. They have, all those kinds of
That's good. Okay.
specificities.
Thank you.
Sure.
Thank you. I don't see any additional questions for this panel, so thank you very much for your testimony.
Thank you.
And for hanging out with finance this afternoon. We do have one virtual witness. Kashif, I'll let you say your last name. Thank you so much for waiting to testify. Good afternoon.
Thank you, Madam Chairman. My name is Kashif Rosby. I'm a medical oncologist at Maryland Oncology Hematology and the director of the White Oak Cancer Center in Silver Spring. My practice has over 70 providers seeing over 120,000 patient visits a year across 14 offices with over 50 nurses, 15 pharmacy techs, 3 full-time clinical pharmacists. And we are committed to helping care for the 7,000 new cancer patients a year that we see, with a singular focus of providing compassionate, competent care close to home to make life easier for our patients and their caregivers. It is for all these reasons and many more that we strongly support this bill, which will afford patients better choice and empower them to better manage their own care. Every day, I deal with the hardships tied to trying to make sure that our patients get their drugs from specialty pharmacies. We have zero access to patient records, recent labs, medical conditions, and oftentimes no access to the patient themselves. They work through us to get access to the patient. So what you've heard a lot today is not completely accurate. We are often giving a cocktail of drugs that include both IV and oral formulations given together. To achieve the best outcome, we need to give the regimen as it is supposed to be delivered on the appropriate days. While we can control the IV drugs, which are in our possession, we have to rely on specialty pharmacies to mail order the oral drug to the patient, assuming that they are able to reach the patient, which is not always the case. It is a common occurrence that we have to delay scheduling a patient or provide treatment with only half of the regimen in place because the drugs have not made their way to the patient. This happens a lot, and it is not acceptable. And for anyone to say that it's not happening is simply false. These drugs have side effects and are all the more toxic in our cancer patients. Patients are often mailed outdated drugs that are either the wrong dose or no longer the right treatment because of patient toxicity or progression of disease. Frequently, after reviewing a scan and informing the patient that we need to make changes in their treatment, they then pull out a new bottle. They then pull out a new bottle of a drug that costs $10,000 a month and ask me, what should I do with these drugs? Just recently, I apologize, I'll just try to keep this quick.
Yeah, please.
Just recently, I saw a patient who came to me with this is just this past week, stage 4 prostate cancer, who's been trying for almost 3 months unsuccessfully to get his drug delivered from a specialty pharmacy. He is from Ethiopia, doesn't speak the language, has a lot of psychosocial needs that are preventing him from being able to coordinate the drug delivery. Yet he comes to my office every month for his IV Zometa, and each time he asks, why can't I just pick up the drug here? And each time I say, because you're basically being told you're not allowed to. Patients dealing with a life-threatening condition like cancer need personalized approach to obtaining their drugs, not a one-size-fits-all model. Sometimes a mail-order pharmacy may be best, and sometimes a patient may prefer getting their drugs from their doctor's office. Not every patient is the same. Patients with life-threatening diseases should be given more accommodations and more choices, not less. We should all trust that patients are knowledgeable enough to choose where to go to get their medications, and that more choices will raise the bar for everyone. We must ask ourselves why we allow patient choice for less critical medicines, but not for life-saving ones. Thank you.
Thank you. Thank you very much. I don't see any questions for you, so thank you for your testimony. And that will conclude the hearing for the day. Thank you all very much. To the members, thank you all very much for your attention to the bills this afternoon. I just wanted to let you all know, we actually have 130 witnesses signed up tomorrow. So have a nice breakfast, lunch. We had 105 today, so we have 130 tomorrow. So, and we're voting tomorrow after the bill hearings. So